10 to form activator. The activator factor combines immediately with tissue phospholipids that are part of a the tissue factors or with additional phospholipids released from platelet as well as from factor 5 to form a complex called as prothrombin activator. Within a few seconds, in presence of calcium, prothrombin is split into the thrombin. At first, the factor 5 in the prothrombin activator complex is inactive, but once clotting factor and thrombin begins to form, the proteolytic action of a thrombin activates factor 5. The activation then becomes an additional strong accelerator of prothrombin activation. Thus, the final prothrombin activator complex, activated factor 10, is an actual protease that causes splitting of prothrombin to thrombin. So, the finally prothrombin activator complex, which activates the factor 10, is an actual protease that causes splitting of prothrombin to thrombin. Now coming to the intrinsic pathway. The second mechanism for initiating the formation of prothrombin activator. Initiating of a clotting begins with a trauma to the blood vessel or exposure of a blood to collagen from traumatized blood vessel. Blood trauma causes activation of factor 12, release of platelet phospholipids. The trauma to the blood vessel or exposure of a blood to vascular wall, collagen alters two important clotting factors in the blood, that is factor 12 and the platelets. When factor 12 is disturbed, such as by coming into contact with collagen or with the wettable surface such as glass, a new molecular configuration that converts into proteolytic enzyme called as activated factor. Simultaneously, the blood trauma is also damages because adherence to collagen or to a wettable surface or by a damage to other ways. These release platelets phospholipids that contain a lipoprotein called platelet factor 3, which also plays a role in a subsequent clotting reactions. Activation of factor 11, the activated factor 12 acts enzymatically on factor 11 to activate this factor, which is the second step in the intrinsic pathway. The reaction also requires high molecular weight kininogen and is accelerated by precalcarein. Activation of a factor 9 by activated factor 11, the activated factor 11 then enzymatically on a factor 9 to activate this factor as well. Activation of factor 10, the activated factor 9 acting on the on concert with activated factor 8 and the platelet phospholipids and factor 3 forms the traumatized platelets, activates the factor 10. So factor 8 is a factor that is missing in a person who has classic hemophilia. So it is called as anti-hemophilic factor. Platelets are the clotting factor that is lacking in a bleeding diseases called as thrombocytopenia. Action of activated factor 10 to the prothrombin activator. This step in intrinsic pathway is same as that of last step in the extrinsic pathway. Thus, activated factor 10 combines with factor 5 and platelets or tissue phospholipids to form the complex that is called as prothrombin activator. The prothrombin activator in turn initiates the cleavage of prothrombin to form a thrombin within seconds, thereby setting into the motion for a final clotting process. Though this factor is very, very, very important. So you can see the intrinsic pathway for initiating blood clotting. This is a flow diagram which shows the intrinsic path. The overview of a coagulation cascade, you can see intrinsic pathway, extrinsic pathway, a common pathway, and the ultimate goal is conversion of fibrinogen to fibrin and a stable fibrin plot. It is clear from the these schematic diagrams that intrinsic and extrinsic system that after blood vessel rupture. So think blood vessel rupture is there. Clotting occurs by both the pathways simultaneously. Tissue factors initiates the extrinsic mechanism, while the contact of factor 12 and platelets with collagen in the vascular wall initiate the intrinsic pathway. So both the pathways are stimulated simultaneously. Very especially important difference between the extrinsic and intrinsic pathway is that the extrinsic pathway can be explosive. Once initiated, its speeds of completion to the final clot is limited only by amount of tissue factor release and traumatized tissue and by the quantities of a factor 10, 7 and 5 in the blood. With severe tissue trauma, clotting can occur in as little as 15 seconds, and the intrinsic pathway is much slower to proceed, usually requires 1 to 6 minutes for the clotting. Now, basic screening tests which are required to screen the patient for the hemostatic mechanisms. The main is bleeding time. It is normally 3 to 10 minutes. It measures platelet count and vascular integrity. Then the platelet count, the normal value as we know 1.5 lakh to 4 lakh. Prothrombin time 12 to 14 seconds. It measures 1, 2, 5, 7 and 10 factor. Partial thromboplastin time, that is 25 to 30 seconds. It measures 1, 2, 5, 7, 9, 10, 11. Thrombin time is 12 to 20 seconds. It measures factor 1 and 2. And the fibrinogen is 200 to 400 microgram per dl. These are the various charts which are showing screening tests for bleeding disorders. That is blood count, platelet count, APTT, PT, prothrombin time, bleeding time. There are some abnormalities, bleeding disorders due to vascular and platelet abnormalities. There are vascular disorders, thrombocytopenia, that is low platelet function defect, defective coagulation also. These are the list of few investigations which are needed for the bleeding to find out the bleeding and clotting disorders. These tests are very important. This is prothrombin time that evaluates extrinsic pathway factor 2, 5, 7, 10 and fibrinogen, and it is prolonged in warfarin treatment, liver diseases, vitamin K deficiencies and DIC. INR, it is an international normalizing ratio. The extrinsic pathway of a blood coagulation is evaluated. Its normal value is 0.8 to 1.2. If it is prolonged, that in the patients, warfarin treatment, liver disease, vitamin K deficiencies, DICs. In this way, you can see all the tests which we are advising are APTT, thrombin time and bleeding time. So you can come to know whether there is a abnormalities in platelet functions, whether there is abnormality in the extrinsic pathway, intrinsic pathway, or any coagulation abnormalities, or patients with various diseases like liver disease, patient is alcoholic, patient is on the antiplatelet drugs. So there are so many things which we can screen clinically by simply asking for the history, proper history in which we can ask the consumption of a drug history, then history of bleeding in the past, history of any operation in the past, then history of taking any drugs, then alcoholism, deficiencies of vitamin C, vitamin K. So there are so many things to evaluate clinically and laboratorily. So now coming to the last part.
Hello.
Make the life simple, don't complicate it. The coagulation cascade always shows that make the life simple. Understanding of coagulation cascade is very, very important. Coagulation cascade is a complex mechanism. So remember, natural physiological mechanism play in a life-saving role. They act immediately, they work immediately, but externally when we see that the process is off within few minutes, and if it is not activated or interrupted anywhere, you may face the dire complications. So coagulation, the goal of coagulation is to form stable clot that occurs during formation of a clot after injury by activation of cascade protein, that is clotting factors. There are three main pathways: intrinsic, extrinsic, and common pathway. Intrinsic is activated by factors in a blood. Extrinsic are tissue factors, and common pathway results in activation of factor 10. Common pathway end with fibrinogen to fibrin for stabilizing the clot. Coagulation disorders occur when there is deficiency of a clotting factor. The common disorders which we know are hemophilia, but there are so many, and the vitamin K deficiencies, liver diseases. We know that hemophilia is also known as a royal disease. Queen Victoria passed hemophilia on many of her descendants. So these are my references. You can see the cascade. Cascade is a change of kinetic energy into the active energy, forming the various active coagulation factors and saving the life of a patient. Thank you very much. The last quote which I want
Thank
to
you so
say
much, madam.
last quote I
Thank you,
wanted.
Dr. Chandak, madam, for enlightening us on this very complicated topic of physiology of coagulation. Over to the MOCs for the next session.
Thank you, ma'am. I now request Dr. Virendra Belekar sir to introduce Dr. Riya Balikar ma'am for the next segment of this session.
Thank you. We have pros and cons of many topics. COVID has given us this new way of interaction so that we can interact and listen to the stalwarts of the subject at the comfort of our home to clear our doubts and queries. It gives me immense pleasure to introduce Dr. Riya Balikar Madam, a young and vibrant hemato-oncologist whom we work with at Kingsway Hospital. Upon whom the patients with deadly blood disorders look upon and feel half cured. And we have seen it. Such is her presence when she talks with her patients. To sum up about few of her achievements, she has done her undergraduation from Goa Medical College. Her post-graduation from in MD Medicine, medicine from KEM, and DM Hemato-Oncology from Institute of Hematology and Transfusion Medicine, Kolkata. To name few of her achievements, she was a gold medalist and has received a President Award in DNB Hematology. She is life member of various international and national professional bodies, including Indian Society of Hematology and Blood Transfusion. She has delivered a talk as a speaker in various national and international conferences at state level as well as national levels, also around more than 100 papers. On academic grounds, she is a postgraduate teacher in hematology and has served as postgraduate teacher at various medical colleges, various poster presentations. She's a part of. She has been a part of various projects Remarkably, among this is she has represented India at International Sickle Cell Working Group meeting in Beirut, Lebanon, for sickle cell guideline formulation. She has various publications in her name in national and international journals. She has written a book in book article on chronic myeloid leukemias. And she is being a part of various clinical trials also. So I welcome Dr. Ria to proceed with the talk. Thank you.
Thank you, sir, for the very kind and exhaustive introduction. So my topic that I've been given for today is pathology behind deranged coagulation profile and the role of blood and blood products. Are my slides visible, sir?
Yes, they are visible. Thank you
Yes.
very much.
Thank you. The best thing about modern living is anesthesia, and I totally agree. Anesthetists are the people who operate behind the table, and they are the ones who are responsible, who I actually say they are the heart and brain of the surgery, and they are the ones who are responsible for smooth outcome of the surgical procedure. So I really respect this profession. And I totally believe in this concept that it is not the operation itself that is the concern, it is the anesthesia. So the surgeon just operates and goes, but it is the anesthetist whose duty it is that the patient should come out right from the pre-op period, the intra-op period to the post-op period. And this topic has been excellently chosen by sir. Especially in the era of novel anticoagulants, especially in the era where we are seeing so many patients who are post-angioplasty, post-bypass. We are seeing so much of PPH, DIC, sepsis, and as Dr. Belekar said, COVID. So this topic would be covered under normal coagulation, which Madam has very exhaustively told us about. Just a couple of slides on this. Deranged coagulation, the common causes, how to interpret a abnormal coagulation profile, approach to the patient, what is new in diagnosis, what is TAG, what is ROTEM, what are the different components and when can these components be used, what is PCC, the new drug which is now available to us, fibrinogen, NOACs, and anticoagulation reversal. So like Madam has already said, this is how the coagulation pathway is. If you see, it is grossly divided into something called the intrinsic pathway, something called an extrinsic pathway. Intrinsic pathway includes all these factors which are seen in red. What is seen in blue is the extrinsic pathway. And ultimately, when you have activation of factor 10, prothrombin, thrombin, and fibrinogen forming and the polymer forming, that is what is the common pathway. But what we actually see in the body is that all this is just one process. Everything happens simultaneously. In our body, there is nothing called an intrinsic pathway and extrinsic pathway. This is obviously for the purpose of understanding, and this is how we understand it. But what we need to understand is that everything in our body happens in sync together. And when you see there are so many factors in the body, anything wrong with any one of these factors can create havoc. Any one of these factors which is missing can result in severe life-threatening bleeding. Also, what you can see is there are two processes which are happening simultaneously. One which is responsible for causing the clotting, and at the right side, you can see all these factors, the tissue factor inhibitor, the plasminogen activation inhibitor, the protein C, protein S, the degradation of the fibrin which is happening. All these factors are simultaneously responsible to keep this process in check. So again, we have the intrinsic pathway. This is just for us to understand. We have the intrinsic pathway. The tests that we, like Madam has mentioned, do to check the intrinsic pathway is the APTT, the activated partial thromboplastin time. It will basically check all these factors. 2, 9, 11, 12, 8, and fibrinogen. We have the tissue factor pathway. We have the prothrombin time that will focus on these factors. So the main factor that is covered by the prothrombin time is factor 7. And it will also help us in assessing the common pathway. These molecules which are marked in purple, these are part of the common pathway. We have another test that we use, and that is the thrombin time. Basically, that is a marker of how good your fibrinogen stores are. And to some extent, it also helps us to check the common pathway. Now, coming to my topic proper, causes of an abnormal coagulation profile. There are hundreds and hundreds of causes why a patient can bleed intra-op, but I'll focus on the main causes because of lack of time. The first is genetic. So people who have intrinsically, they have factor deficiencies, like we are talking about hemophilia A here, we are talking about hemophilia B here. Hemophilia A is basically deficiency of factor 8. B is deficiency of factor 9. We also have something called hemophilia C when the factor 11 is deficient. It's a very rare condition. Next is something called von Willebrand disease. This is very, very common, and this is something that is missed. The most important presentation here is menorrhagia in a lady, or sometimes occasional epistaxis, bruising from wounds. So this history should be kept in mind, because von Willebrand disease normally does not present with life-threatening bleed unless it is very severe. So this patient can directly bleed on the table. The next cause, and this is not so common as inherited, we see it more often in the acquired setting. But recently I had one such patient who had hypofibrinogenemia. This again is a challenge, and this should be picked up. Next is what we see very, very commonly. Liver disease is on the rise. So coagulopathy associated with liver disease. As we know, in our body, there is a balance between procoagulant and anticoagulant factors. And the liver is responsible for secreting most of the factors other than factor 8 and von Willebrand factor to some extent. So any problem with the liver, this delicate balance gets hampered, and both the procoagulant and the anticoagulant levels will go down. So these patients are prone both for bleeding as well as thrombosis. Especially intra-op, the problem would be bleeding, but post-op, what we see more commonly, the problem is thrombosis. And you can see there are so many factors which are involved. One more problem that happens in these patients is platelets are on the lower side almost always. So along with coagulopathy, there is also something wrong with the platelets. The platelets are on the lower side. One more problem that we see routinely is something called disseminated intravascular coagulation. This is more important to us as anesthetists, as intensivists, or as hematologists. This will come in our, into picture with reference to this topic only when we are going to take this patient up for surgery, which we will shortly see. So what happens in DIC is, because of any trigger, most often it is sepsis or it's something like a postpartum hemorrhage, the coagulation pathway is activated. At the same time, there is a decrease in the anticoagulation level. So simultaneously, what you have is thrombosis at one side, and one side what you have is bleeding. So again, this is a very delicate balance, and managing these patients becomes a real challenge. In which patients do you give blood supports? In which patients do you give antifibrinolytic agents? And which patients do you give anticoagulation? Now, this is a small chart that tells us causes of acquired hypofibrinogenemia. This is again much more common than what we anticipate. And these patients sometimes can present very late with intracranial bleeding or life-threatening GI bleeding. So causes of acquired hypofibrinogenemia will be liver problems where the fibrinogen is not being produced. Massive transfusion. This is something which we should keep in mind, especially in the setting of polytrauma and in some patients who are undergoing cardiac surgery, especially who are on extracorporeal cardiac bypass machines. Hemodilution, which happens, can be life-threatening. So it is very important to strike the balance between blood and blood components. One more cause, obviously, is DIC. Drugs, a very important cause. Now we see that initially there was a time when what we used was aspirin, clopidogrel, warfarin, and heparin. Now we have a range of drugs which are the novel anticoagulants or the NOACs, and managing bleeding in such setting has again become difficult. coming to how do we check the coagulation cascade? PT, APTT, thrombin time, fibrinogen are the main tests. Madam has already exhaustively told us about this. Prothrombin time, the main cause, if you have just the prothrombin which is elevated, could be a factor 7 deficiency, a very rare thing. So the next common cause, but normally what happens in these other causes is the APTT is also slightly prolonged. All these factors are basically vitamin K dependent factors. So anything that is causing the vitamin K to go down, be it malabsorption or be it reduction in the dietary intake, any liver problem, or warfarin, acetylrome, all these drugs, they cause vitamin K dependent, they interfere with this enzyme, the weak cock, which is responsible for hydroxylating the factors, and because of that, the prothrombin time will get prolonged. Now, conditions in which both PT, APTT get prolonged, the most important condition for us is DIC and massive transfusion and sometimes liver failure. Condition in which only APTT gets prolonged, especially if you have a male patient, we would more likely think in terms of something like a hemophilia A, B, or a hemophilia C. One more drug which causes only APTT to be prolonged is heparin. This is in the setting of bleeding. Now, if a patient has come to us with clotting, and if the APTT is prolonged, then we obviously think of antiphospholipid antibody syndrome. Thrombin time, not routinely available to us. There are very few centers which do it. So most important cause of prolongation of thrombin time is anything to do with fibrinogen, either congenital or acquired. And sometimes heparin also can cause prolongation of the thrombin time. Now, what happens with these tests that we do? PT, the APTT, the thrombin time, the fibrinogen. The most important problem with these tests is that these are in vitro tests. We are not actually checking the tendency of the body to cause coagulation within the body itself. So first thing, they are in vitro, done outside the body. Second thing, you don't know when the sample has been taken. You take the sample, you shift it to the lab, you don't know when it would be run. So these tests need to be done immediately if you want accurate results. So the time lapse that happens is a big problem in interpretation. Exact cause, like we saw, there are multiple causes of a prolonged PT, APTT. It's difficult to pinpoint the exact cause. And one more thing is efficacy of your ongoing treatment. Suppose you have a patient of cardiac surgery or suppose liver transplant on table. You don't know using these tests whether your replacement therapy, the factors that you're giving, the cryoprecipitate that you're giving, you don't know whether all this is causing any effect or no. So efficacy of treatment is also difficult to judge based on this. So there comes the role of thromboelastogram. And this is very much available in our hospital now. So on table, and even patients with severe coagulopathy, like during COVID, we have used this a lot. In dengue patients, we have used this a lot. This is a test which is actually helping us guide factor replacement therapy. So it's a very, I'm putting it simply, it's a very sophisticated thing. This basically the starting, this part that you're seeing here, this is the latent time. This will tell us about the clotting pathway. This is the angle, that is how far that clot is going to be produced, how fast that clot is going to be produced. So that again tells you about your clotting pathway and the fibrin. The amplitude is the maximum strength of the clot. That is telling you about the interaction between the platelets and the fibrinogen. And this later part, the breakdown that we are seeing, that is telling us whether the clot is strong or no. So whether that is getting lysed or no. So basically this helps us to guide therapy, decide whether the patient should be given FFP, cryoprecipitate, the patient should be given platelets or what else. Difference between TEG and ROTEM is that in ROTEM, the pin oscillates, in TEG, the cup is oscillating. So coming to how to approach these patients. First, a pre-anesthetic checkup is very, 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 very important. A detailed history, including history of bleeding, a strong family history of bleeding, if that is there, drugs the patient that is on, examination to see if there are any obvious telltale signs of bleeding like petechiae, ecchymosis, and sometimes signs of liver failure, signs of autoimmune disease. This is something which should be followed, a bleeding assessment tool or mat. This is a one classic example. This is by the International Society of Thrombosis and Hemostasis. So we can see the questionnaire on the left-hand side is the pediatric one, right-hand side is the adult one. There are many points which are given. So according to the points which are given, you should stratify your patients. Most of it is with respect to bleeding. So basically this helps us to predict whether this patient is going to have a on-table bleeding. Coming to the most important part, management. And I would say the first part of management is history, because not in every patient are you going to do all the coagulation tests. What we routinely do is just a platelet count and a prothrombin time. But if patient has anything to suggest that this patient could be having either something acquired or genetic, which is causing bleeding, a detailed workup, including assay of the higher clotting factors, fibrinogen, platelet function test should be done. So I would stress this is the first part of management, a proper history. So if everything is clear, there is no history, the patient is not on any drugs, or examination is clear, go ahead with surgery. Nothing needs to be done, just a platelet count and a prothrombin time. Any of it is positive, then you need to involve the expert, and accordingly the tests which are suggested need to be done so that the patient doesn't end up with on-table bleeding. Now we know that blood is not the answer for everything. So here comes the role of component therapy. Components are basically nothing but what we have derived from the blood. So the blood has red blood cells, white blood cells, and plasma. All our clotting factors are derived from plasma. So the first component is FFP. We are very familiar with it. And because of lack of time, I am not going into details of this. We know that it is frozen. It can be used for up to 1 year. What is important here to remember is most clotting factors, the availability is 1 unit per ml only. So if I want to give 250 units of the factor, I need to give 250 ml, that is 1 bag of FFP. If I need to give 1000, then I need to give 1 liter of the FFP. This is important to remember. Clotting factor content is 1 unit per ml only. Fibrinogen content of FFP is again very low. And the dose that we use, hemophilia A, hemophilia B, it will all depend on the level of correction that you want and the surgery that you're aiming for. Roughly, we aim for a 50 to 80% correction depending on the type of surgery. Neurosurgery, we aim for 100% correction. 100% correction would be around 2.5 liters of FFP, which is massive. Fibrinogen, when we give FFP, the amount that needs to be given is 15 ml per kg. We know that there are multiple side effects associated with FFP use, including the patient can land up in trally, the patient can go into volume overload. So it should be used only when needed. These are the indications. FFP can be used in warfarin reversal. It can be used on table if the patient has bleeding and something like a cardiac bypass procedure. Plasma exchange FFP can be used. Warfarin toxicity, it can be used. Again, all these things need to be kept in mind. One more problem is that, however, even if you do NAT testing, sometimes the window period might not be picked up, so the patient can end up with a viral infection. This is cryoprecipitate. Cryoprecipitate are much, much smaller bags. Each one is around just hardly 30 ml or so. It has more concentration of the factor. But problem with cryo is all the factors are not there. Cryoprecipitate just has factor 13, factor 8, fibrinogen, fibronectin, and Wolberi-Brand factor. These other factors which the FFP has will not be present in cryoprecipitate. So cryoprecipitate is very useful, but in certain settings. We have something now which is called highly purified fibrinogen concentrates. I'll be coming to that later. It's just a small vial which has powder which should be reconstituted and given. Excellent product, recently come into the market. Cryoprecipitate, this is for us. FFP, the dosage, what is important from this slide. FFP is 15 ml per kg. Cryo is just 1 bag roughly for every 10 kg of body weight. This is where cryo can be used. Hemophilia A, B, von Willebrand disease, and fibrinogen deficiency. Sometimes you use it in DIC also. Very important to remember, no blood component is 100% safe. So that is the concept of isolating factors. So we have highly purified factors now. We have factor 8, we have factor 9, and we have long-acting factors. Eloctate is easily available for us now. These are all used in the treatment of hemophilia. So this is what I was saying, fibrinogen. So in patients with fibrinogen deficiency acquired, which can be because of DIC, which can be because of PPH, or inherited, fibrinogen powders are now used. And there are multiple studies. As you can see, please look at these graphs. You can see the surgical, both the intra-op, the post-op, and otherwise also the hemostatic efficacy that has been achieved has been excellent with fibrinogen versus cryoprecipitate. So this is an excellent drug which is easily available to us now, and very, very good, free of side effects. And the risk of subsequent bleeding also becomes minimal with use of fibrinogen concentrates. So there are multiple recommendations on how much that you should give. Normally we give 70 milligrams per kg body weight as a loading dose. Then we look at how much the level of fibrinogen that needs to be achieved, and accordingly we titrate the dose. Uses of fibrinogen, the first is inherited deficiencies, second is PPH, DIC, massive transfusion, and fourth is cardiac surgery when the patient is on a extracorporeal machine. So this is how the product is. Initial dose I've already mentioned. Many times this doesn't even need to be repeated. Gynac settings, the dose needs to be high. It needs to be around 3 grams. Otherwise, a dose of 1 to 2 grams is sufficient. So, NOACs, last part of the topic. What are NOACs? They are the novel orally available anticoagulants that we have, and multiple guidelines with use and when to stop, when not to stop. So quickly in the next, I have 5 minutes. I'll just go through these drugs and the guidelines. If the patient is on low dose aspirin and the patient is posted for any surgery, the patient can safely go ahead with the surgery. Low dose aspirin, what we mean is 75 milligrams only. If the patient is on clopidogrel, if the surgery can be deferred, please defer the surgery. If not, then it has to be stopped for minor surgeries 5 to 7 days, major surgeries 7 to 10 days before the operation, because clopidogrel causes a higher chance of on-table bleeding. This becomes a problem, especially in patients who have undergone angioplasty, who have a stent. So you cannot basically stop the drug. For a bare metal stent, which we hardly use now, it is 3 months. But for a drug-eluting stent, as far as possible, we try not to stop antiplatelets for 12 months. So managing of these patients becomes difficult. Warfarin, again, if the patient is undergoing a minor dental procedure like a root canal, joint aspiration, cataract, which is a bloodless surgery, endoscopy without biopsy, warfarin need not be stopped. If at all, you may consider switching to heparin, which can be titrated. But if patient is undergoing major surgery, it has to be stopped 5 days before the surgery. About NOACs, if possible, defer the surgery if you can for some time. If not, immediate surgery is available. We have products to reverse the NOAC. We'll be coming to that. Dabigatran is one drug which can be removed fast with hemodialysis also. So to understand when the NOAC needs to be stopped, we need to know the half-life of the drug. Rivaroxaban has the shortest half-life, 5 to 8 hours. Apixaban is 7 to 8 hours. Dabigatran is 12 to 15 hours. So you need at least 2 to 3 half-lives to pass between the dose and the surgery. If the patient has any renal impairment, mild renal impairment, moderate creatinine clearance is less than 30, then the time is doubled. You need at least 4 to 5 half-lives. So accordingly, we plan our surgery. Anywhere from 24 hours to 72 hours before you need to stop the dabigatran. This is the recommendation for dual antiplatelets. These are the new drugs which are available to us, prothrombin complex concentrates. These can be either 3-factor or they can be 4-factor. 3-factor prothrombin concentrates do not have factor 7, 4-factor have it. We have all these drugs available for us. They can be used to reverse bleeding caused by warfarin, In liver disease, they can be used to reverse bleeding caused by all the NOACs. The problem with them is that these drugs can cause thrombosis. So their use should always be justified. This is the activated APCC that we have, which is called FIBA. Very expensive drug, but very powerful drug. We keep it as a reserve. So this is again treatment options in patients on NOACs who are bleeding. One more beautiful drug that we have now is something called Novo 7, a new drug. Important part that I want to say is that they are very, very efficacious, as we can see here. But problem with them is they cause thrombosis. So they should be used only when needed in consultation with the specialist. This is all reversal of the drugs. This was the wonderful drug that I was telling you about, Novo 7. Very powerful drug. Basically, what it does is that it directly activates the common pathway. You are actually giving factor 7 with the tissue factor gets activated, causes instant clotting. Effect is wonderful. But again, problem is if patient has had an angioplasty in the future, past, patient has had a thrombosis in the past, it can result in rethrombosis and blockage of the stent. So used with caution. Take home message, my last slide. History examination and a bleeding assessment questionnaire, utmost important in sort of triaging your patients, which patients need further workup, which patient don't. Rational, justified use of all the component therapy that we have, depending on the interpretation of the results. Individualized, like the treatment that you would give a pregnant lady who is in DIC would not be the same that you would give to a cardiac patient who's recently undergone a bypass or angioplasty. Now we have components available which are very safe, wonderful drugs with minimal side effects, novel agents, but risk of thrombosis has to be kept in mind. So thank you so much for having me. And it was a real pleasure being a part of this. If there are any questions, I would like to take it. And like I said, the surgeon is the main blood and heart of the surgery, but the anesthetist is the brain behind the surgery. The anesthetist is the person who is actually responsible to see that the patient comes out safely. So I salute your profession. I salute all of you and thank you for whatever that you are doing. Thank you so much.
Thank you, Ria. Do we have time for questions, organizers? We have a few questions here. Hello.
Hello, sir.
Do we have time for questions?
Yes, sir.
Yes, sir.
Yes, sir.
So we have a few questions here. Yeah, Dr. Ria, is
Yes,
PT or INR better measure for evaluating the effect of vitamin K on coagulation profile than APTT, and why?
Yes, sir. Vitamin K is basically acts on 2, 7, 9, and 10. And most of these factors are covered by the prothrombin time. The most important factor that we are talking about is 7. So if we want to assess the efficacy of warfarin or the vitamin K antagonist, prothrombin time is the best test. These tests also prolong the APTT, but not so much. And the scores that we have for predicting efficacy are based on the INR rather than the prothrombin time. Prothrombin time is the test that we use more for the liver patients. But INR is the test, along with PT, of course, that has been validated to assess the efficacy of warfarin antagonist, vitamin K antagonist. So you're not audible.
Yeah, so massive blood loss in PPH, what is the fluid management strategy till we get blood in hand? Like till if patient is bleeding and the blood is yet to arrive. So what kind of fluid, or maybe he needs to, he may be asking the role of commercially available coagulation factors during such time.
Yes, sir. So actually, there is a role of on-table POC testing point of contact testing. And the best test here is a thromboelastogram. I would strongly recommend this in this setting. Results are very fast, and this will actually help to guide us the factor therapy, what should be given, what not to be given. But in the absence of time, the first thing that should be given is fibrinogen, because most of these patients have some dilutional coagulopathy with acquired hypofibrinogenemia. So I would directly give this patient 3 grams of fibrinogen concentrate. I would put this patient on tranexamic acid high dose, which is 1 gram IV. And in the meantime, till blood products can be arranged. Obviously, normally in such patients who are high risk, we do keep at least a blood standby, PRBC standby. So whole blood can also be given, sir, in this instance. It is an excellent option because it will help replenish the clotting factors also.
How to decide
And
the dose of
too much of
FFP?
loading the patient, we should use crystalloids. Yes. Crystalloids, the previous question was crystalloids should be used, but too much loading would be a problem because there is some amount of cardiac overload and volume overload also which is happening. FFP, the dose would be, sir, 10 to 15 ml per kg body weight.
Any other questions?
Sir, we have a very interesting question for Dr. Chandak, ma'am.
Yes.
Ma'am, kindly, there's a question in chat box. So kindly elaborate on ready place time, ma'am.
Yes. So it is a test, a blood test used to detect deficiencies of abnormalities in the fibrinogen. The purpose of blood test is used to detect deficiencies and abnormalities in fibrinogen. Functional plasma, it is a functional plasma clotting assay based on enzymatic action of a batrosobin. Defects, deficiencies, and abnormalities of fibrinogen, especially in case of a heparin contamination. So its purpose is to detect deficiencies and abnormalities of fibrinogen. It is prolonged in a hypo of fibrinogenemia. Okay.
Thank you, ma'am.
Any other questions?
Yes, sir. There is one more question. Here is a
Okay.
from Arvind Shinde, sir. He is
12-year-old girl with
Yes.
raised INR and normal liquidity for tonsil adenoid surgery, no bleeding and family history. Clinical examination is normal. LFT is also normal. Vitamin K has been given. INR checked in other lab, but still the INR is 1.56. What would be the line of management in this case?
So is it for me?
Yeah. Yes.
I would, LFTs have already been done. So that is what I would, and the next thing I would do is a factor 7 level. So a borderline low factor 7 can result in prolongation of the INR. So factor 7 level should be the next thing which should be done. And suppose in the event, I'm expecting a factor 7 level to be low. So in that case, the patient can be given Novo 7, which is the purified factor 7 concentrate, and the surgery can be done. But if the factor 7 levels come normal, there are other factors also involved with this. Though we look at factor 7 and we look at the something like tissue factor, something like some minor problem with the common pathway can also result in just one part being deranged, but the other part being normal. So if that is the case, then I would, and factor 7 is normal, I would give FFP to this child. The dose would be 10 ml per kg and then take the patient up for surgery.
Okay. And factor concentrates also we can try that.
Yes, factor 7 concentrates can be given.
Okay. Should PT-INR be mandatory for all patients undergoing surgery? I think we don't advocate, but do you advocate, ma'am?
Sir, we normally do just the platelet count and the bleeding time, clotting time is something which is obsolete now. It doesn't have much role, but bleeding time tells us about the coagulation pathway, tells us about the platelet function test also. So I would just do a bleeding time and platelet. But if it's a major surgery, then yes, I would do the prothrombin time, even in the absence of significant history, only if it's a major history surgery. But again, the BAT questionnaire and everything should be taken into account, whether it should be done or not.
So excellent presentation, madam. So rightly said, the take-home message that history remains the main cornerstone for managing such patients, and then investigate accordingly before we take the patient on paper. Thank you very much, madam.
Thank you, sir.
Hello.
Yeah.
Sir, there's just one more question, ma'am, sir. From Dr. Anup Nlavar. Sir, what is the ma'am? What is the best management? Hello.
Huh.
Yes, ma'am. So, what is the best management of dual antiplatelets post PTCA and who also had simultaneously subdural hematoma, ma'am? Kindly answer, ma'am.
So basically, you want to do some invasive intracranial procedure, is it not?
Yes, ma'am.
Yes. So, and the post-plasty, the time is how much? Can you stop the antiplatelets? Post-plasty, is it been 1 year, 2 years, 6 months?
That has not mentioned, ma'am, in the question.
Okay. So if it is, you use a drug-eluting stent and it is more than 2 years post-plasty, you can stop the drug.
Yes, ma'am.
And you can go ahead with your procedure. But because it's a brain surgery that you're dealing with, I would do it under platelet cover, honestly, because what these antiplatelets do is they cause a platelet function defect. The platelet count will be normal, but the platelets will be abnormally functioning platelets. So I would do it under platelet cover and stop the drug. Now, if it's less than 2 years when my plasty has been done, I would
stated 15 days, ma'am.
15 days is a very acute event. So it's a very, very, very difficult situation, very, very tricky situation, honestly. So if the SDH is big, causing compression, midline shift, then only I would think of taking this patient up for surgery. And during surgery, obviously, I would stop the antiplatelets and I would give STP. But immediately post-surgery, I will start this patient on heparin, fractionated heparin, because you have to save both. You have to save the heart and the brain. If you stop the antiplatelets, the stent will get thrombosed. And if you continue it, the bleed will increase. So I would put this patient on fractionated heparin, 5,000 BD or QID, depending on how bad things are. Stop the antiplatelets, take the patient up for surgery only if needed, and simultaneously give platelet transfusion in this patient.
Thank you so much, ma'am, for that insight, ma'am, and the answer. I hope Dr. Anup would have gone an excellent answer for that question, ma'am. Now we are ready for our next session, ma'am. Moving on to our next session.
Just 1 second. Thank you so much, and thank you, Doctor. Special thanks to Dr. Chakule, sir, for having me. Thank you so much. It was a pleasure attending. Bye.
Thank you. Guys, now we are moving on to our next session, which will cover the challenges faced by anesthesiologists while evaluating a patient with coagulopathies.
Our honorable chairperson for this session are Dr. Muralidhar Joshi, sir, who is the chief guest for today, and Dr. Jayashree Sen, ma'am, professor and from Department of Anesthesiology. I now request Dr. Muralidhar Joshi, sir, to introduce the first speaker of this session, Dr. Jiggy Devatia, sir.
Morning once again. You're seeing my face. Well, it's part of the process. But I think whatever the 2 sessions I heard about the physiology, pathology, it has a phenomenal program. If you ask me, one of high quality CMEs I have attended, I should congratulate Wardha ACCT branch and the office bearers and also rest of the members. It's very high quality work which is going on. Phenomenal speakers. It's highly, I would like to say they are not speaking on the borrowed language. I would like to say they have been working in that area. They know the nitty-gritty of what is happening, why is happening. And I think we are blessed to have the first 2 speakers. Next 3 speakers also phenomenal, and I had the honor to introduce the first speaker of second session, Dr. Jiggy Devet here. I know him personally for so many years, so I don't know from where to start, where to end. I start that one that is much bigger than his lecture. Sir was there at Tata Memorial Hospital as professor and head of the department and heading so many responsibilities and all. Right now, he is there at Rajasthan. Has been recently promoted to one of the Tata units as the dean of the institution, dean or director. I'm not sure, but one of the high positions. And apart from that, I would like to say he was editor-in-chief for ISA, and he did a phenomenal job as editor. And IJ, what is seeing today is because of teamwork from all the past editors who have worked at that particular point of time. And he had a very good cohesive approach towards meeting people and speaking to people and get the job done. That's what it matters in life. How much people you get. So I would like to say, Jiggy sir is one of the phenomenon, and I think he accepted the invitation at one go from Wardha team. Thank you, sir. We would like to hear from you. One of the most important thing is the clinical side. Preoperative assessment. Once again, sir, thank you so much, sir. What do you think? Thank you so much.
Thank you, Dr. Joshi, for that very, very kind and generous introduction. And thank you, Dr. Chakole, for inviting me to this meeting. I've been listening to all the talks so far with great interest, and I'm really happy to be part of this excellent CM. So I've been asked to speak on the preoperative management of Can I share my screen? Just please give me a minute.
Yes, sir, you can share the screen.
Hello, sir.
Yeah, I'm just going to share my screen in a minute.
So, sir is looking for the screen and all those. Yes, I think sir is online.
Yes, sir, your screen is now.
We got it. We got it, sir.
So I'll be speaking on the preoperative assessment and optimization of patients with the deranged coagulation profile. And I'll not be talking on the platelet part of it, but mainly on the coagulation factor part of the. Okay, and okay, so we've already seen a lot of this, and so we know that we've got the intrinsic pathway and
Please mute everyone except for the speaker, please. Please mute everyone except for the speaker. Thank you.
So you've got the extrinsic pathway, the intrinsic pathway, and that is assessed by the activated partial thromboplastin time. You've got the extrinsic pathway, which starts with endothelial injury and exposure to tissue factor, and that is assessed by the prothrombin time. And we've got this common pathway, that is activation of factor 10 along with this complex over here, and that activates prothrombin to thrombin. And you heard this very nice talk in the morning, how the coagulation actually happens. So essentially, we're going to assess the APTT, and we are going to assess the PT or the INR as our main sort of coagulation factor tests. And you've sort of seen, in the previous talk that you can have different sort of combinations of derangement of coagulation factors. And I won't go into all this in detail, but you need to know whether your PT is elevated, your APTT is elevated, or both are elevated, right? And so if you've got deficiencies primarily in your extrinsic pathway, that is, you will have an elevated PT, and that will be factor 7, vitamin K deficiency, warfarin, and sepsis. So if you, right, or DIC, if you've got only an elevated APTT, then you're probably looking at something like heparin, which is there in the circuit, or so in the patient, or some isolated factor deficiency, as was pointed out in one of the answers to one of the questions. And you also need to keep in mind, in some patients, for example, you've got a young lady who's got a bad obstetric history, number of fetal deaths, abortions, and he's got an elevated APTT. It could be a lupus anticoagulant over there. And these patients tend to clot rather than bleed. So you need to keep that in mind as well. And some patients who have a very high APT as well as PT, they could be having very high heparin or vitamin K levels, and or they could be having liver disease, DIC, and all those sorts of things. Okay. So that's essentially what you're sort of going to be looking at. Thromboelastography is an excellent test. It's a viscoelastic test, so it tests the entire coagulation process, starting from the platelet plug formation right down to the thrombolysis. And therefore, it's a very good test, and it's available in many, many places. You have different types of viscoelastic tests. The one common one is thromboelastogram, whether you've got the ROTEM. They're all sort of more or less similar, and you just need to be able to, know the patterns in, and it helps you in diagnosing what is the problem, and also in guiding your therapy, your specific therapy, whether you want to give platelets, whether you want to give fresh fluid plasma, cryopsate, fibrogen, or even anti-fibrinolytic. Okay, so you should have a look at these patterns, gives you a very good idea of what you're dealing with. And in patients who've been on, say, dual antiplatelet therapy, and you don't have enough time to stop the dual antiplatelet therapy, a quick look at the TEG will tell you how badly your platelets are affected and whether it might be okay to just sort of go ahead or not, right? So thromboelastography is an extremely important test, although there are no valid, for example, you cannot say that you need to have an alpha R time of X to titrate heparin therapy. You can certainly know that this patient is having some factor deficiency or is having heparin on board. That will tell you if your R time is prolonged, right? Okay. Now, one very important message that I want to give everyone who's listening over here is that that we've got inherited coagulation defects, like hemophilia, and they usually have a typical history. But a lot of the acquired defects in coagulation, they're either because of drugs which patients are taking, or because of some diseases, underlying other diseases that the patient has. And even the drugs that the patient take to take care of coagulation or to prolong the coagulation are because they have an underlying disease. For example, warfarin for atrial fibrillation, right? So they have heart disease, they have atrial fibrillation, that's why they're taking warfarin. So you need to understand that in all these patients, the abnormal coagulation tests, of course, they are a problem by themselves, but they also occur in the setting of other serious illnesses or conditions. And therefore, we must optimize the coagulopathy as well, but it is extremely important to optimize the underlying illness, which has made the use of anticoagulants or which has made the patient coagulopathic, right? So we need to optimize that as well. And in some instances, like in DIC, patients with sepsis and DIC, they may have to undergo emergency surgery because correction of the primary problem is the treatment of the DIC. And you have to therefore continue preoperative as well as intraoperative support of the coagulopathy. And of course, if you've got the coagulopathy and undergoing elective surgery, then you need to defer surgery till you sorted out the cause of the coagulopathy and managed it adequately. And the history is extremely important. So, you'll ask for history of bruisability, especially in young boy, history of easy bruising, whether they had hemarthrosis or joint swellings or, and of course, you'll do your laboratory tests. But it's again, this is one sort of situation where good consultation with a good hematologist is extremely important, especially when you're looking at some of the inherited conditions or some of the acquired conditions, and the results are equivocal. Okay, and so you need to consult. Of course, you need a hematology consult, but like I mentioned, you need to have optimization and consults of the various specialists for the underlying medical conditions and comorbidities. You need to have good liaison with your blood bank or the transfusion medicine department so that you can sort out the use of your different coagulation factors, your different isolated sort of factors that are available, and you should have a good liaison with your dispensary and your transfusion medicine department so the appropriate factors and the concentrates are available. And of course, because in every coagulopathic patient there's a risk of bleeding, there must be a good discussion with the surgical team and counseling of the patient and the family. So with this sort of background, let's go into a case. Okay, so this is a young lady who's got mitral stenosis, got chronic atrial fibrillation, and is on warfarin, right? So again, so the warfarin is going to make her coagulopathic, and but she's got mitral stenosis and she's got AF. So we need to optimize that condition as well, but we won't go into that, right? And she's got an INR of 2.5, well controlled, but she's now come for a commando operation. So how do we sort of handle this sort of patient? So in this patient, right? So warfarin is extremely commonly prescribed. Of course, now the NOACs are also being prescribed quite a bit. So prosthetic heart valves, atrial fibrillations, DVT, and primary pulmonary embolism, and other thromboembolic events. How does warfarin work? So the warfarin, so vitamin K is required for normal coagulation. It is converted to KH2. It is reduced by this enzyme. And then this KH2 is oxidized. And in the process of oxidation, it activates all these coagulation factors, which are largely in the extrinsic pathway, right? 7, 9, 10, and 2. And so then this vitamin, the oxidized vitamin K is, again, it is reduced back to vitamin K1, and that is how vitamin K is recycled, right? And therefore the vitamin K levels remain constant. And what warfarin does is it sort of blocks this pathway, which reactivates, which recycles vitamin K. And this results in a reduction in the vitamin K levels, and therefore it results in reduced activation and reduced activation of these coagulation factors. And therefore you get a high INR or a high prothrombin time, right? Now, when you have a patient on warfarin, and who's going to undergo surgery, you are worried that the patient will bleed, and therefore you need to do something about the warfarin. At the same time, remember, this patient's atrial fibrillation can throw a clot at any time, and therefore you also need to worry about the risks of rethrombosis or reembolization or thromboembolism, and you need to somehow balance the sort of risk. Now, to prevent excessive bleeding, you need to reduce the INR to about 2.5. At the same time, you need to make sure that you're quickly able to restart anticoagulation immediately after the bleeding risk of the surgery is over, right? So you need to assess, of course, the INR is going to tell you how likely the patient is going to bleed, but you also need to assess the bleeding risk in some of these patients, right? So, and some patients have a higher risk of bleeding, and they need little quick, better reduction of the INR. Now, we know that warfarin, okay, it inhibits vitamin K, right? And that is largely responsible with the factors 2, 7, and 10. And factor 7 has a very short half-life. Factor 2 has a long half-life, about almost 4 to 5 days, 3 to 4 days, right? And therefore, initially, when you give vitamin K, the first level that drops is factor 7, and the last sort of factor level that drops is factor 2, right? And essentially, after about 5 days, all the factors are reduced when you give warfarin. So effectively, the action of warfarin will start by reducing factor 7 levels within a few hours, but you'll get the full action of warfarin in about 5 days, which is an important thing you have to consider when you restart warfarin. Okay. Now, if the patient on warfarin, what do you do? So there are 3 simple strategies. One is you stop the warfarin. The second is you give vitamin K, either oral or IV, so that you restore the vitamin K levels. And you can give some factors, either fresh frozen plasma or other factors, which we'll talk about, to substitute for the factors which are reduced. So these are 3 rough strategies which we use in patients who are on vitamin K. Right? Now, remember, the half-life of warfarin is 40 hours, roughly 48 hours. And therefore, if you stop warfarin for about 3 half-lives or 120 hours, that's 5 days, your warfarin levels will be negligible and your INR should come down to normal. So if surgery is not urgent, just stopping the warfarin for 5 days should be enough. However, this is not suitable for urgent surgery. So if you've got enough time, you can very elective surgery, then all you need to do is stop the warfarin, keep monitoring the INR, right? And when this INR is less than 1.5, you do the surgery. Usually be around on the 6th day, because 5 days your INR will come back to less than 1.5. Now, if your patient is at high risk of clotting, and that's assessed in many ways, but valvular atrial fibrillation is probably a high risk of clotting, and then you need to do what we call as bridging, right? And bridging means in the time when the warfarin levels are going down, you need to cover with either standard heparin or low molecular weight heparin to reduce the risk of clotting, right? So here you start bridging with either IV unfractured heparin or twice a day low molecular weight heparin, starting around day 3, right? And then you stop this 24 hours before your surgery, operate 24 hours after you stop the low molecular weight heparin, or 6 hours after you stop the unfractionated IV heparin, and go ahead and do your surgery. And then you restart warfarin in the post-operative period. You give the warfarin on the first day, but remember warfarin will take 5 to 6 days to pick up. Around day 2, you start prophylactic doses of heparin, and then you continue that till your INR picks up.
तो बस इसका भी करो प्लान
That's roughly how we do it.
और
Okay. Now, if you don't have 5 days to do the surgery, suppose it's a more urgent sort of operation. If you've got about 24 hours, then you can give IV vitamin K, right? And if the IV vitamin K is not enough, then of course you give substitute fresh frozen plasma. Can I request everyone who's not?
Sir, I think it's overlapping, sir. Somebody has logged in by mistake or overlapping. Sir. So you go ahead, sir. You go ahead. We can hear it. Don't worry about it. Sir. Thank you, sir. Okay, sir, please go ahead.
So, and if it's very urgent, then vitamin K will not work very fast. You need to immediately reverse by giving fresh frozen plasma to substitute for the factors which have been affected by vitamin K, right? So, and always remember that a vitamin K is, should be given over 30 minutes, and for very rapid reversal, you need to give FFP. And the initial dose of FFP is 15 mils per kilo. There are 2 other alternatives which are available and which are useful, especially in very bad cases, where you've got urgent, say, you've got a neurosurgery, you've got an intracranial bleed, then activated factor 7 and prothrombin complex concentrates, right? And they can reverse within half an hour to 2 hours. But please remember, you must also give vitamin K in such patients, because otherwise the factor 7s will be regenerated within 4 hours, right? So you need to give vitamin K over here as well, right? So give a rapid reversal, you give FFP on, if you've got money, and a little more expensive but extremely effective, activate factor 7 and prothrombin complex concentrates, right? So fresh frozen plasma contains all of these, including fibrogen, von Willebrand factor, and antithrombin. However, you need to give large volumes, right, to get sufficient amount of these factors in with the FFP, and therefore and also the effect of FFP is little variable. You cannot really predict. Roughly, the factor levels go up by 20% with 15 mils per kilo, but the effect can be variable. And there can be a risk of fluid overload, as in this lady with mitral stenosis, right? Of course, then you need time for thawing. So it takes time to give the FFP, and it takes time to do this. There's a risk of trally and all those kind of things. Activate factor 7 is useful, but what is now also shown to be very useful is a 4-factor prothrombin complex concentrate. Very small volume, factors 2, 7, 9, and 10, as well as protein CS and heparin. And that actually, based on an INR level, you can titrate your dose. A little expensive, but they are extremely useful, work extremely fast, and are available in India. And they can be used in cases where you need rapid, urgent reversal of warfarin effect. And you can add vitamin K, should add vitamin K to avoid a rebound increase in INR. Okay, we've heard about the NOACs, the direct acting and the factor 10A inhibitors. So these are the new oral or the novel oral anticoagulants. And now these 3, rivaroxaban, apixaban, are very commonly used in India, and they inactivate factor 10. And factor 2 inhibitors, so direct thrombin inhibitors, is dabigatran. So they work by slightly different mechanisms, but they are all orally available, and they are alternatives to vitamin K antagonists, that's warfarin, in many situations. Okay, and what you need to do is understand is that dabigatran is cleared by the kidney, and if you want to reverse dabigatran, you can actually dialyze the patient. Now, the other important thing is that in most of the times in therapeutic doses, the PT and APTT are not significantly prolonged in patients taking these drugs. So if you just do a screening PT, INR, and APTT, you may not get any major abnormality. If you want to really know what's happening, you need to do a thrombin time for dabigatran, and you need to do a activated factor 10 level for rivaroxaban and apixaban for these drugs, which are 10A inhibitors. So if you do, and these tests, the factor 10 levels are not done on a routine basis. So that is why it's a little difficult to keep track of how much effect is there. However, if there is an overdose or there's an excess, then your PT and APDT will be deranged. Okay. So there are different ways of doing it, but I suggest that if you really want to know what's happening, you need to do specialist tests and consult a hematologist who will help you in figuring out what is what. There are also reversal agents for some of these NOACs, which are now available, again, extremely expensive. So for dabigatran dialysis, otherwise there's an antagonist called idursulfimab, and for anti-10A agents, you've got adexanet, right? So these agents are available, but they're expensive. But in certain situations, you could consider using them. So that's the sort of drug-induced anticoagulation with vitamin K antagonists and NOACs. The other situation is this. Okay, so you've got a young male who's involved in a road traffic accident, hit on the right side by a truck. He obviously has a liver injury, but hematoperitoneum. He's got a fracture of the femur. He's already been resuscitated on the way in the emergency department and in another hospital before he comes to you with lots of fluid. He's got few packed red cells. Okay, and he's got red cells continuing. He's given a little bit of FFP. And when you see he's got a raised INR and a APDT and thrombocytopenia, and he has to undergo an urgent exploratory laparotomy for his hematoperitoneum and liver injury. Right. So here what we are dealing with two things. We are dealing with the coagulopathy associated with trauma. So a trauma patient, even before he gets any blood or blood products or fluids, can have about 20 to 30% will have a deranged INR. They will have a coagulopathy just because they've had major trauma and because of systemic inflammation, right? So that has triggered off a coagulopathy, and many trauma patients will have that, especially with major trauma. In addition, these patients are resuscitated with lots of fluid and packed red cells. So all our fluids and our packed red cells do not contain any coagulation factors. So there's a dilutional coagulopathy. The coagulation factors are diluted and their platelets are diluted. So they've got a dilutional thrombocytopenia. They've got low factors 5 and 8. Citrate has come in from all the red cells that you've given. So what you use to for blood storage, the citrate which is there in your ACD is again going to reduce the calcium levels and cause citrate intoxication, and that's going to make the patient bleed. And also, if the patient has got shock, you might be headed for a DIC sort of picture. But this picture that I showed you is not necessarily a DIC, right? This picture of a raised INR and AP could just be coagulopathy of trauma and dilutional coagulopathy. Okay. It is also very important to understand that the coagulopathy of trauma is multifactorial, and there are 3 things which actually make the coagulopathy worse, and you need to take care of all of that when you're dealing with a trauma patient. So you've got a coagulopathy of trauma, and if you've got acidosis, and that's usually because of hypoperfusion and because of hypovolemia and shock, and hypothermia, and this is called the vicious triad or the bloody vicious cycle of trauma. Got bleeding, and the coagulopathy makes the patient bleed. You give the patient bleeds, he becomes hypovolemic, he becomes acidotic, he's exposed, he gets hypothermia. You give lots of fluid, which doesn't contain coagulation factors, and you get a coagulopathy. So it becomes a vicious cycle, and that makes the coagulopathy worse. So we need to break this cycle. And there is now this concept in trauma of what we call as hemostatic resuscitation. And this recognizes the fact that coagulopathy may already be present in trauma when the patient presents to the emergency department and can worsen rapidly. And what you need to do is early platelet and FFP transfusion along with packed red cells. So you now give these in a ratio of 1:1:1. In the past, we used to say first give 4 to 6 RBCs, then you give 1 to a couple of FFPs. After you've given 2 rounds of this, then you give 1 platelet. But now it is suggested that you should, in patients with massive polytrauma, massive trauma, and massive transfusion, you should give platelets, FFP, and RBCs in a ratio of 1:1:1. And based on the CRASH 2 trial, these patients should also receive tranexamic acid, 1 gram over 10 minutes, and then 1 gram IV infusion over 8 hours. So this is hemostatic resuscitation, which can save patients with trauma from exsanguinating till you get them into the OT and get control of the bleeding. Okay. Some patients who got ongoing hemorrhage, in spite of all this, will continue to bleed. And these patients sometimes do very well with activated factor 7 or Novo 7, as Dr. Ria pointed out in the last previous lecture. So again, Novo 7 will work best if you got at least some platelets, some control of the coagulopathy, and this will really enhance the clotting, and it's life-saving in many, many situations. We now go on to the coagulopathy of liver disease, right? And liver disease is, and chronic liver disease especially, is a condition where your vitamin K, all your coagulation factors are reduced, and especially your vitamin K dependent factors are reduced. So you will get, in chronic liver disease, you get an increase in the prothrombin time, right? Now, unlike in patients who receive vitamin warfarin, right, increased INR or increased prothrombin time predicts that the patient will bleed. In patients with liver disease, chronic liver disease, the high INR tells you that your coagulation factors are reduced, but we also need to understand that in the liver not only synthesizes coagulation factors, it also synthesizes anticoagulant factors, right? And in chronic, so these are the anticoagulants which actually prevent the blood from clotting excessively, right? Like protein, and every time there's an activation of coagulation, at some stage there is activation of anticoagulation to make sure that there is no excessive clotting, and the balance between coagulation and anticoagulants, fine balance is maintained in the body. So the patient remains in good hemostatic homeostasis, right? So as you can call it. So the liver synthesizes the coagulation factor. It also synthesizes anticoagulants. We are measuring by the INR. We know that the coagulation factors are reduced, but at the same time, the anticoagulants are also reduced, right? So we don't know which way the balance is going. So unlike in warfarin, where a high INR predicts bleeding, in liver disease, a high INR does not necessarily predict high risk of bleeding, because your anticoagulants also reduced. And in fact, some patients with chronic liver disease may be at risk of thrombosis rather than hemorrhage. Just need to keep that in mind when you're dealing with patients with chronic liver disease, right? So like I said, the INR will tell you that the procoagulants are reduced, but we are not doing anything to measure the anticoagulants, and balance between them, we are not very sure. And one very good way of knowing what's happening is to go thromboelastogram. The thromboelastogram will tell you what is the overall thing. And we've seen in patients with chronic liver disease that patients are actually hypercoagulable, and so you need to keep that in mind. The other sort of condition affecting the liver is obstructive jaundice, and here it's very straightforward. Vitamin K is not presented to the gut because of biliary obstruction, and therefore there is a deficiency of vitamin K, and that leads to reductions in the vitamin K dependent factors 2, 7, 9, 10. And a simple treatment of this is to give vitamin K for 3 days. Right? And once you give vitamin K for 3 days, you restore the vitamin K levels, and the coagulability, high INR level, becomes normal. Okay, so you just need to keep in mind that in obstructive jaundice, there are many other things that you need to worry about, but as far as coagulation is concerned, vitamin K is good enough. If the INR doesn't come up, or if there is then or you want to do urgent surgery, then FFP can be given to take care of this problem. In chronic renal disease, you can get a coagulopathy. It presents as platelet dysfunction, but it's often due to a reduction in 1 Willebrand factor, and that reduces platelet function, right? And the way to get 1 Willebrand factor up, one is of course FFP or but a simple way is to give DDA, desmopressin, 0.3 milligram per kilo IV if the bleeding time is prolonged. And DDAVP or desmopressin in this dose, not the dose that you use for after neurosurgery or after pituitary surgery, to get your AV, to get vasopressin levels up. But this is for antidiuretic hormone, but this is for to increase the 1 Willebrand factor, 0.3 milligram per kilo for improves platelet function and Wallbrand factor levels in renal failure. And finally, the last case is a male who's had a resection anastomosis of his gut a few days ago, but now he's sick, he's febrile, he's hypotensive, he's tachypnic, he's got shadows on his lung, and he's got a leak from that anastomosis. So this patient obviously has septic shock. He's got low platelets, his INR and APTT are both high, and he needs a laparotomy to take care of his leak. And this patient is of course very sick, and he's probably got a DIC. Right now, disseminated intravascular coagulation is also a funny sort of thing. You can, because of the sepsis, you've got consumption of coagulation factors and platelets, and that leads to hemorrhage. At the same time, you've got fibrin deposition. The sepsis leads to fibrin deposition in the microcirculation, and that causes microvascular thrombosis, and that leads to organ failure. So on one hand, you've got hemorrhage. On the other hand, you've got microvascular thrombosis leading to organ failure, right? And the fibrolysis of these clots leads to rise in FDP, fibrin degradation product. So in DIC, you've got low platelets, low fibrinogen, because that's consumed, platelets are consumed, low coagulation factors, they are consumed, and you've got a high fibrin degradation products because the intravascular clots are being lysed by the body, and therefore you've got a rise in FDP. So you've got low platelets, high APDT, high INR, and low fibrinogen and high FDPs. And we don't know which way the balance is. Again, the thromboelastogram helps you very well, but it's important to understand that unless you take this patient up for surgery, his sepsis is not going to get better and his DIC is not going to get better. So you need to give him FFP, support the factors which will stop the bleeding, right? Give him support with those factors and go ahead with the surgery and hope for the best. Okay, so that is the management of DIC. You have to treat the cause with source control, that's exploration, sealing the leak, or washing out the abdomen, antibiotics, good supportive care, and coagulation support. Some people think that heparin may work for the thrombosis which is going on, but that is very, very controversial, and it's could be go one way or the other. Antifibrinolytics are, because the FTPs are high, but that's a protective mechanism of the body. So unless your TEG suggests that there's excessive fibrolysis, I don't think you should sort of give antifibrinolytics to patient in DIC unless there is a strong sort of test which suggests that. Okay, so I think I've finished what I wanted to say. Again, I'd just like to reiterate that, that acquired defects in coagulation often occur in the setting of other serious illnesses, and we must optimize. So optimization of coagulopathy is important, but optimization of underlying illness is vital. They may often undergo elective surgery. Have a good consultation with your hematologist, and have a good consultation and link up with your transfusion medicine department and blood bank. So thank you very much for inviting me, and thank you very much for listening, and I'll be happy to take questions.
Dr. Jiggy sir, thank you very much for sharing your thoughts and all. But the only thing is we can only discuss, there are so many questions are there. We have this session, question answer session at 12:15, sir. So we can have a cup of coffee or tea in between, or maybe we can go through WhatsApp and we'll meet you at 12:50. But thanks for raising the question. But I request the organizer, sir, with your permission, please save all these recordings, what the lectures are being said, and maybe it's very useful, not only for postgraduates, the practitioners like us also, newer trends, newer medication. I request the organizers, please save all this lectures and the questions answered. If you cannot answer the session, please make sure the concerned speaker is asked about whatever doubts the delegates had. That way, the continuity, it makes sense. I hope Dr. Jiggy sir agrees with my thoughts.
Sure, sir. Absolutely, sir. Thank you.
Over to you, back to organizers. Thank you so much.
Yes, sir. Yes. Sure. So we are recording the entire session, sir. And sir, we do have certain questions in chat box. So we are ready to discuss it now, sir.
If you're out, sir.
If you're.
It's okay. It's your call. You're the organizer. We are just here to support.
Yes, sir. We will continue with the question.
Question, sir. So first question from Dr. Jayashree Sen ma'am is, sir, the question is, the patient of TBI with hemorrhagic transformation should receive anticoagulation and post how many hours of the surgery?
So if you've got TBI with hemorrhagic conzo, I don't think you should give anticoagulation. Now I presume that madam is asking about prophylactic dose of low molecular weight heparin, and maybe you need to wait for 24 hours before you give prophylaxis for DVT using a low molecular weight heparin. If the patient is sick and is not neurological state is not good, I think this patient should not get a low molecular weight heparin. In fact, this patient is better off getting mechanical thromboprophylaxis with a calf compression pump device, pneumatic calf compression pump device.
One more question, I believe. Sir, can you hear me?
Yes, I can.
Yeah, first of all, I must introduce myself. I am Dr. Jayashree Sen. I had been with you as a co-judge in the Bangalore, Bangalore conference. I wonder if you can remember me. I was there in the postgraduate students paper presentation competition. I was with them. And
Yes,
I'm happy, I'm grateful to the organizing committee that I have been given a platform to share with Dr. Muralidhar Joshi to all world of anesthesia. And also sharing this session, being a chairperson with you, sir, the drawing of anesthesia. I think there is another question. The question actually has come from a dear MD student, he's in Bombay Hospital. And he has another question, like in a patient receiving thrombolysis, for acute ischemic infarct, when should be the invasive lines be started post-surgery, post-infarct? A patient has come for patient receiving thrombolysis for acute ischemic infarct. When should invasive lines be performed post-infarct?
It's a difficult question to answer. I mean, I would say that you put an invasive line, like say a central line, only if it's absolutely required, and in a large number of patients we can get away without any central lines in many of these cases. I assume we are talking of a brain infarct, right? Acute ischemic infarct, myocardial infarction, or a stroke. Yeah. So most of them should not require unless they have other complications. And I guess again, you can do a thrombin time, or you can do a thromboelastogram and decide what is the best period to sort of do it. But at least for 6 to 12 hours, I don't think you should even think of putting in an invasive line, and be guided by a thromboelastogram or something before you go ahead with any of these things.
Okay, sir, thank you so much. I'm very grateful that you have enlightened us with your knowledge and wisdom so profusely. Okay, sir. Thank you so much. Any other question? Any other question? There is another question, sir, from Snehal Naik. She has written that the CA ovary patient, post-operative peritonitis perforation, to continue thrombocytopenia, recovering from sepsis, and no complications of thrombocytopenia, what should be the management?
Yeah. So I think you're lucky your patient is doing quite well. So I think you just keep your fingers crossed. If you are asking whether we should transfuse platelets for a platelet count of 30,000, I think if there is no bleeding and you're not contemplating any further procedures, you should just wait and not do anything. Your patient seems to be doing quite well and recovering. I would expect the platelet count to come up in a couple of days. You should be on the lookout for further, sepsis somewhere, either from lines or whether it's from something else in the abdomen, which may still be there. So I would. So then you should just keep a lookout for that. But otherwise, I would say that keep your fingers crossed and hope for the best in this one. If, however, you're planning, say, you've done a CT and you need to put in a pigtail or drain something, then you need to give platelets to get the platelet count about 50 to 70,000. Okay, but if nothing is planned, then leave it as it is.
Another question from Dr. Pitan, that please mention the dose of PCC.
Okay, so the dose of PCC is variable, and it depends on what is your INR. Okay.
Okay.
So let me just see if I can get. So Now, this it comes as a 250 or 500 units vial. And what you need, if your INR is say 2 to 4, then your dose is 25 units per kilo. So in other words, if for a 60 kilo patient, you'll need roughly 1500 units, which means you're going to have 3 vials of 500 or 6 vials of 250. If your INR is 4 to 6, then you need 35 units per kilo. And if it's more than 6, then you need 50 units per kilo. Right? And if you don't know what is the INR with the patient, but you know the patient's been taking vitamin K, at least you start with 25 units per kilo. Right? So that's roughly what you need. So you need anywhere starting from 6 vials of 250 units upwards for your patient.
Okay, sir. Another question from Dr. Jitesh. He has written that patient is has a complaint of ISD and patient is on aspirin and Perioperative for elective abdominal surgery. Now he wants to know what test has to be done if the patient is planned for thoracic epidural. The patient is suffering from ISD or aspirin.
So this patient has ISD, he's on aspirin and clopidogrel, and he's for elective surgery. So for this patient, we would say that you stop the clopidogrel for 5 to 7 days and continue the aspirin, low dose aspirin, 75 milligrams. And then there is no need to do anything. Go ahead and give your thoracic epidural. Okay. So this is elective surgery. So you stop the clopidogrel for 5 to 7 days. And
5 to 7 days. There is one other question. The person has written a long one. I just read it out. I have done a patient 75 years old, has a diabetes mellitus history for 15 years, recently diagnosed as hypertension, hyponatremia, and fractured tibia, and opposite side IT femur. Now showing decreasing trend of platelets from 1.9 to 80,000. As the patient was being optimized for sugar control and sodium correction, what is the reason of thrombocytopenia and when we can go ahead for this surgery? A patient, 75 years old, suffering from diabetes for 15 years, is going for, it's also having hyponatremia, and after correction of sugar and sodium correction, what reason of thrombocytopenia and when the patient should go for surgery?
So essentially, you've got a patient with a femur fracture, and he is your worry is the thrombocytopenia, which has developed over the last 3 days. Right now, thrombocytopenia, and I'm just assuming that all the other coagulation tests are normal, and this is an isolated thrombocytopenia. So, there are many causes of thrombocytopenia, and in this sort of setting, one is if the patient is very often drug induced. So if the patient is on some antibiotics, then some of the antibiotics can cause thrombocytopenia. If you've got, is this patient on low molecular weight heparin or standard heparin, then you can get something like heparin induced thrombocytopenia, which can occur. You can, it could, if everything else is okay, but in a long bone fracture setting, thrombocytopenia may be an indication of fat embolism syndrome. So that's the other thing you need to keep in mind. And I would say, and infection. So these are the 3 or 4 things which you need to keep in mind at the top of, over the top of my head. Okay. Drug induced, infection, heparin induced, and as a sort of things which you should keep in mind before you sort of go ahead. I guess this will also get better eventually with time. If he's got lots of blood transfusions or something, I don't think it's been mentioned. I don't think you should be having too much any blood transfusion, but these are the sort of main things that you would keep in mind.
No end of questions for you. Another question has come from Dr. Yadav. What is the platelet transfusion trigger for post-operative neurosurgery patient?
So I think for most surgeries, you would accept about 70,000, but for neurosurgery, I guess about 1 lakh would be a good sort of target. So you would like to keep your platelets minimum 75,000, but preferably 1 lakh.
Okay, sir, this is the end of questions for now. Later some questions will come again. And I thank you so much for your kind presence and giving us your valuable time.
Thank you, madam. And I'll be happy to be there at 12 o'clock.
Thank you so much, sir, for your valuable sapience on this topic, sir. I now request Dr. Jayashree Sen ma'am to introduce Dr. Sheetal Dalal ma'am for the second segment of this session.
Dr. Sheetal Dalal ma'am, she has quite a, a decorative academician. Her present attachment is an associate professor of anesthesiology in Jnmc Nagpur. She is a recognized postgraduate teacher in Maharashtra University of Health Sciences Nursing since 2008. She has achieved a lot of awards and accolades in different presidential appreciation award, best proficiency award, best first public awareness award, and so on and so forth, a lot of things. And she's presently, she was a secretary in ISA Nagpur City branch. She was faculty, delivered lectures in national and state conferences. She presented paper and poster at various national and state conferences. And she had so many publications in national and international indexed journals and instrumental in starting CPCR activity on a mass scale. With this short introduction of Dr. Dalal, I request you please enlighten us with your representation. We will be happy to listen to you. Dr. Dalal, please.
Good morning, everyone. Aditi, can you give me the video presentation? Actually, I was an honorable president duty, but the president duty is cancelled just now at Nagpur, so I have given the video presentation.
Yes, ma'am. We will display the presentation.
Till then, respected Chairperson Dr. Muralidhar Joshi sir, very good morning. Then Dr. Diwatiya sir, honored to be part of this CME.
Nice to hear, Dr. Sheetal. Nice, a lot of work you're doing the session and other things.
Yeah.
Presentation goes on. I do understand. Please go ahead. Please go ahead. All the best. Don't worry, technical glitches. Don't worry about that. But thanks to my ISA for your great efforts.
Thank you, sir. I am honored to be part of National Task Force Against COVID-19.
We are grateful to you for your services and all of you. I can't say person A, person B, but I'm just hoping that we have more physical meetings.
Yeah.
But this is a very good topic. I request organizers.
I have missed you in my conference.
No, we'll join. Don't worry. We are not away from Nagpur.
Yeah.
Just 1.5 hour flight. Don't worry.
Any problem, organizers?
Technical. Don't worry. Just take it easy.
Ma'am, we are ready to start, ma'am.
Okay.
तो म्यूट होता जी सर.
Go from first slide. Some problem with the sound.
You please continue, sir. Continue, ma'am.
Otherwise, I will share my screen.
You are audible.
There is no sound.
Yes, ma'am, we are looking into it. ma'am.
But we can, she cannot use.
नहीं है अभी।
Madam, are you audible? Are we audible?
Not yet.
I can share my screen, sir.
We can hear you, madam.
Share video off you have written. What is his screen?
You can video.
Or is
There
let
is
madam, let madam present, no? Let madam
Yeah, I
present.
can present, sir.
Yeah, madam can present. You can cut off this one and let madam present on her own. That might be
Yes, sir.
idea.
Yes, sir.
It's okay. It's okay. Small things. Don't worry about it.
I can share my screen.
Don't worry. Don't. Small things. Don't worry.
Can we see?
Your video is okay, madam.
Not yet. Not yet. Rakshita.
Ma'am, your video is
Not
coming,
yet.
ma'am, but this screen has been not shared, ma'am.
You have to screen. Not yet. Don't
Some
worry.
problem is occurring.
No. Don't worry. Don't worry. Relax. Relax. Don't panic. Keep it done. Don't worry.
Can again log in? I can log in again.
Hello, ma'am.
Some problem is occurring.
Hello, ma'am. Oh, ma'am. Ma'am, we can share the screen from our side, and if you don't mind, you can continue with the audio, ma'am.
Yeah, that will be ideal. That will be ideal, Dr. Kapil. That will be ideal.
Yes, Kapil, please do it.
Yes, sir.
Madam, we will share the slide. You continue your
And you can always
presentation.
next one slide will move on. Don't worry, madam. Sheetal, don't worry. Don't worry.
Hi.
Just put the slides and you can speak on that slide.
Yes, sir. Sharing the screen. Right
Some
now.
problem with my Zoom.
Don't
I
worry.
think.
Don't worry. Don't worry.
Sir, 1 minute. I will log out. Then again I will log.
No. Don't do it. Don't do it. It's running a live session. Don't do it. Don't do it. You're on live. Kapil, please go ahead. Kapil, please go ahead.
1 minute. Yeah.
Perfect. 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 Sheetal, are you there?
Yeah, I am there.
Please go ahead, ma'am. Please go ahead.
But I
You can just say next, they'll move on the slide. Simple.
1 minute. I can't see anything, sir, in my desktop.
Kapil, can you help them?
Ma'am, I'm sharing the screen on the.
All of us are seeing.
Okay. I will go with another.
We're all seeing you.
Yeah.
Ma'am, are you able to see your presentation on the
1
screen?
minute. Am I audible?
Yes,
Good morning,
ma'am.
everyone. Respected chairperson.
Yes.
Actually, at the onset, I would like to thank the organizer for giving me this opportunity to share this platform, a wonderful CME on the perioperative management of coagulopathy. So since last 2 years, we are dealing with the most disastrous COVID pandemic, and we have already seen the first, second, and third wave. Being working as a COVID 650 bedded COVID dedicated hospital at Nagpur, I have seen the most dangerous, which is the center of EPIC at Nagpur, second wave. And we are getting lot many post-COVID patients. We had in abnormal coagulation profile. And so the today's topic of my presentation is assessment of post-COVID patient for coagulation profile for the planned surgery. The first question, really the COVID pandemic affect the coagulation, your coagulation profile or not? So coming to the next slide, please. Coming to the pathophysiology of the COVID-19. First, there is a invasion to the virus or viral invasion to the host cell AC inhibitor and transmembrane protease serine 2. So there is an active replication and viral release and causing perioperative, that is a viral entry and early infection. After that, there is a host immune response in which there is a DAMP and PAMP recognition. The pro-inflammatory cytokinase and chemokinase release is there, and there is a recruitment of microcyte, macrophages, and virus-specific T cells, which causes the elimination of infected cells. So this is a physiological host response for everyone, which consists of early phase and late phase. After that, there is a transition from mild to severe COVID-19, which causes, in which there are two phases. First is hyperinflammatory phase and then multi-organ dysfunction. So in the hyperinflammatory phase, there is an excessive infiltration of the immune cell in the lungs and the systemic overproduction of the pro-inflammatory cytokines like IL-6, IL-10, interferon, and there is an aberrant irregulation. And after that, there is a extrapulmonary organ involvement, and due to this pro-inflammatory cytokinin and aberrant regulation, which leads to cytokine storm, and there is endothelial dysfunction, which causes the vascular damage, and there is a disturbed flow. And this may cause the which is responsible for the extrapulmonary organ involvement and activation of the procoagulant response. So here the all the systems are involved in this COVID-19, specifically in the active phase, and their sequelae is always remains in the post-COVID phase. Next slide, please. Next slide. Next. Next. Next slide. It is well understood that the inflammation can activate the coagulation cascade by several mechanics. This may be possible on the basis of the cases as significantly higher D-dimer levels, fibrin degradation products, and elevated PT and PTT, a condition in which blood clots from throughout the body and thrombosis. It is thus essential to realize the systemic inflammation and the coagulation system in combination can play a crucial role in overall mortality associated with the SARS-CoV-2. So next slide. Next slide. Am I audible? Hello?
Yes, ma'am, you're audible now.
Next slide, next slide. So what are the prominent changes that occur in the hematological and coagulation system? So its pathogenesis is related to the inflammation and the cytokine release. The immunothrombosis is a phenomenon known to occur as a result of host defense against various pathogens. So procoagulant response is also associated with the inflammatory effect of cytokines in the vascular endothelium, including the increased vascular permeability and damage as a result of immune cell infiltration. So there is a correlation of IL-6 level with the increased fibrinogen and a D-dimer in severe COVID-19 patients. It is likely that the cytokine-mediated procoagulant changes are partially responsible for the specific thrombile which occurs in critically ill patient in COVID-19. So presence of NET are also possibly linked to COVID-19 thrombosis by activation of intrinsic coagulation. And it was well evident that we are experiencing since 2 hours the loss of oxygen transfer capacity of hemoglobin and impaired gas exchange in the alveoli with the microthumbi can explain this. So we have used the timely anticoagulant therapy and prone progesterone for the better prognosis of COVID-19. And this improves the ventilation perfusion ratio by changing the vascular flow and disruption in the pulmonary vessels, and not by the recruitment as we have seen in the ARDS. So this evidence is enough to prove there is a close correlation between the inflammatory and coagulation response of COVID-19. So when there is one study that they are compared the non-survivors to the survivors in COVID-19 related, there is a significantly higher level of fibrin related markers and fibrogen degradation products. There is longer prothrombin time at admission, while lower fibrinogen levels and antithrombin activity at the end of hospitalization. Moreover, 71.1% of the non-survivors, as when compared to 0.6% of survivors, match the criteria that DIC in the latter stage of pneumonia, according to the International Society on Thrombosis and Hemostasis. So what about the platelets? The organizer is very keen. Madam, lots many patients are coming with thrombocytopenia in the post-COVID area for the elective surgery. So how the platelets are affected? The thrombocytopenia is detected in 41%, 5 to 41% of COVID-19 patients, and the incidence is varied, of course, according to the severity. Then mild thrombocytopenia is present almost 58 to 95% of severe COVID cases. In fact, such severely ill patient with systemic immune and coagulation activation maintain the reasonable platelet count implies the marked coagulability and compensatory platelet production response. So severe thrombocytopenia is very rarely reported in COVID-19 patient, for instance, in association with the immune thrombocytopenic purpura-like state. So what will the causes? There are 4 causes. First, the cytokine storm. There is a bone marrow progenitor of the cells are destroyed, and this causes the reduction in primary platelet production. Second cause is directly infect hematopoietic system and bone marrow stromal cells. Then there is an immune response, that is increase of antibodies and immune complexes. And fourth, of course, the lung injury. There is a decreased level of the circulating platelets. So what about the von Willebrand factor? The activated and damaged endothelial cell release. Next slide. The activated and damaged endothelial cell release, they are Willebrand bodies containing ultra-large molecular weight multimers of von Willebrand factor. The ultra-large, these can spontaneously blind the platelets and lead to microthrombosis. So there is a significant elevated levels of this factor in COVID-19. So what about the coagulation? This is very important. The COVID-19 coagulopathy is somewhat similar to the sepsis-induced DIC, which typically present with the suppressed fibrinolysis. However, as compared to sepsis-associated DIC, D-dimers level are typically more significantly elevated in COVID-19 patients. Then what about the L30 measurement during COVID-19 can be seen to imply the fibrinolytic shutdown. The very low LY TEG values, that is a TEG values at 30 minutes. That is a lysis values at 30-minute measurement for this patient reveal an absence of elevated in vitro fibrinolysis. There is a marked elevation of D-dimer in COVID-19 appears to reflect the coagulation activation from viremia and the cytokine zone. So there is also the fibrinogen degradation project is increased. D-dimers and FDP progressively increase with COVID-19 severity, but the fibrinogen level stayed elevated. So the COVID-19 coagulopathy can often meet the criteria that relatively newly defined entity of sepsis-induced coagulation, which is defined and quantified according to the reduced platelet count, increased INR, and high organ dysfunction score. The COVID-19 coagulopathy represents the combination of localized pulmonary platelet consumption, low-grade DIC, and the variably thrombotic microangiopathy. There is an elevated level of von Willebrand factor, which are already told, and the soluble thrombomolybdenum imply activated and damaged endothelium. Then elevated soluble P-selectin levels and platelet flow cytometric studies suggest the increased activation of endothelium and the circulating platelet in the patient. So in nutshell, the COVID-19 result in the hypercoagulable state and thrombotic event can occur during acute illness and convalescence. The most common hemostatic abnormality in COVID-19 include mild thrombocytopenia, increased D-dimers level, prolongation of prothrombin time, international INR is also increased, then thrombin time and shortened activated partial thromboplastin time. So that's why there is a need of anticoagulant therapy in the which we have used in this patient according to the severity of the disease. So what are the mechanism of anti-inflammatory anticoagulant? We have used both in for this patient, antiplatelet agent as well as anticoagulant. So this anticoagulant present directly has an antiviral effect, and it causes the anti-inflammatory activity attenuating the NF-kB and IL-6 pathways. Then antiplatelet, they are also rampantly used in this patient, and these acts by anti-inflammatory response, and they also impair the virus propagation. So these are the anticoagulant and antiplatelet we are used. But we have all known the aspirin is the maybe misused in mild patient, but it has been used up to 2 months. The patient is given the aspirin, and the patient who was admitted in the ICU, they have given the low molecular weight heparin and unfractionated heparin. And again, the DOC which is used in the COVID-19, that is the rivaroxaban. So what should be the preoperative assessment of this post-COVID patient scheduled for planned elective surgery for coagulation? So there should be a consideration of post-viral. Next slide. Next slide. Next. 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 Next slide. So the aim should be consideration of post-viral syndrome and sequelae should be taken account while evaluating the patient for planned surgery. The timing of elective surgery should be decided. The optimal timing of elective surgery after recovery from COVID-19 must be decided after taking account of the symptoms, the disease severity and presence of post-COVID-19, and the multi-organ dysfunction and drug use for COVID-19 management that can affect perioperative outcome. Next slide, please. So the American Society of Anesthesiologists and Anesthesia Patient Safety Foundation advise the COVID-19 patient wait for the few weeks after recovery from non-urgent or elective surgery. So our Indian Society of Anesthesiologists have come up with the ISA advisory, and this is the ISA advisory which I have mentioned. What should be the exact time the patient should be posted for the elective surgery? Next slide. So in pre-diagnostic evaluation, the assessment of sequelae of SARS-CoV-2 infection on various organ systems for optimization and to find out if the patient is on medication which could influence the peri-anesthetic events. So apart from the proper history and physical examination, including the functional assessment and mandated investigation along with the meticulous documentation. The objective tests that evaluate the cardiopulmonary and nutritional status, renal and liver function, coagulant system, and the inflammatory markers may be performed. The test can be chosen based on the degree of index illness, ASA physical status of the patient, and the nature of planned surgical procedures. Next. So these are the investigation which to be done according to the procedure, whether it is minor, intermediate, or major procedures, and according to the pre-history of the severity of disease, whether the COVID patient is asymptomatic, symptomatic, then is he admitted in the ICU, does the ventilator therapy he has received. So why there is a need of coagulation pre-operative assessment, especially in the post-COVID patient. So as we know, there is a hypercoagulable state. So duration of COVID-induced prothrombus state is still known. So some literature says the patient with mild thrombocytopenia, the antithrombotic therapy again carried risk of the bleeding, that is increased thromboembolic risk at least 1 month from the time of normalization of the PCR, and the higher thromboembolic risk in the patient with moderate or severe COVID-19 infection. Especially in the critical ill patient, the chance, next slide. The chances of large vessel ischemic stroke and acute embolic claim up to the 7 days. But as we have this is a literature says, and there is always elevated and compound risk of either thrombosis or excessive bleeding when the patient is on antithrombotic therapy. But what we have seen clinically when we are dealing with the patient, we have seen that there is an increased chances of CVD even up to the 120 days of post-COVID diagnosis. So patient not on anticoagulant therapy, a preoperative D-dimer measurement. Next slide, please. Patient not on anticoagulant therapy, a preoperative D-dimer measurement or venous ultrasound for thrombosis should be considered. If a deep vein thrombosis is identified on ultrasound, anticoagulants such as heparin can be administered in addition to the prophylactic compression. As an additional consideration, ICU survivors may be thrombosed or injured arteries that were cannulated previously for monitoring. Therefore, intraoperative ultrasonographic examination before new instrumentation is advised. Then non-oncological surgery should be deferred at least 1 month from the time of PCR normalization. Then the Divatia sir has very well talked about the pharmacological as well as mechanical thromboprophylaxis. So pharmacological thromboprophylaxis dosing should be increased over standard prophylaxis to an intermediate dose. Finally, mechanical thromboprophylaxis could be an option for increasing thromboprophylaxis being used in addition to the pharmacological thromboprophylaxis up to the ambulation. So next slide, please. Preoperative coagulation profile should be done, that is PT-INR and activate partial thromboplastic type. In addition, if the patient is on direct anticoagulant, the usual coagulation rate does not quantitatively or qualitatively measures the effect of DOC. If the type interval is less than 72 hours, the serum direct anticoagulant level or quantitative anti-factor 10th assay is required. Whenever in doubt, or if facility exists, thromboelastograph or thromboelastomer can reliably provide the exact coagulation status of the patient in the perioperative period. Next slide. The cessation of therapy should be addressed pre-operatively to consider the risks and benefits. However, post-operatively, health medication promptly should be restarted. For acute warfarin reversal, prothrombin complex concentrate can be considered if intravascular volume is of concern. Rivaroxaban and epizoxaban now can be reversed acutely with andexanet alpha. And what about dabigatran can be reversed with idarucizumab, what sir has said. And sir has said it is easily available in India, but I have not used it. So what should be a perioperative management of antithrombotic and antiplatelet agent in COVID-19, especially in post-COVID patient. So this recovered patient may be on antiplatelet agent, then clopidogrel, prasugrel or ticagrelor or ticlopidine, then on low molecular weight heparin or unfractionated heparin, then factor 10A inhibitors such as fondaparinux, then direct anticoagulant such as betrizapam, rivaroxaban, then epizaban and dabigatran. Next slide. So low dose aspirin, there is no question. You can continue with the low dose aspirin. The precaution should be taken unless the patient presents for eye, prostate or neurosurgery. For the patient with high risk of cardiac events, clopidogrel or prasugrel is discontinued 5 days preoperatively and is resumed 24 hours postoperatively. For the patient who has low risk cardiac event, dual antiplatelet therapy is stopped 7 to 10 days preoperatively and it should be resumed 24 hours postoperatively. For those with coronary stent, dual antiplatelet therapy, including aspirin and clopidogrel, is continued perioperatively if surgery cannot be postponed. For the patient taking once daily dose of LMWH, it is prudent to interview at least 12 hours after the last dose and restart 24 hours after surgery. Next slide, please. However, if the dose is twice daily or if the patient is on factor 10A inhibitor, one should wait for at least 24 hours before any intervention. There is a need to check for heparin-induced thrombocytopenia in patients on more than 4 days of unfractionated heparin therapy. Then direct anticoagulant should be ideally discontinued 24 to 48 hours prior to surgery, depending on the risk of bleeding in the surgical procedure. they must be discontinued minimum 72 hours prior to the neuroaxial technique. A problem with the newer DOSC is that antidotes, although present, but are not easily available. Next slide. In case of abnormal coagulation profile, or if there is an increased bleeding is observed, the most reasonable solution is the fresh frozen plasma. Then we are now routinely using tranexamic acid, then antifibrinolytic, especially in the patient with orthopedic surgery, gynecologic surgery, and the cardiac. So what about this agent? So we are not recommended this agent, especially used in post-surgical patient. We have seen lot of their effects, especially in patient in mucormycosis, which they have come to us in the after second wave. The use of such agent may further promote the thrombosis by inhibiting fibrinolysis with disaster results. Next slide. Then what about regional anesthesia in patient on anticoagulation, especially in the post-COVID patient? If the procedure is emergent, the patient should not receive regional anesthesia. Incidence of spinal hematoma is increased in the cases of when the regional anesthesia is attempted. Be cautious during labor epidural analgesia and anesthesia in post-COVID obstetric patients. The anesthesiologist must remain cognizant for the standard contraindication to neuroaxial procedures, including severe thrombocytopenia and the result use of the anticoagulants in COVID-19 positive patient. You can give the regional anesthesia if your platelet count is more than 75,000. So the specific medication and the timing of the last dose of antithrombotic medication are the vital for planning neuroaxial and deep perineural procedures. So the recommended minimal time interval between the agent administration and the neuroaxial puncture, catheter removal, before puncture, oblique removal, or after puncture and catheter manipulation or removal is as follows. With the prophylactically and therapeutically unfractionated heparin, it is 4 to 6 hours, then and removal is 1 hour. For LMWH, it is 12 to 4 hours. For therapeutic LMWH, it is 24 hours, then 4 hours. Honda Perinax is 36 to 42 hours, then 6 to 12 hours. Rivaroxaban, it is 22 to 30 hours and 6 hours. And dabigatran, it is 5 days or 6 hours. The experience with the dabigatran and neuroaxial anesthesia is still limited. Next slide. The recommended time interval between the discontinuation of antiplatelet agent and the neuroaxial procedure is as follows. So with clopidogrel or tigradol, it is 5 to 7 days. Pasugrel, it is 7 to 10 days. Ticlopidine, it is 10 days. And cangrelol, it is 3 hours. They can be resumed 6 hours after the puncture or catheter removal. All the drugs are contraindicated with the catheter influence. So to conclude, especially in the post-COVID patient, the pre-anesthetic assessment should be primary aim for the assessment of the functional status of the patient, the assessment for the sequelae of the COVID-19 from various organs and their optimization. And if the patient is on any medication, especially the antithrombotic therapy, which could influence your pre-anesthetic events, especially the thrombotic events, either bleeding or the CV. Then the objective test should be done evaluating the coagulation system and inflammatory markers. There is always compound risk of either thrombosis or excessive bleeding, and the anesthetic consideration should be followed taking account the perioperative sequelae. So, thank you to the ISA advisory. I'm proud to be a part of ISA National Task Force COVID-19 as a clinical coordinator and the PPE-clad COVID warrior, which we are working since 2 years, and hats off to all of you. So this is the ISA advisory, that is a perioperative management of post-COVID-19 surgical patient by Indian Society of Anesthesiologists. Thank you very much. अभी ऑपरेशन नेक्स्ट स्लाइड, अभी ऑपरेशन थिएटर रणभूमि है. अगर वहां का योद्धा अर्जुन सर्जन है तो रणभूमि में लेके जाने वाला, सही राह दिखाने वाला, विपत्ति के समय का एकमेव साथी सखा, सारथी श्री कृष्ण एनेस्थेसियोलॉजिस्ट है. एंड द कोविड पैंडेमिक जस्ट प्रूवन दिस. थैंक यू.
Madam, thank you so much, Dr. Dalal. Such a vivid presentation, and so the presentation is so enlightened one. So may I put the questions, ma'am, which is come in the chat box?
Okay, you can ask.
Okay. Dr. Purnima has asked a question that, Madam, can you please explain about the donor screening for convalescent plasma therapy?
What?
And how long should the donor wait? The donor for plasma therapy. Madam, can you hear?
No, ma'am, I am not hearing. Hello? About plasma therapy. Hello? Hello?
Can you listen? Can you hear me?
Yeah, yes, ma'am. What is the question?
The question was about the donor screening for convalescent plasma therapy. And
Donor
how long
screening
the
for
donor
convalescent
should wait after post-COVID recovery period for donation of plasma.
Convalescent plasma is given in acute phase, no, ma'am?
Yeah, plasma therapy.
Yeah, here we are dealing with the post-COVID patient. We are giving the convalescent plasma in the acute phase. There is no use if the acute phase of whenever patient is admitted in the ICU. That is the indication of the convalescent plasma.
Yeah, but how long has the donor wait?
After post-COVID.
Yeah.
That I don't know.
Okay, ma'am. There's another question that is, what is LY30 and how it is related to D-dimer measurement?
LY30 is a TEG. Actually, it is a LY30 is a TEG measurement at 30 minutes. Yeah, it is a thromboelastogram finding. So if it is a low, so there is a thrombocytopenia is present, and there are more chances of clot formation is there.
Okay.
And if it is increased, so there is a mainly DIC phase.
Okay. And how it is related to D-dimer measurement?
There is always increased elevated levels of D-dimers in this. Thrombocytopenia, there is increased INR, then PTT is increased in this. If LY30 is, it is measured by a percentage, ma'am.
Is measured in percentage. Okay, another question is, any changes in doing compulsory RT-PCR and COVID-19 testing for elective surgery with current COVID status in India?
Actually, what the advisory says, the up to 90 days. If the patient is post-COVID, up to 90 days, we don't, even up to 120 days, we don't have to do the post. But we are doing, ma'am, regularly. We are actually, I am working in the institution. We are doing this test preoperatively regularly. But since 1 month, the third wave is very, it is not so severe in our at Nagpur. So since 1 month, we are not doing it unless and until it is indicated and there are the symptoms of which is related to COVID for elective surgery.
If there is any symptom, then it's, the test has been done. If there is no symptom for 1 month,
no.
Not even the RAT test, not even the rapid antigen. Okay, ma'am.
We are not, nowadays we are not doing. But for I am working at ENT surgery and they are more dealing with the oral surgeries. So actually for our safety, we are doing in our own.
Yeah.
Because it is easily available in our institute.
Okay, ma'am. Any more questions?
Sorry for interruption on my side.
No, it's okay. It's all technical things, you know. So these things can happen. And I thank you so much for giving your valuable time and enlightening us with such, vivid knowledge and all.
Thank you.
And the students are very happy with your speech.
Thank you.
Okay. Thank you so
much, ma'am, for that valuable insight, ma'am. I now request Dr. Jayashree Sen, ma'am, to introduce Dr. Samina Khater, ma'am, for the third segment of this session.
Yes, sir. Yeah, sure. Dr. Samina Khatib. She is a professor in anesthesiology in medical college or rural medical college Loni, and she is quite a brilliant academician. She has achieved she became first in HEC State Board Kolhapur. She is probably the third or fourth PhD anesthesiology at India level, besides being a first in MUHS Maharashtra. She has so much of achievements, awards, and accolades. She's the first one, first in so many paper presentations in competition. She has 9 papers published in national and international journals. She had won first prize in paper presentation in West Zone Anesthesia Conference held in Akola. She has received first prize for presentation of diagnosis of tuberculosis in Jnmc Milange and first prize presentation for Arch of Water from Department of Anatomy. She has won prizes for speech and quiz competitions also. She has so much of extracurricular activities, sports, celebration, competition, debates, etc. And she has been involved in different social work also. With this brief introduction of Dr. Sabina, may I please request you to go ahead with the presentation, please. Dr. Sabina, please.
Very good afternoon to all respected seniors, delegates, and all students who are attending this CME. I'll share my screen.
Good afternoon, Samina.
Yes, good afternoon, Dr. Vivek sir.
I cannot see you.
Okay, actually it was, the video was stopped by the host themselves, so that would be the reason.
Dr. Yatharth, can you share the
is my screen visible?
Ma'am, I have requested to start your video, ma'am.
Yeah.
Yes, ma'am. You're visible, ma'am.
Yeah. Thank you, everyone. Before I begin, I would like to thank the organizers, ISA Wardha and Jnmc Savangi Mege Wardha, for giving me this opportunity to be a part of this platform. It is a great privilege for me to share a platform with the great experts in our field, the who's who of anesthesia. It's a big privilege for me. Thanks to the organizers. The topic for today's discussion that has been given to me is anesthetic considerations in patients with inherited disorders of coagulation. My work has been already simplified by the previous speakers when they have explained the physiology of coagulation in great detail.
Excuse me, ma'am.
So I will, yes.
Ma'am, can I request you to please share your screen, ma'am?
Audible?
Ma'am,
Yeah, I've shared the screen.
we are unable to see your slides, ma'am. We are able to see you.
Okay. I'll just see what can be done.
Yes, ma'am.
Just a minute.
Excuse me, ma'am.
No, yes.
Ma'am, we have your PPT, ma'am. If
Yes, you can
allow,
share my
ma'am, we
yeah,
can.
that will be okay.
Yeah, we can play and then you can say, ma'am.
Yes. That will also be okay.
Thank you, ma'am. Ma'am, can we begin?
Yes, but I can't see the PPT. Shall I exit and join again? I can't see the PPT.
Ma'am, the presentation is on the screen, ma'am.
Okay, I'll start. Yes, I'll start. No, not an issue. I'll start. Yeah. So my work has already been simplified as the physiology of coagulation has already been explained in detail by the previous experts. In order to understand the inherited disorders of coagulation, we need to have an in-depth understanding of the physiology of coagulation. So instead of explaining all the details, I would just like to start with the classification of coagulation disorders. Please go to slide number 7. The coagulation disorders can be classified as disorders of hemostasis and disorders of thrombosis. Again, in the next slide, this slide shows the intrinsic pathway and common pathway and the defects in any coagulation factors that can give rise to coagulation disorders. So if there is deficiency, congenital deficiency of factor 8, then it gives rise to a condition called as hemophilia A. If there is congenital deficiency of factor 9, then it gives rise to condition that is hemophilia B. And there is another very rare condition when the factor 11 is deficient that gives rise to condition called as hemophilia C. Now, can you display slide number 9? Here we have the table displaying the inherited bleeding disorders. Hemophilia A and B, they are inherited as X-linked recessive disorders. The primary defect being the deficiency of factor 8 and 9. These are relatively more common as compared to other bleeding disorders. Hemophilia, since it is an X-linked recessive disorder, it is present in males, and carrier females give birth to the diseased males. Hemophilia C is seen in very rare. It is a very rare condition. Its inheritance is either autosomal dominant or recessive, and seen in a group of Jews in Eastern Europe. Not a very common condition. One of the most common inherited disorder of coagulation is von Willebrand's disease, with an incidence of 1 in 10,000 population. Then there are deficiencies of factor 2, 5, 7, 10, and 13. The incidence of these factor deficiency is very, very rare, with incidence of 1 case in a million population. Then there are conditions such as dysfibrinogenemia and hypofibrinogenemia. The incidence of this disorder is also very rare. Now we have next is the inherited bleeding disorders related to platelets. They are congenital platelet production defects. The conditions are congenital hypoplastic thrombocytopenia with absent radii. It is autosomal recessive condition. We have conditions such as Wiskott-Aldrich syndrome. It is an X-linked disorder. There can be associated eczema and immune problems. Then we have conditions like Alport syndrome, Glanzmann's disease, and Bernard-Solier disease. These are also very rare conditions. Then we have inherited thrombophilias. Inherited thrombophilias are related to overactivity of coagulant system, and I will come to this later on again. Then von Willebrand's disease I will I would like to say that I will be discussing two conditions in detail: von Willebrand's disease and hemophilias. I'll be describing in detail, and I will talk about the other rare inherited disorders in short, and also I would cover the inherited thrombophilias in the end. So first, coming to von Willebrand's disease, this is the most common inherited coagulopathy with incidence of only 1%. It is an autosomal dominant condition, inheritance, and in this disease there is a quantitative or qualitative deficiency of von Willebrand factor. Now, what is von Willebrand factor? It is a plasma glycoprotein produced in megakaryocytes and endothelial cells, and it plays an important role in primary hemostasis by causing platelet aggregation and adhesion to the site of vascular injury. It also binds and stabilizes factor 8 in blood. Hence, it acts as a carrier molecule for factor 8. Next slide. We have various subtypes of von Willebrand's disease. The main types are type 1, type 2, and type 3. Type 1 is the commonest form of the disease, accounting for 75% of all cases. In this, there is quantitative deficiency of von Willebrand factor, and the levels range from 10 to 40% of the normal. In type 2, the levels may be normal, but the quality of the factor is, there is some defect in the quality of the von Willebrand factor. In this, we have 4 subtypes. And in type 3, there is complete or near complete absence of von Willebrand factor to less than 10% of the normal levels. Now, I will describe in short the subtypes of von Willebrand's disease. In type 2A, there is decrease in the large von Willebrand multimers and decreased affinity to platelets and decreased platelet dependent von Willebrand functions. In type 2B, there is abnormal affinity and increased platelet dependent functions of von Willebrand factor. In type 2, there is no decrease in the number of multimers, but there is impaired binding to platelets. And in type 2N, there is decreased affinity between the factor and factor 8. Next slide. Von Willebrand's disease has a clinical presentation of the patient gives typical history of prolonged epistaxis, bleeding from gums. In females, there may be history of menorrhagia, then history of bleeding from a cut or following any surgical event or a dental procedure, easy bruising, and also family history of similar symptoms in other family members. How do we diagnose this condition? This is done by measuring von Willebrand antigen, von Willebrand, and the cofactor which is present with it, and also we have to measure the factor 8 levels. Measurement of factor 8 is important because von Willebrand factor is the carrier protein for factor 8, and the normal levels are 50 to 150 international units per deciliter. Then to measure the levels of von Willebrand factor, we measure von Willebrand factor antigen levels. This measures its function. It does not measure its function, but it measures only its level, and the normal range is 50 to 200 international units per deciliter. In order to measure the functional ability of von Willebrand factor, we measure its ability to bind to platelet glycoprotein with ristocetin as a cofactor. So when we measure the antigen along with ristocetin as a cofactor, we get the idea of the functional ability of von Willebrand factor. The normal range is 50 to 200 international units per deciliter. All these levels will be reduced to 40% or less, and there will be prolonged bleeding time in the presence of normal platelet levels. Only in one subtype of von Willebrand factor, the platelet levels will be low, that is in subtype 2N. While in all other types, the platelet levels will be normal. Next slide. Now, if such a patient comes for surgery, we need to have some preoperative testing done after having diagnosed the patient. First thing we have to do is the complete blood count, because these patients may have anemia, and so we need to do the related corrections. We need to have blood groups, ferritin and CRF levels, prothrombin time and APT levels, activated prothrombin activated PTT levels needs to be done. If the plasma level of factor 8 is less than 30, then only APTT will be prolonged. And that will be in severe type of disease, that is type 3 disease. The other test that we do is platelet function analysis, 1 milligram factor antigen levels, and as I have previously described before, and the ratio of 1 milligram and ristocertin cofactor to the antigen level. If it is less than 0.6, then this is the pointer of type 2 disease. Now we have to when we prepare these patients for surgery, we should have the idea of the type of disease, because type 2 and type 3 disease patients will not respond to drugs like desmopressin, because desmopressin is a drug which is used for correction of hemostasis level in these patients. So if the patient is having type 2 or type 3 disease, then there will be no response after administration of desmopressin. Next slide. Our goal for preoperative preparation for these patients is that we need to correct the 1 milligram factor levels so that there is no excessive bleeding during the surgery. So this can be done by 3 ways. First is by causing endogenous release by giving drugs like desmopressin, then by giving adjunctive agents that improve hemostasis without modifying the levels of 1 milligram factors such as tranexamic acid and aminocaproic acid, and replacing the 1 milligram factor by human plasma derived concentrates. So by these 3 methods, we can do the preoperative correction of the hemostasis. Then I will talk about the next slide, please. So first, for minor surgery, the levels of 1 milligram factor should be more than 50 international units per deciliter on the day of surgery and on first post-operative day. And for the next 2 to 5 days, the levels should be more than 30 international units. And for major surgeries, these levels should be more than 100 units per deciliter on the day of surgery and first post-op day. And the levels should be maintained at more than or equal to 50 units for the next 7 to 14 days or until the healing is complete. Next. So one by one, I will discuss how we prepare these patients for surgery. First is the use of the drugs like desmopressin. Desmopressin is a drug which stimulates the release of 1 milligram factor through its agonist effect on vasopressin V2 receptors. This drug also causes increase of factor 8 and these levels increase 2 to 5 times the baseline. The standard dose is 0.3 micrograms per kg given intravenously. Subcutaneous formulation is also available. The peak effect of this drug occurs 30 to 90 minutes after administration, and it has to be repeated every 12 hours, considering its half-life of 8 to 12 hours. Repeated administration has its own problems. It can cause tachyphylaxis and hyponatremia with repeated administration. So fluid intake should be monitored and restricted 24 hours after dosing. Also, there is a risk of a rare but a possible risk of myocardial infarction in some patients. So we need to monitor the patient. Again, I have to reminder that this drug is not effective in type 3 disease and of limited utility in type 2 disease, because in these patients there are functional mutations and the 1 milligram factor itself is abnormal in these patients. So even if the drug is given, it is of no use. We also give, in mild cases, antifibrinolytics are very useful because they act as adjunctives to hemostasis. Commonly used is tranexamic acid, which inhibits the conversion of plasminogen clots. This drug can be given orally, IV, or even as a mouthwash in case of dental surgeries. The dose is 10 ml per kg per hour, given every 8 to 12 hours. It can be given 1 gram intravenously shortly before induction of anesthesia, or orally 1 gram 3 to 5 any invasive thing like dental procedures and all. There is one contraindication for this drug, that is if there is upper renal bleeding, then this drug should be avoided as it can give rise to ureteral clots and that can cause hydronephrosis. Next slide. While giving replacement therapy, we have to keep in mind that this is important for patients who are low responders to desmopressin and for type 3 patients with very low or absent von Willebrand factors. And this can be done by recombinant and plasma-derived concentrates or by using FFP and cryoprecipitates. The von Willebrand concentrate is made from pooled human plasma. We have preparations such as Immunate. It contains active substance factor 8, 50 international units per ml, and von Willebrand factor 25 international units per ml. 1 unit of von Willebrand factor is considered to increase the plasma levels by approximately 2%. The loading dose is calculated by weight of the patient and multiplied by weight of the patient and divided by half-life of the drug, and this has to be given every 24 hours. We have to keep in mind that levels should not be more than 150 to 200 because this can increase the risk of thrombosis. In absence of recombinant or plasma-derived products, cryoprecipitate is an option, and the dose is 10 to 12 units of cryoprecipitate every 12 hours in an adult. Next. Now we come to the actual anesthesia management. I have just outlined the important principles, and these principles are applicable to all the bleeding disorders, especially the inherited disorders. First thing is that the surgeries should be scheduled early in the week and preferably in the morning so that we have adequate manpower, and also we should have liaison with the laboratory services to ensure availability of factor concentrates and blood products. Then perioperative avoidance of mucosal trauma, intramuscular injections to be avoided. There should be appropriate maintenance of normothermia and pressure point care, avoiding trauma to the joints by giving adequate padding. Then care with vascular access and invasive monitoring. We have to consider the use of ultrasound in difficult cases, and risk and benefits of neuraxial block and regional blocks need to be assessed. Generally, these are avoided in type 2 and type 3 disease. In type 1 patients, if the levels of von Willebrand factor are adequate and if all the levels are normal, then we can give regional anesthesia even in these type of patients. We need to maintain the all the blood pressure and pulse rate within normal range. Hemodynamically, the patient has to be maintained stable because if there is hypertension and tachycardia, this itself can increase the risk of bleeding. Next. If neuraxial anesthesia is planned, then the factor levels have to be maintained above 50 international units per deciliter following the prophylactic treatment already explained before. If epidural is planned, then use of round tip catheter has to be used and the space should be dilated before its insertion. And this procedure should be done by an expert, and if available, ultrasound guidance is preferred to avoid repeated procedures and to avoid unnecessary trauma. The normal levels of factors has to be monitored and maintained for the duration of catheter placement and for 12 to 24 hours after catheter removal. If we are using this for cesarean delivery, the catheter should be removed as soon as possible after the delivery, because after delivery, the factor concentrations rapidly decrease. What to do if there is uncontrolled hemorrhage in such patients? Then in such cases, we have to consider the platelet transfusion and give supplementary factor 8 von Willebrand factor concentrate. For adjunctive, we have to give desmopressin and consider the possibility of inhibitor. Now, what is inhibitor? I will talk about it again. These are the antibodies which develop against these factors which then nullify its action. So if the patient is not responding to this, we have to assess for the presence of inhibitors and and if there is a possibility, if patient is not responding to all this, then we have to give recombinant factor 8 or bypass agents such as activated factor 7, Novo7 or FIBA. Now, post-operative care of these patients, early mobilization, and we have to consider deep venous thrombosis prophylaxis also, because although these are patients with bleeding tendencies, we are giving them additional supplements such as cryoprecipitate, and so these patients, there's a dual possibility even of thrombosis also in these patients. So all these possibilities we have to keep in mind in post-operative period. Multimodal pain management and avoiding drugs which causes platelet dysfunction such as NSAIDs and aspirin. And the goal is to maintain the levels of factor 8 and 1 Hildebrand factor as long as there is a hemostatic challenge. For minor surgery, this period is of 1 to 5 days, and for major surgeries, it is up to 14 days. Means till as long as the healing occurs, we have to maintain the normal hemostasis in these patients. Now, I request them to start the slide number 31. I will come to the next condition, that is hemophilia. It is a congenital bleeding diathesis with deficiency of factor 8 or factor 9, factor, that is hemophilia A and hemophilia. This is an X-linked inheritance in type A, and hence males are affected and females are carriers. So although females do not have disease, there are certain conditions where patient may have females, although they don't have disease, the carriers may have excessive surgical bleeding, such as after postpartum hemorrhage they may have. And we have another hemophilia C, it is the deficiency of factor 11. It is a rare condition present common in Ashkenazi Jews. Again, I will explain the clinical features in short. The symptoms range from mild to severe. In severe disease, there is history of frequent and severe bleeding episodes anywhere in the body, especially in weight-bearing joints, muscles, brain, genitourinary system, and intracranial bleeding may be the major cause of mortality in these patients. There is history of similar symptoms in family members. Also, the patients may give history of frequent treatment with factor 8 concentrates. The factor 8 and factor 9 are important in intrinsic pathway of clotting cascade, and they are required for thrombin generation and fibrin formation. So deficiency of these factors gives rise to bleeding tendency in these patients. The normal levels of factor 8 is 0.5 to 1.5 international units per ml, or 50 to 150%. 1 unit is equal to the normal of percentage of or concentration of coagulation factors in 1 ml of normal pool plasma. Now, how do we grade the severity of hemophilia? This we can do by assessing the factor levels. In severe cases, the percentage of activity is less than 1. In moderate cases, the percentage of activity is 1 to 1.5. And in mild cases, the range is between 5 to 40% of the normal. Now, if such patients are posted for surgery, first is the pre-anesthetic evaluation. Detailed evaluation has to be done. History of medications, its severity, then family history that has to be taken. Prior information about response to the desmopressin, use of recombinant factors 8, and previous history of blood transfusion has to be taken. The clinical examination has to be done along with routine general and systemic examination, and we have to rule out the presence of joint deformities, contractures. Since these patients have history of spontaneous bleeding into joints, so there is a condition called as hemarthrosis. They may have, this condition gives this causes deformities and contractures in joints. So all these factors have to be ruled out and kept in mind, because we have to all this documentation has to be done so that in postoperative period we don't have any medical legal problems. And assessment of this patient has to be done by a multidisciplinary team involving the hematologist, surgeon, and the anesthetist. Next slide, please. Slide of laboratory investigation. The laboratory investigation, we do the complete blood profile, coagulation profile, fibrinogen level assays, factor assays. Since this patient received blood products frequently, so we have to test for HIV, hepatitis B and C, and testing for inhibitors has to be done because these patients frequently receive the blood products. So there are chances that they may develop antigens against these antibodies against the factor 8. So if such inhibitors are present, the patient will not respond to routine line of management. There is a study called as mixing study in which there is shortening of APTT when we mix the patient's plasma with the normal plasma. But if inhibitors are present, then this shortening will not occur. Next slide. Preoperative preparation. This is done by first identifying all the case correctly, assessing and correcting other coexisting problems such as anemia. Then we have to do the correction of factor 8 levels or factor 9 as the case may be. Preoperative autologous donation is to be avoided in these patients. Now how to do preoperative preparation, next slide. Preoperative preparation is done by we have to do 80 to 100% correction of factor 8 before any major surgical procedure. The levels have to be maintained for 6 weeks postoperatively in orthopedic procedures and 1 to 2 weeks for other procedures. We have 2 options for correction of factor 8. For mild cases, this can be done by pharmacological options as we had done for 1 milligram cases before. And second option is by using the blood products. For pharmacological options, there is desmopressin, and this is a very useful drug. It causes 3 to 5-fold increase in factor 8 with a dose of 0.3 microgram per kg. We have subcutaneous intranasal preparations and oral preparations for this drug. We have to keep in mind that desmopressin is not effective in hemophilia B and in severe hemophilia A. Adjunctive drugs such as tranexamic acid and epsilon aminocaproic acid, they are useful in reducing the intraoperative bleeding. They promote clot stability, and their dose is 15 to 25 milligram every 8th hourly or IV 10 milligram 8th hourly. Orally 3 grams of this can be given in 3 divided doses. Next slide, please. The preoperative preparation of hemophilia is done using factors and blood products. Recombinant factors 8 and 9 are available. The advantage of this is that it is free from disease transmission. They are very potent drugs, and they can be stored at room temperature for 9 months without cold chain. The only limiting factor is the cost, and the other thing is that they may not be useful. They are not useful in patients with inhibitors. Next slide, please. How to calculate the dose of correction? For that, each factor 8 unit will raise the plasma factor 8 by 2%. So the number of units required for factor 8 will be weight of patient into percentage of factor level desired into 0.5. And for factor 9, the formula is factor 9 raises the levels by 1%. So number of units required is weight of the patient into percentage of factor level desired. The next is preoperative. Then other products that we can use for preparation is intermediate and high purity factor 8 concentrates, cryoprecipitate, and FFP is no longer used as we require large volumes of drugs. So that is not feasible option. Next slide. We can use prothrombin complex concentrates as has been previously explained by Divatia sir in his presentation. The dose is 15 to 50 units per kg, and maximum we can give 5,000 units. It has to be avoided if we have given tranexamic acid to the patient. There is risk of thrombosis with this drug, so we have to be careful in, especially in patients with orthopedic procedures, severe traumatic injuries, and liver disease patients. Then we have factor 8 bypassing activity agents. These are this is activated prothrombin complex concentrate and recombinant factor 7. These are useful in patients who are having circulating inhibitors in the body. Next, now I have added a slide of rare coagulation disorders and their therapeutic options also. In this only because as these are very rare, I won't be discussing them separately due to time constraints. If there is deficiency of factor 1, then we have used therapeutic options available for correction are plasma derived fibrinogen and concentrate and cryoprecipitate. For factor 2, we can give prothrombin concentrate or FFP. For factor 5, we can give platelet transfusion and FFP. For factor 7 deficiency, we can give recombinant factor 7A, FFP, and prothrombin complex concentrate. And if there is deficiency of factor 10, again we can use prothrombin complex concentrates. As I have previously discussed before, screening for inhibitors has to be done prior to surgery. We have two categories of patients in this. First is a low risk inhibitor and second is the high risk inhibitor. They require alternative regimens like recombinant factor 7 or FIBA for correction. Now, management of hemophilia patients posted for surgery. Now we assume that these patients have been adequately prepared by giving adequate amount of factors for correcting the factor levels. Now, again, the principles for management of hemophilia are same as that of any patient with bleeding disorder. Optimal timing of surgery. We have to be careful with vascular access, avoiding intramuscular injections and arterial punctures, avoiding trauma during transport, positioning, and mobilization. Next, the intraoperative management, we have to have a smooth induction of anesthesia, avoiding succinylcholine because this can cause muscle fasciculations, which may worsen hemorrhage in joints and other sites. Avoiding procedures such as nasal intubation as it is more traumatic and bleeding can occur, which can lead to aspiration. If difficult intubation is suspected in such patients, we have to go for video laryngoscope or fiber optic scope and has to be done by an expert. Gentle manipulation of airway is needed, otherwise submucosal hemorrhage can occur, which itself is a life-threatening condition as it can cause blockage of the airway. Endotracheal tubes should be previously greased with lubricants and there should be gentle insertion of feeding tubes temperature probes because all this again gives rise to submucosal hemorrhage. For intraoperative management, we again the similar points that I have already explained before. Hemodynamics has to be maintained as close possible to the normal range and extubation has to be done in deep plane. Skilled surgical approach is advised to prevent blood loss. We can go for controlled hypotension and blood salvage can be done, but avoiding acute normovolumic hemodilution because this will cause dilution of the factors. If best thing is to avoid regional anesthesia, but there are reports in literature where regional anesthesia has been done in these patients if factor 8 is in normal range. Wherever this is planned, it has to be done by a skilled person and preferably under ultrasound guidance. And very important is that normothermia has to be maintained because that itself causes disturbances of coagulation. And normothermia can be maintained by fluid heating devices, warm air blowing, warm air blowers, etc. Now I come to the postoperative care in these patients. We need to maintain the factor 8 levels in the postoperative period as already discussed before. The half-life is 12 hours of factor 8, so the infusions have to be repeated every 8 to 12 hours and till the hemostasis is achieved, till the surgical healing is achieved, we have to monitor the levels and give the factor 8 accordingly by using the appropriate blood products or recombinant factors. For postoperative analgesia, we avoid drugs such as NSAIDs because of the and we avoid we can give opioids and multimodal analgesia. Optimal analgesia is important in these patients because this reduces the sympathetic activity and avoids the contractions of limbs which can occur if there is inadequate pain. So for hemophilia B patients also we have similar management, but in this case we are using recombinant factor 9 or factor 9 prothrombin concentrates. It has to be used very cautiously as compared to factor 8 because we keep the factor 9 has less availability as it gets absorbed into collagen and its half-life is 18 to 24 hours. So repeat infusion has to be done every 12 to 24 hours. Next slide. For patients with inhibitors, recombinant factor 7A is given in a dose of 90 to 120 micrograms per kg every 2 hours for first 28 hours, and FIBA if can be given in a dose of 70 to 120 units per kg first, and then every 6 to 8 hours for 3 days. Now I will discuss in short about the platelet disorders. I will be only highlighting the important points due to the time constraints. For minor procedures, local or systemic tranexamic acid is given. This is the only intervention needed. For severe disorder or if the major surgery is there, then desmopressin has to be given, and platelet transfusions are also required. For major surgeries, the platelet count may be 50 to 70,000 above, and for neurosurgical eye and neurological procedures, the platelets should be more than 1 lakhs per millimeter cubes. 1 unit of single donor apheresis platelet or 6 units of random donor platelets increases the platelet count by 50,000 per millimeter cube. So we have to keep this in mind while deciding how much platelets to give for that particular patient. Now I come to hypercoagulable states, the inherited hypercoagulable states. The body has an intricate balance of coagulation and anticoagulation. If any of the factors in the anticoagulant system is deficient due to some congenital causes, then it gives rise to congenital thrombophilias. So if there is deficiency of antithrombin 3, protein C or protein S, then this gives rise to patients with thromboembolism risk. The deficiency of antithrombin 3 is autosomal dominant trait, and these patients have 20 times more risk of developing thromboembolism as compared to normal patients. Protein C and protein S, these are important factors in anticoagulant system, and protein C inactivates factor 5 and factor 8 and stimulates plasminogen activator, and protein S whose normal levels is 63 to 160% is its cofactor. So absence of any of these proteins in the body can give rise to some thrombophilic thromboembolism in the patients. Here in this table, next slide please. In this table, I have explained the inherited thrombophilias. These are mostly autosomal dominant inherited conditions. We have, besides the deficiencies of antithrombin 3, C and S, there may be abnormal factors such as factor 5 Leiden and prothrombin and dysfibrinogenemia. In factor 5 Leiden, the half-life of this factor is prolonged due to a different structure, congenitally different structure of this thromboembolism. Then due to conditions like hyperhomocystinemia also, patients may be prone to thromboembolic conditions. Now, how do we manage such patients if they are posted for anesthesia? Venous thromboembolic prophylaxis is needed in these patients. We need to give oral or parenteral anticoagulants. These have been explained in detail before also. These anticoagulants, we can give warfarin, then low molecular weight heparin and fondapurinax. In post-operative period, we have to give compression boots, intermittent pneumatic compression, and elastic stockings. For orthopedic procedures, we need to give oral direct thrombin inhibitors like rivaroxaban, apixaban, and placement of a vena cava filter is also advisable to prevent from pulmonary thromboembolism. So with this, these are the references. With this, I complete my presentation, and I thank everyone for listening patiently. Once again, I thank the organizers for giving me a chance to speak on this platform. Thank you all once again.
Thank you, ma'am. Thank you.
Thank you so much, ma'am, for the insight. Ma'am, this topic is open for any questions, ma'am.
Yes, yes.
Okay, ma'am. Thank you so much. Am I audible to you?
Yes, ma'am.
Yes, ma'am.
No, it should be audible to.
Yes, I can hear.
Dr. Samina Madam.
Yes.
Yeah. Dr. Samina Madam is a brilliant academician right from her school days. So her presentation is also master caliber. So there is one question for you. Yeah.
Thanks, madam, for your kind words.
There is one question for you.
Yes,
That the lab investigations for diagnosis of von Willebrand syndrome.
Von Willebrand syndrome diagnosis. Is this what they want me to tell?
Yeah, that's what.
Yeah. I have already explained that in detail. Von Willebrand disease diagnosis, I have already explained in detail. First is the presentation, clinical presentation. Whenever a patient comes, we have history and lab investigations. These are two ways by which we diagnose any condition. So the patient gives a typical history of increased mucosal bleeding, bruising, epistaxis, and in females we have menorrhagia. That may be the only symptoms these patients may be having. And for that, for accurate diagnosis, we have to do the lab test. In lab test, we have von Willebrand factor assays. So the normal level is 50 to 200 international units per deciliter. Anything 40% less than anything of this is considered as disease. So if the level is less than 40% of the normal, then we consider that the patient has the disease. With even less amount of von Willebrand factor, the patient will have normal coagulation system. So for diagnosis, the criteria is that it should be less than 40% of the normal. Then for if we have three types of the diseases. So if we want to diagnose the subtypes, then we have to go in details. We have to do the von Willebrand factor antigen levels, then von Willebrand factor risostatin, that is a cofactor for that, and we have to do the ratio of von Willebrand factor and risostatin levels. If the ratio is less than 0.6, then that is a pointer that although the von Willebrand factor is present in the body, but its functional capability is not in the I mean to say that all the von Willebrand factor levels, although it is qualitatively deficient, although the quantity is correct, the quality is not is deficient. There may be some deletions in the and mutations giving rise to abnormal von Willebrand factor levels. So if the level of this if the ratio of antigen and factor level is less than 0.6, then it points to type 2 disease. And in severe disease, the level is less than 10% of the normal. So you keep in mind that the normal level is 50 to 200. Anything less than 40% of this is disease. So that is the key point in this. And for quality level, we have functional capacity, you have to do the assay of the cofactor, resource and cofactor. So these three things you have to keep in mind while diagnosing von Willebrand disease.
Okay, madam.
I hope it's clear to everyone. I hope it's clear.
Yeah,
I
it's
hope it's
clear.
clear to the audience.
And yeah, such an elaborate discussion. And there is one more question.
Yes.
That how to investigate in the pre-operative period the thrombocyte disorders.
Thrombo.
Platelet
Which patients?
disorders.
Which patients?
Yeah. How to investigate platelet disorders?
Platelet disorders. Okay, platelet
This
disorders.
From Umesh.
Yeah.
Umesh.
We have for platelet disorders, basic is the platelet count and bleeding time. Then we have platelet functional assays also are available for this. They give detailed they give a detailed idea of the functioning of the platelets, because there are certain conditions in which platelets are circulating in the body but they are not functioning appropriately. So platelet function assays are available for this purpose. So in that we get an idea of the percentage of normal circulating platelets versus the abnormal platelets. These are some basic tests which we can do for platelet this thing. And yeah, that's the basic thing that we have to go for, see in platelet disorders. And there may be some syndromes, so that has to be evaluated by the hematologist. These are the basic things that an anesthetist should know, according to me.
One question from Dr. Surekha. What is the lab profile for hypercoagulable state?
I'm not clear which condition. Which condition we are talking about?
Lab profile. What is the lab profile for hypercoagulable state?
Okay, hypercoagulable states. Lab profile for hypercoagulable states. For hypercoagulable states, we have basic is prothrombin time and APTT. These are the two tests we have to do, these are the most important tests. Bleeding time and all that, they will not be much affected because these are patients with thromboembolic disorders. Yeah. We also have the test which have been previously explained by Chandak madam, thrombin time and reptiliase time. These are the assays which we can do in patients with hypercoagulable states.
I think Dr. Surekha is satisfied with the questions she had answered, and she had question and she got the answer, I believe.
Yeah.
And I think that's all.
Thank you, madam.
Okay, Dr. Zamina, thank you so much for giving us your valuable time. And
thank you, everyone. Thank you so much, everyone, for having listened to me patiently, because this is this topic which is we have been listening to your things for such a long time. Thanks, everyone.
Thank you so much, Dr. Thank you so much, Dr. Ma'am. Thank you so much, Dr. Jigiri Bhatia, Dr. Sheetal Dalal Ma'am, Dr. Samina Khatib Ma'am, for enlightening us with your commendable talk on this whole subject. We also like to thank Dr. Muralidhar Joshi sir and Dr. Jayashree Sen Ma'am to head this session.
yeah, that's my pleasure. I'm sorry.
Thank you.
Thank you so much. And I must thank the organizing committee for giving me this opportunity to share this platform with Dr. Muralidhar Joshi, the stalwart of anesthesia, and to sharing, to be here to listen to Dr. Dwivedi, another doyen of anesthesia. So I'm really thankful to you all. The session is over, no?
Yes, ma'am.
It's lunch break now.
We will be now moving on to our third session, which will cover the pharmacology of anticoagulants, regional anesthesia, and patients with abnormalities of coagulation, as well as the management of deranged coagulation profile preoperatively in ANC patients. So our honorable chairpersons for this session are Dr. Nima Acharya ma'am, Professor and Head of the Department of OBGY Jnmc, and Dr. Anita Nihate ma'am, Consultant Anesthesiologist at Vedanta Hospital, Nasik. I now request Dr. Anita Nihate ma'am to introduce Dr. Javed Khan sir for the first segment of this session.
Thank you, Dr. Soumya. I would like to thank the organizers for arranging such a wonderful and very day-to-day important topic of perioperative management of coagulopathies. Am I audible, Soumya?
Yes, ma'am. Yes, ma'am.
Yeah, yeah. And I would like to thank the organizers of our Department of Anesthesia, Jnmc, DMIMS, Savangi, and ISA Wardha for giving me this opportunity. Thank you, Dr. Chandak sir, Chandak madam, Dr. Neeta, Dr. Sanjot, Dr. Aruna, and Dr. Aditi. So I would like to, yes, I would like to introduce Dr. Javed Khan. And yeah, do we have a CV of Dr. Javed Khan? Dr. Javed has done his anesthesia from MGM Indore, and he has also done his fellowship in interventional pain management from Kolkata. We know him as a very active member of the Association of Regional Anesthesia, AORA India, and he has given many lectures and workshops on the subject of regional anesthesia. So we are looking forward, very much looking forward to this lecture by Dr. Javed. And over to you, Dr. Soumya.
Yes, ma'am. I now request Dr. Javed Khan, sir.
Hello. Am I audible?
Yes, sir. Yes, sir, you're audible, sir.
Yeah. Good afternoon to all my chairpersons, my organizers, and delegates. Thank you, Anita madam, for such nice words. And can I share my screen?
Yes, sir.
Yes, sir.
Presentation. Okay.
Yes.
Namaste. Pranam.
Namaste.
It's so nice to see you, man, after long night.
How are you, Muli?
All good, Javed. All good. Please go ahead. Ready to hear and listen to you.
Good afternoon, Dr. Javed. See you.
Lot of greetings from the cleanest city of India. I'm Dr. Javed from Indore, and many congratulations to the Department of Anesthesia, Jnmc, Savangi, and ISA Wardha. And thanks a lot for inviting me for such a valuable CME webinar. And special thanks to Dr. Vivek, my dear Vivek Chakole. The topic allotted to me is the regional anesthesia and anticoagulation along with the pharmacology. But I'm lucky enough that most of the burden of pharmacology has been beared by my previous faculties, Dr. Divetya, Dr. Sheetal Dalal, and so my burden is relieved. So we'll let us start. It's a lot more theoretical, but we have to bear it. What we have to concern as an anesthesiologist for the anticoagulation and regional anesthesia. In the recent times, we have seen the use of this anti-clotting drugs has been increased many folds. Why? Because we are getting more and more patients receiving these drugs because of post-coronary angioplasty, post-valvular replacement, as a treatment of atrial fibrillation, and post-myocardial infarction. And so also for the prevention and treatment of the deep vein thrombosis. These drugs inhibits hemostasis at various levels. The first is the inhibition of the platelet aggregation, that is the antiplatelet drugs, and the anticoagulants and the third one is that prevent the fibrin formation, that is the fibrinolytics. You see the incidence of spinal hematoma was originally reported as 1 in 150,000 in epidurals and 1 in 220,000 in spinal. But the recent epidemiological study reveals the incidence is as good as 1 in 2,700 to 1 in 19,500 by epidurals. The most recent study shows the overall risk is 1 in 21,643 epidural injection. So as you see the chronology, the incidence of spinal hematoma and in the central neural blockade has been increasing. And most of the studies which has been done coagulants and regional anesthesia is mainly directed towards the central neural blockade. Now, there are various risk factors associated with spinal hematoma. We have elderly patients which have spinal abnormalities, osteoporosis, and peripheral vascular disease. Female genders are more liable to get these abnormalities. A patient with renal insufficiency, because clearance of the anticoagulants will be late. And a patient of spinal stenosis, there is a lumbar canal stenosis because of osteophytes, because of the hypertrophy of the ligament flavum and facetal joint arthroplasty. And so the use of the immediate preoperative and the early postoperative period of low molecular weight heparin. An indwelling epidural catheter is always at a risk of producing a spinal hematoma than a single shot epidural or a spinal, or a traumatic needle displacement, whether it's a spinal or an epidural. And there is a simultaneous application of antiplatelets along with the anticoagulant drugs. Obstetric population seems to have a low incidence, most probably because of hypercoagulable state of the in the pregnancy and a wider capacity of epidural space and higher intraepidural space. So whatever the bleeding is there, it gets dislodged because of the higher intraepidural pressure. Now there are some special circumstances which give rise to the abnormalities of the coagulation. A lot of tissue trauma, hemodilation, hypothermia in case of polytrauma. There's a lot of consumptive coagulopathy in sepsis. Thrombocytopenia, secondary in uremia, give rise to these abnormal coagulation conditions. Liver, of course, the most of the coagulation factors are produced in the liver. So in liver failure, we get a deranged coagulation. Massive trances again give rise to a lot of consumption coagulopathy, so as the DIC. So why we need a guideline to help for the getting an regional anesthesia implication? See, with the introduction of low molecular weight heparin, the incidence of spinal hematoma has increased many folds. There's raises the eyebrow of so many, and that results in prompting the FDA to issue a health advisory in December 1997. And as a result of that, the first consensus or the first guideline was laid down by American Society of Regional Anesthesia and Pain Medicine in 1998, which is updated in 2003, 2010, and so on. There are some other sets of guidelines like European Society of Anesthesiology, Scandinavian Society of Anesthesiology. Now we are having almost 4 or 5 guidelines for the regional anesthesia and anticoagulants. These all guidelines were based on extensive review of the literature of the drugs and the pharmacology of different anticoagulants. These available guidelines based on a recommendation of the time interval where to stop the drug before the procedure, when to restart after the procedure, and before removal of the epidural catheters. The risk of complication of anticoagulant patient should be weighed against the benefits of regional anesthesia. This is a key factor which is to be remembered by each and every anesthesiologist while performing a regional anesthesia. So we'll start with the pharmacology of anticoagulants. First, we have antiplatelet agents. Aspirin and non-steroidal anti-inflammatory drugs. They inhibit the platelet cyclooxygenase enzymes, which prevent the synthesis of thromboxane A2, which is a protein vasoconstrictor, which facilitates the aggregation of the platelets. Aspirin affects the duration of platelets, while NSAIDs affect the function. The function of platelet function assumed to be decreased for 1 week with the aspirin and for 1 to 6 days with NSAIDs. They are mainly used in low doses for primary and secondary prevention of stroke and myocardial infarction. See, the continuous production of fresh functioning platelets along with the residual platelets, they combinedly explain the relative safety of the performing a neuraxial block in these patients. So ASRA guidelines recommends that there is no additional precautions to be taken when you are taking a patient for regional anesthesia treated with these drugs for any central neurexid or peripheral nerve block. Now comes the P2Y12 receptors inhibitors. They inhibit the adenosine diphosphate mediated platelet aggregations. They divide into two groups, thienopyridines and non-thienopyridines. We'll start with one by one. Clopidogrel, the most widely used drug nowadays. The maximum platelet inhibition of with clopidogrel standard dose, that is 75 milligrams, that happens within 3 to 5 days, but with a loading dose of 300 to 600 milligrams within 4 to 6 hours. The ESRA recommends the interval of 7 days to withhold clopidogrel before attempting any procedure. For any procedure, a test of platelet function is recommended. Ticlopidine causes neutropenia, thrombocytopenia, purpura, and hypercholesteremia. So it is not in common practice. ESRA recommends 10 to 14 days of interval for commencing any regional anesthesia blockade. Again, the test of platelet function is mandatory before going for a procedure. Then we have non-thienopyridines, ticagrelor and congrelor. These drugs causes 90% inhibition of the platelet function as compared to 60 to 70% for clopidogrel. Prasugrel is causing irreversible inhibition of P2Y2. It takes almost 7 days for platelet activity to normalize after stopping this drug. So an interval of 10 days has been recommended for any procedure. And the drug can be restarted within 6 to 24 hours after the neuraxial procedure or epidural catheter removal. Ticagrelor is reversely bind to the P2Y2 receptors. The antiplatelet effect is rapid and achieved within 2 to 4 hours, and the recovery is also rapid. Resumes normal at the 5 days after the last dose. So an interval of 5 to 7 days has to be there for any of the regional anesthesia procedure, and those can be restarted again the same, the 6 to 24 hours after neuraxial procedure or catheter removal. Now we have platelet glycoprotein 2 and 3A, 2B and 3A receptors antagonists. Then we have 3 drugs. They inhibit the platelet aggregation by interfering the binding of platelet fibrinogen and platelet 1 Wilbur fracture. The time interval returns to the normal platelet function are longer with abscizumab is 24 to 48 hours as compared to epitifibatide and tirofiban, that is 4 to 8 hours. Dipyridamole is used to prevent ischemic stroke. Recommendation for withholding is 24 hours before any procedure, and the drug should not be given when there's a catheter in situ. Cilostazol. It also it inhibits the phosphodiesterase 3A and thus platelet aggregation. Recommendation is again 48 hours before any central neuraxial block procedure or any peripheral nerve block procedure. Now, how to monitor the platelet functions? The first and foremost, the easiest way is doing the bleeding time. A reliable predictor of abnormal bleeding receiving antiplatelet drugs, but the post aspirin bleeding time is not reliable indicator for post aspirin bleeding. Then PFA, platelet function analyzer, it is prolonged after antiplatelet therapy. But unfortunately, the PFA 100 is not a sensitive test for monitoring the platelet function of these inhibitors, clopidogrel, prasugrel, and ticagrelor. Then we have an advanced test, PFA 200 of the previous one. It seems to be sensitive for these drugs. However, the point of care studies of these new PFA tests is still lacking. We have some new tests that monitor P2Y12 inhibitors activity. This includes vasodilator stipulated phosphoprotein assay, VSP assay, and verify now assay And the next one is the multiple platelet aggregometry test. There's a multiplate. And the recent one is the platelet mapping component thromboelastograph or TEG. This Verify Now assay can monitor the antiplatelet effect of aspirin and P2Y12 inhibitors. The tag is commonly used in surgery and anesthesiology, while the Verify Now is the predominant assay in clinical cardiology. Now we come to the second category, anticoagulant drugs. Heparin and low molecular weight heparin. Now, if you take the unfractionated heparin, it binds to antithrombins and causing the inactivation of thrombin, factor 2A, factor 10A, and factor 9A. The intravenous unfractionated heparin acts immediately, while the subcutaneous administered 5,000 international unit exerts its effects after 1 hour. Low molecular weight heparin activates antithrombin, accelerating the antithrombin interaction with the thrombin and factor A. It has a great activity against factor 10A. The plasma half-life ranges from 2 to 4 hours of IV injection, intravenous injection, and 3 to 6 hours of subcutaneous injection. It is mostly used to prevent and to treat venous thromboembolism. It is recommended for profiling this low molecular weight heparin. Recommendation for any blockade is the prophylactic use. We have to have 12 hours intervals, and for therapeutic, we have to have 24-hour intervals. Epidural catheter removal can be done after 4 hours. On the subcutaneous heparin, with the therapeutic dose of subcutaneous heparin, that's 5,000 units twice a day. The smaller dose are mainly used for prophylaxis rather than for the treatment. The maximum anticoagulation effect observed for 40 to 50 minutes and return to normal within 4 to 6 hours. FPTT usually remains unchanged and therefore is not monitored with this subcutaneous heparin. We can very well do an uracil block with the patient on a twice a day regime. But as I recommend not to use in a patient who is having a thrice a day subcutaneous heparin because of lack of adequate data. Now, how to monitor the heparin effect? There's various tests. We start with we have activated partial thromboplastin clotting time, APTT, and one more activated clotting time. The prolongation of APTT is greater than 1.5 times of the baseline. It reflects the therapeutic anticoagulation. APTT usually does not prolong with the subcutaneous administration, so should not be monitored. Protamine neutralizes the effect of intravenous administered heparin. Now, parenteral heparin alternatives, then we have factor 10A inhibitors, fondaparinux. With the synthetic anticoagulants, it produces an antithrombotic effect by selective inhibition of factor 10A. It is rapidly absorbed at a maximum concentration within 1.7 hours of administration, and its half-life is 17 to 21 hours. The extended half-life is approximately 20 hours that recommends a single-day use once a day, and that issues a black box warning for this drug. This drug is recommended for mainly for the antithrombotic agent for major orthopedic surgery and initial treatment of pulmonary embolism. And any of the neuraxial block should be performed as it is done with the clinical trials, thus like a single needle, atraumatic needle, not with the indwelling catheters. Now we have direct thrombin inhibitors, agratroban and bivalirudin. The effect is monitored by APTT. Effects last for 3 hours after intravenous administration. Neuraxial techniques are not recommended in patients taking these drugs. Now come to the oral anticoagulants. Factor 10 inhibitors, rivaroxaban, endoxaban and apexaban. They are the team and drugs in this category. Rivaroxaban, this plasma concentration reaches within 2.5 to 4 hours. The maximum inhibition factor is up to 68%, with occurs within 3 hours. It is maintained for 12 hours or little more, 24 to 48 hours in high doses or in elderly patient populations. It's indicated for symptomatic venous thromboembolism. Guideline recommendation is 2 to half time of the lifetime interval for the discontinuation and epidural catheter placement or removal. Scandinavian guidelines recommend 18 hours, while the European guidelines mention 22 to 26 hours. The guidelines also recommend 4 to 6 hour intervals before resumption of the next dose. Just to monitor this rivaroxaban, is the prothrombin time has a linear correlation, while the APTT lacks sufficient sensitivity, while the anti-10A is a surrogate marker. Reversal can be done with activated charcoal, but it should be administered within 8 hours of this drug intake, and 4-factor PCC. Apixaban, this terminal half-life with a single 5 milligram dose is 13.5 plus minus 9 hours. With the multiple dose of 5 milligrams is 15.2 plus minus 8.5 to even to 11.7 plus minus 3.3 hours. It's mainly used to reduce the stroke or systemic embolism without increasing the risk of bleeding. Monitoring is done with the PT, which has a laser effect. Then we have a dilute PT assay. This is more sensitive, and one more, the anti-10A assay. Now, the guidelines for these anticoagulants, 5.5 times of the 5 times of the half-life interval should be recommended after discontinuation of the drug and doing any of the neuroaxial procedure. And interval of 8 to 24 hours time should be there before resuming the drug after procedure or removing the epidural catheter. Now we have oral thrombin inhibitors, dabigatran. It is direct thrombin inhibitors. Peak plasma concentration attained within 1.5 to 3 hours. It has a half-life of 14 to 17 hours. 80% of the clearance is by kidney. So in case of end-stage renal disease, the elimination half-life doubles from 14 to 28 hours. It is used to prevent and for the treatment of venous thromboembolism and stroke. ASRA guideline recommends a time interval of almost 122 hours after the last dose before performing any neuroaxial procedure. ASRA guidance is against using this epidural catheter in situ, and moreover, the catheter must be removed 6 hours before administration of this drug. How do we monitor dabigatran? APTT. APTT is prolonged after this drug. Thrombin time, also known as thrombin clotting time, is highly sensitive for the dabigatran. And we have one more, carrying clot, ECT, carrying clotting time, which directly measures thrombin generation and is dose dependent prolongation by this drug. Reversal is by hemodialysis because 80% of drug is eliminated by the kidney. Now the warfarin. Warfarin is the direct inhibitor of the clotting factors 2nd, 7, 9, and 10. It also inhibits the anticoagulant protein C and S. Factor 7 has relatively short half-life, 6 to 8 hours, and the prothrombin time PT may be prolonged with the therapeutic doses, 1.5 to 2 times of normal within 24 to 36 hours. Higher loading dose of warfarin, 15 milligram, may be applied for first 2 therapy to achieve the desired anticoagulant effect within 48 to 72 hours. The anticoagulation effect of warfarin persists for 4 to 6 days after termination of therapy. It can be very well reversed with the transfusion of fresh plasma and vitamin K injection. prothrombin complex concentrate can also be used in emergency situation to counteract warfarin. The monitoring, the simple method is INR, an INR of 1.5, an absence of any visibility and normal liver function is regarded as safe. In the patient, if the patient is taking warfarin more than 24 hours, INR should be checked before any procedure. INR should be normal for the 5 days of the warfarin, the last dose of warfarin for any of the neuraxial blockade. And the patient's neurological status should be checked routinely during epidural and angiotensin infusion every 2 hourly, as well as 24 hours after removal of the catheter. Now we have thrombolytic or fibrinolytic agents, alteplase and streptokinase. This agent interacts with the fibrinogen to produce plasmin that causalizes the link between the fibrin molecule and plasmin. The clot lyses lead to the elevation of fibrin degradation products, which have anticoagulant effect and by inhibiting the platelet aggregation. They are mostly indicated in acute myocardial infarction, pulmonary embolism, and CVA. Any of the central neuraxial block should be considered 48 hours after administration of this agent, where the clotting studies are normal. Measurement of fibrinogen level may be helpful, but for catheter removal. And the patient should be neurologically monitored at least for 24 hours every 2 hour interval. Now, most of the herbal therapies are in common use nowadays. The garlic inhibits the platelet aggregation. Its effects on hemostasis appears to last for 7 days. Zingo inhibits platelet activation factors. Effect lasts for 36 hours. Ginseng also inhibits the platelet aggregation and is prolonged both the thrombin time and APTT. Its effect lasts for 24 hours. Herbal drugs do not add a significant risk to the development of spinal hematoma and central neuraxial blockade. Discontinuation of this medication or cancellation strategy is not supported by any of the available clinical data, and there's no accepted test to assess the accuracy of hemostasis in patients who has taken or taking herbal medicines. Now, to sum up or recapitulate the guidelines in a tabular form of first start with the antiplatelet drugs. We have 3 columns where the drug is first is where the drug has to be withheld. Second, whether the drugs to be start after procedure, and third, and about restarting the drug after the catheter removal. Aspirin anesthesia does not have any, don't need any additional precaution. They can be continued. Clopidogrel, as mentioned earlier, 5 to 7 days, but I hardly bet any surgeons wait for 7 days. Mostly 3 to 5 days. Most of the practitioners, they took the patient within 3 to 5 days. Then drug can be started after 24 hours. And after removal of the epidural catheter, they can be started immediately, and loading this should be given after 6 hours. Prasugrel and ticlopidine, they have to be withheld for 7 to 10 days. Ticagrelor, again 5 to 7 days. While catheter in situ, not recommended for this prasugrel and ticagrelor. While with the ticlopidine, you can start after 24 hours. These drugs can be started after removal of catheter immediately, but the loading dash should not be given before 6 hours. There's the new drugs. Most of the drugs they usually is withheld for 3 to 4 hours, except apsizumab, which should be withheld 24 to 48 hours, and dipyridamole should be extended release formation should be withheld for 24 hours, while the cholesterol should be withheld for at least two days. And most of the drugs are not indicated while the catheter in situ in the postoperative period. And after removal of a catheter, there's no specific guidelines for most of these drugs. So they should be used very cautiously. The guidelines in evaluation with the anticoagulation drugs. Unfractionated heparin, if you're using subcutaneous for more than 4 days, it is mandatory to perform a platelet count. With the low dose prophylaxis, 5,000 units twice a day or thrice a day, the drug should be withheld for 4 to 6 hours. For high doses, 12 hours. For therapeutic doses, 24 hours. Restarting therapy, low dose you can start after 4 to 6 hours, and high doses you to analyze the risk and benefit of the patient. And after removing of the catheter, low dose can be started after 1 hour. High doses, there's no specific guidance, so should be used with cautious. Intravenous unfractionated heparin, if used for more than 4 days, it is mandatory to use to do a platelet count, but should be withheld for 4 to 6 hours. And while catheter in situ, after procedure, you should wait for 4 to 6 hours. And after removal of catheter, you can administer after 1 hour. Low molecular weight heparin again. If you're giving a prophylactic dose, it should be withheld for 12 hours. For treatment dose, large dose should be for 24 hours. And after the procedure, the first dose, we can start after 24 hours. And removal of catheter should be done 12 hours after the last dose. And the treatment dose, it's not recommended to use low molecular weight heparin in the postoperative period. While after removal of catheter, a prophylactic dose can be given 4 hours, but the treatment dose should not be given before 24 hours. And 48 to 72 hours in high risk or bleeding, high risk of surgery, where the bleeding chances are more. Fondaparinux should be used as advised in the clinical trials. There's a single needle, that too atraumatic, without any indwelling catheter. For rivaroxaban, it should be stopped. It should be withheld for at least 72 hours, both the drugs. And in the post-operative period, not recommended. By chance, an accidental or an unanticipated administration has happened, it should be withheld for 20 to 26 hours or 20 to 28 hours. And after removal of the catheter, they can be given after 6 hours. Apexaban should be withheld for 72 hours before any procedure. In the post-operative period, it should not be recommended. If by chance there's an anticipated administration, should be withheld for 26 to 30 hours. After removal of catheter, it can be given, both these drugs can be given after 6 hours. As dabigatran is mostly 80% is excreted by the kidney, the creatinine clearance has to be taken into account. If it is more than 80 ml per minute, you can withhold the drug for 72 hours. If it is 50 to 79, 96 hours. It was 30 to 49, 122 hours. If it is more than 30 ml per minute creatinine clearance, this drug should be avoided and should not be recommended in the post-operative period when the catheter is in situ. Warfarin, ideally, we should stop 5 days before and should get done the INR regularly. In the post-operative period, the low dose can be given after checking the INR. If it is below 3, catheter is well accepted with the used with the caution. But if it is more than 3, we should hold the warfarin. And after catheter removal, there's continuous monitoring of the INR and the neurological symptoms, at least for 24 hours. It's thrombolytic drugs. They should be withheld at least 48 hours before the procedure. And normal clotting factors, at least the fibrinogen should be normal. They're not recommended in the post-operative period and after removal of the catheter. So how to use these guidelines for CNS and peripheral blockade in the anticoagulant patient? The tragedy is that the very less objective information is available. The ASTA guidelines in 2021 presented a summary of 32 cases reported of the patient who have several hemorrhagic complication after PNB and plexus blocks and peripheral blocks. What they show, the patient suffering from neurological deficit all completely recovered within 12 months. Not much. Hospital stay was prolonged, and the complication resulted more from the blood loss than from the neurological damage. And most probably the expandable nature of the peripheral side causes a lower risk of doing a reversible neural ischemia. Deep plexus like lumbar plexus and perioperative blocks and deep peripheral nerve blocks, proximal sciatic nerve blocks carried a higher risk. And there was no evidence of vessel trauma. So this is the result of the 30 cases study done by ESRA for the peripheral blocks. Now, what are the relative risks related to the central vessel block and peripheral nerve blocks in patient with the cognition abnormalities? Yeah, we look at the infiltration, not major blood vessel involved there. So local infiltration is the most of the benign procedure that can be done very well without the risk of any bleeding. While we're going for superficial blocks, like a superficial cervical plexus block, forearm, arm blocks, wrist blocks, bias block, or saphenous or ankle blocks can be very well done without much of the risk. But if you're talking of interfacial plane blocks, like inguinal, iliohypogastric, tab block, facial, rectus sheath block, facial atta blocks, they carried a mild risk but as there is no major blood vessel involved, but the risk is always there. And if you are going slightly higher to the superficial perivascular block, like interscalene axillary block, intercostal femoral popliteal, where the major blood vessel is there in the neurovascular bundle, they definitely carry a higher risk than the previous ones, because the blood vessel is not compressible. And the deep blocks like supraclavicular, infraclavicular, vertical infraclavicular, obturator nerve block, or proximal sciatic, they carry a mild to moderate, not only moderate, but sometimes they are at high risk of doing these blocks. Perioperative blocks, lumbar plexus blocks, deep cervical blocks definitely carry a much mortality and morbidity. And epidural catheter with single shot epidural or spinal carry a high risk. And use of ultrasound in plexus block and peripheral nerve blocks. The chances or the incidence may have decreased with the complication can decrease with because vascular puncture due to the dynamic visualization of the structure adjacent in the ultrasound can be minimized, but even ultrasound doesn't guarantee a foolproof safety of the complication, because you may be having a good ultrasound, but definitely visualization of needle, unless until you have good echogenic needles, the tip of the needle should be visualized near adjacent to the vessel. Regional anesthesia and the sufficient hemostatic conditions. The minimum hemostatic conditions required for regional techniques has been a controversial issue. And still it is controversial because there's no universal consensus has been reached in this regards, and none of the guidelines that refers to the explicitity of this complications. The minimum threshold of hemostatic capacity, what we call, we have certain tests to explore the platelet function, like PFA 100 or thromboelastogram. But none of them is validated as the predictors of the possible bleeding or hemorrhagic tendencies. So the minimum hemostatic condition can be for a CNB or a peripheral nerve blocks in a non-compressible vessel may be estimated as, according to guidelines, the functional platelet should be more than 50,000 INR. International normalized ratio should be less than 1.5. And activated prothrombin time, APTT, should be more than 45 seconds. The APTT ratio should be less than 1.5. But as we have seen with the platelet count of 50,000, neuro procedures are not done. most of the people, it varies from place to place, from person to person. Most of the people, they took the platelet count to be 70 to 80,000, or maybe about more than 1 lakh. The general strategy for management of patient on anticoagulant while taking a regional anesthesia, you still have to weigh the risk and benefits of regional anesthesia. A careful review of the history, including a family history of bleeding disorders and a physical examination for any bruises or ecchymosis. An appropriate coagulation test should be done. Optimize the coagulation status. Single shot spinal or epidural is always better than an indwelling epidural catheter. If the simultaneous use of drugs that affect hemostasis should be considered again while weighing the risk. Probably use a low concentration of local anesthesia in order to avoid, to check for the neurological monitoring, and we should have while performing a regional anesthesia, we should have a good facility of a blood bank or good laboratory and a hematologist. So to conclude this, the use of anticoagulant and antiplatelet agents has been increasing primarily as a result of aging populations, increased life expectancy, prevalence of cardiac disease, and expansion of indication of this new anticoagulants which are coming regularly. The new guidelines are emerging every 6 months or 1 year. That we are coming with the new guidelines and changes in the guidelines for perioperative management of patient for regional anesthesia with anticoagulant. And whether to continue, whether to discontinue, whether to restart the anticoagulant drugs should be a process of decision making in a shared basis. The surgeon and anesthetist has to decide combinedly about these things. The final decision must be evidently made on the basis of the assessment of the individual benefits for each of the patient. That's all. Thank you so much for listening to me patiently. Thank you, sir.
Thank you so much, sir, for your valuable insight on the topic. I now request Dr. Nima Acharya ma'am to introduce Dr. Karuna ma'am for the next segment of the session.
Good afternoon, everyone. Am I audible?
Yes, ma'am, you're audible.
Are we going to take any questions or this thing with the previous speaker, Dr. Javed Khan, or at the end?
Ma'am, still there are no questions, ma'am, for the previous topic, ma'am, as of now. So we'll continue with the session, ma'am, and as soon as the questions will come, we'll head in with the session with the questions after that, after the next segments, ma'am.
Okay. So it was a wonderful talk by Dr. Javed Khan. And first of all, let me congratulate the entire team who has thought of this most relevant topic of managing perioperative management of coagulopathies, and especially it is very important for us as obstetricians because we are finding these days a lot of thrombocytopenias are coming in our day-to-day practice. The next speaker is Dr. Karuna Taksande. She's my beloved colleague, and she's presently working as professor in the Department of Anesthesia at our own institute, DMIMSDU. She did her MD anesthesiology from Jnmc Mumbai, that is JJ Group of Hospitals, and presently she is a proud PG guide for her students and a humble person whom I know since last a decade, I must say, and a member of ISA. So may I invite Karuna ma'am to deliver her talk on perioperative management of coagulopathies in ANC patients. By the time Karuna ma'am is putting her this thing, let me thank Dr. Chakole and Dr. Aditi Gaurkar for managing it so well and giving me this opportunity also. Thank you so much.
Thank you. Thank you so much, Nima ma'am.
presentation is visible.
Yes.
Yes.
Thank you so much, Niva ma'am, for such a nice word and wonderful introduction. So good afternoon, everyone. First, I would like to thank organizing committee who gave me an opportunity as a speaker. So let me start my presentation on the management of rearranged coagulation profile perioperatively in ANC patient. So before moving to the topic, one need to understand the physiology of coagulation in pregnant women differs from those women who are not pregnant. Pregnant women frequently develop physiological anemia and experiences such changes in the level of coagulation factor that alter the balance between coagulation and bleeding in preparation for bleeding during childbirth. So anesthesiologists should understand both physiological changes in coagulation system and disease and medication induced pathophysiological changes during pregnancy and increases the safety of regional anesthesia for painless delivery and cesarean section. Now, changes in coagulation related factor during pregnancy, the level of factor number 7, factor 8, and factor 10 increases along with the level of fibrinogen, while fibrinolysis and the activity of protein S and C decreases, resulting in a hypercoagulation state. The level of fibrinogen increases significantly from the 20th week of pregnancy, and it is 2 times higher. It is 350 to 650 milligram per deciliter than in a non-pregnant woman, which is about 200 to 400 milligram per deciliter. D-dimer level also increases throughout the pregnancy, and at the end of pregnancy, the level exceeds the level which is used to diagnose the thromboembolism in non-pregnant population. Preoperative coagulation screening in ANC patient. The preoperative coagulation screening should be done if there is a history and physical examination that suggests a possibility of any coagulation disorder. Second, the patient is on anticoagulant and antiplatelet drug. And third, a medical history suggestive that could alter the coagulation. These are the basic tests to check the coagulation disorder. Bleeding time, normal value is 0 to 10 minutes. It measures the platelet count, vascular integrity. Platelet count 1.5 to 4 lakh. Prothrombin time 12 to 14 seconds, and it measures the activity of factor 1, 2, 5, 7, and 10. Partial thromboplastin time 25 to 35 seconds, and it measures the factor number 1, 2, 5, 8, 9, 10, and 11. Thrombin time, normal value is 12 to 20 seconds, and it measures the factor number 1 and 2. And normal fibrinogen level is 200 to 400 milligram per deciliter. Now coming to the disorder of coagulation in pregnancy. It is classified as a clotting factor abnormalities and platelet abnormalities. In clotting factor abnormalities, we have congenital coagulopathies and acquired coagulopathies. Congenital coagulopathies are Owen-Willebrand disease, hemophilia A and B, prothrombin type, antithrombin deficiency. Acquired coagulopathies include pregnancy-induced hypertension, placental abruption, retained dead fetus, amniotic fluid embolus, and liver disease, or if the patient is on anticoagulant like aspirin or heparin. Platelet abnormalities, these are mainly the qualitative and quantitative abnormalities. In quantitative abnormalities, we have gestational thrombocytopenia, idiopathic thrombocytopenic purpura, Hell's syndrome, and DIC. Now, congenital coagulopathies include Owen-Willebrand disease. This is inherited as an autosomal dominant characteristic by the bleeding of varying severity. It is a disorder affecting Owen-Willebrand factor, which is a part of factor number 8 complex. There are 3 types of this disease. Type 1, this is mild to moderate bleeding disorder, and there is a partial deficiency of Owen-Willebrand factor. In type 2A, there is a quantitative defect in the Owen-Willebrand factor. Type 2B, there is a qualitative defect in our Owen-Willebrand factor with the increased binding to a protein platelets causing mild thrombocytopenia. In type 3, there is a severe bleeding disorder in which there is a complete absence of own Milgram factor and reduced level of factor number 8. So patient with the own Milgram disease have a prolonged bleeding time and normal platelet count except in the type 2 B disease. As far as the liver and liver is concerned, in congenital anomalies, abnormalities, during pregnancy, there is a 3 to 4-fold increase in the own Milgram factor. Patients suffering with the type 1 disorder improve during pregnancy as own Milgram factor level increases up to a normal range. Women who suffering from the type 2 and type 3 disorder do not improve during pregnancy. Desmopressin and own Milgram factor concentrate are used to increase the level of own Milgram factor. So vaginal delivery is considered safe if own Milgram factor is more than 40 international units per deciliter. If the operative delivery is concerned, it has to be more than 50 international units per deciliter. So postpartum hemorrhage can occur if the level of this factor fall to pre-pregnancy level. Anesthetic consideration and management in congenital coagulation abnormalities, which mainly depend upon the type of the disease, platelet count, the level of factor number 8 and own Milgram factor should be known considering the regional anesthesia in this patient. An experienced anesthetist should give epidural anesthesia. Regional anesthesia is safe in a patient with type 1 disease as the level of coagulation increases to a normal level. Epidural catheter should be removed immediately after delivery as there is an increased risk of epidural hematoma due to the decline in the coagulation rate. Central neuroaxial blockade is not recommended for a woman with a type 2 and 3 diseases. Hemophilia. Hemophilia A and B are X-linked disorder due to the deficiency of factor number 8 and factor number 9 respectively. Females are usually carrier of this disease as they have only one affected chromosome. The clotting factor level activity is expected to around 50% of the normal. Those women with a low factor level have some risk of bleeding as they affect the male. Hence, they have prolonged activated prothrombin time. Treatment of hemophilia A is factor number 8 concentrate, cryoprecipitated, and intranasal or intravenous desmopressin. Treatment of hemophilia B is a factor 9 concentrate and fresh frozen plasma. So the desmopressin increases the level of factor 8 and own Milgram factor via its action through V2 receptor. It is a synthetic analog of ADH hormone and it can be used as an IV or intranasal to prevent the postpartum bleeding also. The increase in coagulation factor, it remains for 6 hours. There is a theoretical risk of uterine contraction and possible harm to the fetus with the use of desmopressin, but this is not a contraindication to use of that desmopressin during labor, which is the usual time when it is administered. So factor number 9 level is not increased by desmopressin. In antenatal management, pregnancy should be managed in close collaboration with the hematologist. It is recommended that the factor level should be checked at the time of first visit and then at 28 week and 34 week of gestation. The level of factor number 8 and own Milgram factor increases during pregnancy. The level of factor number 8, it may be double than the pre-pregnant value. So there is no increase in the factor number 9 level. So the maternal level do not rise significantly until the second trimester. So invasive procedure such as first trimester abortion, it can be complicated by a serious hemorrhages. The level of clotting factor should be maintained more than 50% of the normal value. During labor and delivery, plasma level should be more than 40 international unit and it is generally regarded as a safe for normal vaginal delivery, and a level more than 50 international unit per deciliter is sufficient for a cesarean section. If the factor level is less than 50, then a prophylactic factor supplementation is needed to maintain the level more than 50 international unit per deciliter throughout the labor and up to the 7-day post-delivery. The level of coagulation factor falls significantly to a pre-pregnancy level after delivery and it will cause a delayed postpartum hemorrhages. Anesthetic management in hemophilia. in pregnant patient, a detailed history of bleeding problem and full coagulation profile with the factor number 8 and 9 should be sought. The use of regional block is controversial unless the factor level is more than 50 and APTT is normal. Regional anesthesia should not be considered. It may be difficult to measure the factor level if the patient present during labor. If the coagulation factor levels were more than 50 in the third trimester, an experienced anesthetist can do epidural procedure if platelet count, APTT and prothrombin times are normal. The epidural catheter should be removed soon after delivery and factor level as these factor levels falls quickly in postpartum period. Now coming to the acquired coagulopathies. Acquired coagulopathies are due to the uncontrolled activation of the coagulation system causing disseminated intravascular coagulation. Once triggered, the uncontrolled activation of procoagulant level leads to widespread intravascular coagulation. This leads to a fall in the level of clotting factor, such a low level that they are insufficient to stop the further bleeding. Disseminated intravascular coagulopathy, the life-threatening thrombohemorrhagic condition known as a disseminated intravascular coagulation and is generally more common in men than women. Apart from the reproductive year, when pregnancy and its complication increases its prevalence. So TIC during pregnancy constituted one of the leading cause of maternal mortality worldwide. This complication is often secondary to the underlying maternal and fetal complication, including placental abruption, postpartum hemorrhage, amniotic fluid embolism, acute fatty liver of pregnancy, preeclampsia and health syndrome, and written stillbirth. Definition: the Scientific Standardization Committee and the International Society on Thrombosis and Hemostasis define DIC as an acquired syndrome and characteristic by intravascular activation of coagulation with a loss of localization arising from different tissue, and it can originate from and cause damage to the microvasculature, which is sufficient severe and can produce the organ dysfunction. So from this definition highlight three important aspects. First is it is always secondary to the other cause, one of them being an obstetric related such as abruption placenta, preeclampsia or intrauterine fetal death. Second, DIC represents the systemic pathological activation of coagulation. In DIC, there is an uncontrolled dissemination of the localized thrombotic process which is clearly pathological. In obstetric cases, there is a extraplacental dissemination of the activated coagulation system, which is usually localized to the placenta. And third, that is crucial aspect of the DIC definition is the role of microvasculature. So these are the different type of DIC. These are classified according to the which pathway is predominant. If the coagulation pathway is predominant, it is a procoagulant DIC and it is predominantly thrombotic origin. And if the fibrinolytic pathway is predominant, it is a hyperfibrinolytic DIC, and which in which the predominantly which manifests as a bleeding. So these are the obstetrical causes, complications that associated with the DIC. Sepsis, it includes sepsis, peripartum hemorrhage, abruption, severe hypertensive disorder of pregnancy, written stillbirth, and amniotic fluid embolism, acute fatty liver. So diagnosis and the management of DIC in pregnancy. If these are the risk factor for the DIC, as I mentioned, acute postpartum hemorrhage, placental abruption, health syndrome, stillbirth, sepsis, acute fatty liver, amniotic fluid embolism. If this risk factor that is associated with the clinical signs of DIC, then prompt treatment is required, including the delivery of the patient, administration of the blood product according to the transfusion protocol. So treatment of the underlying cause and repeated laboratory testing and multidisciplinary approach is required. If these factors are not present without any signs and symptoms, then clinical laboratory evaluation is needed, considering using the point of care testing. Apply DIC score for the risk assessment. In high risk cases, consult multidisciplinary team consider early administration of the blood products and supporting measure close clinical laboratory surveillance is really required. In case with the low risk for ASC, close clinical and laboratory surveillance is required. Now, pregnancy-induced hypertension, it can be associated with a low platelet level. 50% of the patient can have the level less than 1.5 lakh. There is an increased destruction of platelet due to the immunological mechanism. So, coagulation screen is show the prolonged bleeding time and partial thromboplastin time with increased level of a fibrin split product. HELLP syndrome is a life-threatening pregnancy complication, and it is a variant of the preeclampsia. It usually occurs during the later stage of pregnancy, and it can occur after the childbirth also. So HELLP syndrome, as its name suggests, include hemolysis, elevated liver enzyme, and low platelet count. As far as the anesthetic implication in the HELLP syndrome, general anesthesia is more mandatory in these cases. Especially the patient present with the severe thrombocytopenia, eclampsia marked by the high blood pressure and convulsions. Liver disease during pregnancy can be due to the hepatitis, acute fatty liver of pregnancy, cholestasis, hepatic rupture, and HELLP syndrome. There is a decreased synthesis of coagulation factor due to damaged liver. Treatment should be done with the vitamin K and fresh frozen plasma to increase the procoagulant level. Gestational thrombocytopenia. This is not a pathological process. It is the most common cause of thrombocytopenia during pregnancy, and it occurs in a 5 to 8% of pregnant women. The platelet counts are in a lower range of normal, and it can be as low as 1 lakh. So there is a qualitative decrease in the platelet, which is balanced by the enhanced platelet activity. So women with this disorder are not at a risk of bleeding. Now coming to the idiopathic or immunological thrombocytopenic purpura. ITP is an immunological disorder in which anti-platelet antibodies are produced, which coat the platelet membrane. The antibody-coated platelets, they are destroyed by the reticular endothelial system. So the production of the new platelet does not match the destruction of the platelet, and therefore the thrombocytopenia occur. So as the platelet counts are usually below the 50,000, there is an increased incidence of bruising, epistaxis, and gingival bleeding. So treatment mainly aims at increasing the platelet count. It includes supplementation with the steroid, high-dose intravenous immunoglobulin, and splenectomy. The definitive treatment is a splenectomy, since it is a spleen is the site of their destruction. So in labor and delivery, platelet count more than 50,000 are required for normal vaginal delivery, as there is a transplacental transfer of antiplatelet antibodies. The neonate may be born with the thrombocytopenia. If the fetal platelet count is less than 50,000, then delivery should be considered by the cesarean section. Anesthetic management in patient with the thrombocytopenia. If the platelet count is less than 1 lakh, then a clotting screening is required before doing central neuroaxial block for pain relief or cesarean section. And if the platelet count is more than 80,000 and the clotting screen is normal, then regional anesthesia or regional technique can be used. With a platelet less than 80,000, a very careful assessment by a senior anesthetist is required, and preferably regional technique should be avoided. Pregnancy is a hypercoagulable state, and certain disorder increases the risk of thrombosis. So the patient with the inherited thrombophilia have increased tendency to venous thromboembolism. Some example of some genetic hypercoagulable states are antithrombin deficiency, protein C deficiency, protein S deficiency, factor V laden, and hyperchromocystinemia. Antithrombin 3 deficiency. Antithrombin 3 inhibit the activated clotting factor of 2 and 5. So these patients not only have an increased thrombotic tendency, but also have a resistance to heparin. Low plasma concentration of the antithrombin confirm the diagnosis. So treatment is usually with the oral anticoagulant. Acute correction can be done by the administration of the antithrombin 3, which is present specific in a specific concentrate of plasma. Factor V laden mutation. Factor V laden mutation is most common hypercoagulable disorder occurring in a 5% of the population. The mutation will lead to the in the form of factor number 5, and then it is activated to factor 5A resistant to the degradation by activated protein C. There is an increased coagulant activity, and so there is an increased risk of thromboembolism. Now coming to the general anesthesia for parturient with the bleeding disorder. General anesthesia is indicated if the patient has a significant thrombocytopenia or coagulopathy. Senior member of obstetric and the anesthetic team should be involved. Active help from the hematologist should be sought regarding advice and the arrangement of the required blood product. Any severe coagulopathy, it should be corrected before general anesthesia, because there is a always potential for the airway bleeding and increased surgical bleeding. Medical treatment of the postpartum hemorrhage. In post-obstetrical bleeding is one of the major cause of uterine atony. So, but it can also be caused by the premature placental detachment, placenta accreta, amniotic embolism, and consumptive coagulopathy. The main component is the main component in the treatment of medical PPH are rapid testing of the coagulation disorder, transfusion therapy, and pro-homeostatic pharmacotherapy as an adjuvant therapies. So, in transfusion, the guideline for the management of coagulation disorder related to the PPH in International Society of Thrombosis and Hemostasis are against, that is 1:1 transfusion of plasma, platelet, and erythrocytes. So they recommended the fibrinogen supplementation. It is cryoprecipitate or fibrinogen concentrate transfusion and platelet transfusion if it is difficult to obtain the coagulation test result after transfusing the 8 unit of red blood cell and fresh frozen plasma. The vascular endothelium in the pregnant woman, especially in those with the health syndrome, has damaged the glycocalyx, and therefore the plasma component is expected to play a protective role in a pregnant woman. So the NATA guideline, they recommended a restrictive erythrocyte transfusion policy, and it consists of the erythrocyte transfusion only if the hemoglobin level are less than 7 gram per deciliter in severe PPH, unless in case of massive bleeding, and 50 to 20 ml per kg of plasma transfusion if the coagulation abnormality in pregnant women with a severe PPH. In antifibrinolytic therapy, antifibrinolytic agents such as tranexamic acid inhibit the fibrinase activity and stabilize the fibrin clot. So tranexamic acid reduces the perioperative bleeding by interfering with the fibrin degradation and by plasmin without any special side effect. So pre-administration of the tranexamic acid in patient who underwent cesarean section or vaginal delivery can reduce the bleeding. So NATA guideline recommended that the IV injection of 0.5 to 1 gram of tranexamic acid along with the oxytocin if there is a high likelihood of PPH upon a cesarean section, and IV injection of 1 gram of tranexamic acid as soon as the postpartum bleeding begins within 3 hours, with an additional 1 gram of tranexamic acid via the IV injection if postpartum bleeding continue to remain after 30 minutes. Now, fibrinogen supplementation. Low fibrinogen levels in the early stage of PPH have been associated with the excessive bleeding and transfusion in several observation studies. So fibrinogen concentrate that differs from the cryoprecipitate in that it contains less germ and can be used in 10 to 15 minutes. Cryoprecipitate, however, it has a own membrane factor, coagulation factor number 8 and coagulation factor number 30, as well as it has a fibrinogen along with the although the fibrinogen concentrate, they are rapidly used to correct the hypofibrinolysis. It is advisable to assess the plasma level of fibrinogen and administer 2 to 4 gram of fibrinogen or 5 to 10 ml of cryoprecipitate only when the fibrinogen level is 2 gram per liter. Now, prevention of thromboembolism. Correction of coagulation abnormality is important in severe PPH, but care must also be taken to prevent thromboembolism. The NATA guideline also recommended that the prevention of thromboembolism be initiated if bleeding stabilizes after severe PPH and transfusion. So these are some recommendations by Royal College of Obstetrics and Gynecology for thrombophylaxis in pregnant patients. According to the risk, very high risk patient with a history of previous venous thromboembolism or either the thrombophilia or not on long-term therapy, antenatal high prophylactic or therapeutic dose of low molecular weight heparin and at least 6 weeks of the postnatal warfarin. In high-risk patient which include a previous history of VT venous thromboembolism plus thrombophilia, previous history of venous thromboembolism plus family history of venous thromboembolism, asymptomatic thrombophilia like antithrombin deficiency. In this, the antenatal and 6-week postnatal prophylactic of low molecular weight heparin is required. In moderately risk patient with a history of single venous thromboembolism without any thrombophilia or family history or either risk factor, then the 6 weeks of postnatal prophylactic low molecular weight required with or without antenatal low dose aspirin. The central neuroaxial block in patient taking this drug affecting the hemostasis. So drug patient is on aspirin and NSAID. The antiplatelet effect of aspirin persists until the new platelets are manufactured at least 7 days, whereas the platelet function returns to normal within 3 days after stopping the NSAID. So central neuroaxial block can be safely done in patient taking this drug. Unfractionized heparin, wait for 4 hours after subcutaneous dose and give the first dose after performing a block. Stop IV heparin infusion 4 hours before performing a block. APTT should be normal before performing a block. So restart IV heparin more than 1 hour after performing a block. Low molecular weight heparin, wait for 12 hours after prophylactic low molecular weight administration. Give low molecular weight after 2 hours of performing a central neuroaxial blockade. Wait for 24 hours after therapeutic dose of low molecular weight heparin is given before performing the block. In warfarin it should be stopped 4 days before surgery and start as an alternative anticoagulant such as a low molecular weight heparin and wait till INR normalizes. So I conclude, regional anesthesia is most often used in a pregnant woman. So therefore, when anesthesia is administered in pregnant women with a coagulation disorder or in those using heparin and antiplatelet agent, the anesthesiologist should accurately identify the coagulation status of the individual patient according to the procedure and the process involved in the procedure. Either, for example, catheter removal after epidural administration. So compared with the traditional standard laboratory test, field tests such as TEG and ROTEM that can be quickly diagnose a wider range of coagulation disorder. In addition, anesthesiologists should be actively involved as a part of a multidisciplinary team from the onset of postpartum hemorrhage. In patient with a severe PPH, the active use of plasma, platelet, and fibrinogen should be considered. And tranexamic acid, which is currently the most justified treatment, it should be administered. Thank you. Thank you so much. Thank you for patiently listening to me. Thank you.
Thank you, Karuna. It was a wonderful presentation. You covered almost everything, right? And we always are in, we have a lot of stress when we have a patient of coagulopathy. Like, you know, as pregnancy is, we are on one side worried about thromboembolism, and at the other side, we are worried about coagulation failure coming for LSCS or labor. So thank you so much. It was wonderful presentation. If we have any questions, we can take.
Thank you, ma'am. It's a very important topic in our day-to-day practice.
Yeah, for obstetricians, it is a everyday topic because every preeclampsia patient has thrombocytopenia these days. Whether she has full-blown HELP or not, thrombocytopenia is known. Then another disorder which we have in pregnancy, which leads to, apart from other coagulopathies, if patient has acute fatty liver or cholestatic and the liver fails, then that is another complication which we face, and all those patients require further. Only from surgery point of view, one precaution which every obstetrician should take surgically, or even for episiotomy, I feel, LSCS wise or for episiotomy, when you're taking sutures, you consider if it's a very severe thrombocytopenia or coagulation failure, by the time you're correcting it or in anticipation that it may worsen in perioperative period, always keep a drain at different levels, so that you get an idea how much is coming out. First of all, is she really bleeding? And at the same time, it will not collect, which we were not doing before much. So it's always better to keep drains. So it gives you an idea whether she's collecting inside, and at the same time how much she's losing and how much we need to replace. So we had recently had one acute fatty liver of pregnancy. She came with a non-recordable INR. She was in labor and she was previous to Caesar. So we had to take her up for section. There was no other option. And we had kept drains. She kept on pouring and we kept on replacing. And finally she survived. And the hats off to the anesthetic team, Chakole sir, Ninave ma'am, everyone. And I'm very proud that we have managed so many cases together in our institute. Presently, you are not on the gynae side. We have Ninave
Yes,
ma'am,
sir. We work together for
Dele
a.
sir, and Chakole sir. So thank you so much for working hand in hand with us and managing all these complicated cases.
Okay.
Excellent presentation, Dr. Karuna, and very practical too. And
Yes.
I am very happy to see Dr. Nima, obstetrician, praising you so much. Really,
I work with her, ma'am. She is a very good gynecologist, excellent gynecologist.
No, it goes a long way.
Yes.
I mean, really earned it. Are there any questions in the chat?
Yes, ma'am, we do have questions in the chat, ma'am.
Yes, there is one question about leukemia and how to manage leukemia patient during pregnancy. Question from Dr. Sheetal. So,
I think this question is, whenever you have such rare cases in day-to-day practice, first of all, Google the guidelines, recent guidelines. The first thing which you do, where, we are not in favor of Google, we are always, PG should read textbooks, we are always stressing on it. But certain guidelines which keep on changing every 5 years, 10 years, please go through them because of the availability of the experience, the evidence, and the new drugs or the, this thing come in practice. So please go through it if you get time, and you will definitely get time if you have a patient of leukemia in pregnancy. So early pregnancy, if she comes, most of them may not sustain that pregnancy itself. So that risk must be explained. And second thing is, I think if she is due for chemo, then maybe if she's lucky and it is not premature, you will have to give Dexa, magnesium sulfate in view of maturing the baby and get the baby out. And then from coagulopathy point of view, you will have to do, definitely you're already doing multidisciplinary because she's leukemia. And hematologist, anesthesiologist, depending upon what is deficient, you are going to take care of it. So again, she becomes a high risk coagulopathy patient. So otherwise, leukemia point of view, it will be a multidisciplinary. I will not be an expert to manage her. I can just predict what can happen to her pregnancy and what risk the mother and baby are going to have. So I have to have an hematologist who will manage her basically. And later on perioperatively, peripartum, it will be the anesthetist who's going to help me. And again, the hematologist, right? And the critical care, obviously. So this is how she will have to be managed.
depending on whether she is completed her treatment, whether she is
overall.
Yes.
So for the leukemia, I think it's a steroid is given as a prednisolone, just 1 to 2 weeks, and chemotherapy is advised if age is more than gestational age is more than 20 weeks, and some monoclonal antibodies are there to transfuse it. I think it's better for a hematologist to manage the leukemia in pregnancy, because he will advise better way.
Ma'am, we have another question from Dr. Prasad Kulkarni. He wants to know what is the prophylactic use of tranexamic acid in patients posted for LSCs.
Prophylactically, it mainly depend on what is the cause. Is there any is there any high risk factor is present for LSAs? High risk factor like any history of any bleeding tendencies or this factor.
Always give tranexamic acid for each LSCS patient. I think he wants to ask that.
No. We are not giving it. Okay. Only the high risk cases we can give. We are not always giving the prophylactic treatment to the tranexamic acid to prevent the bleeding. If any high risk factor is present, then we can give with oxytocin. The NATA guideline did recommended tranexamic 1 gram of tranexamic acid with oxytocin. That oxytocin will cause the contraction of the uterus, plus tranexamic acid, it will act as a fibrin clot. It will form the fibrin clot. So we are not routinely giving this patient.
Okay, as we give it to all other like orthopedic cases, major cases, we give
we give it.
Not
like hemiorthoplasties and all this high risk patient.
Probably because it is already a procoagulant state, so that is meant.
Yes.
Yes.
I think they are not to be used routinely. At least we don't have any guidelines.
No. We don't have a practice.
Companies are providing us with evidence which
unless and the patient comes to the as a PPH or postpartum hemorrhage for uterine ligation or all these things, then we will go for it. Otherwise, we are not using tranexamic acid.
Actually, there are few studies which have proven that instead of 800 ml, it has reduced to 500 ml and all. But the blood loss, if you have given this tranexamic acid preoperatively, but I don't think so it should be used as a routine, because if at all it is for prevention of PPH, there other better modalities are there, because most of the time it's going to be the tone which is going to cause the postpartum hemorrhage.
The causes of bleeding in a case of pregnancy, LSCs are different than the other major operation. That is why maybe it is not advocated. Any other questions? There are no more questions in the chat box.
Thank you, the organizing team, Yatharth, and the girl with Yatharth, I don't remember her name. Thank you for your efforts, coordination, and Aditi, thank you so much for being in touch.
Thank you, Nima ma'am, and thank you, Anita ma'am, and thanks the organizing committee to be a part of a very nice CME. Thank you.
MC Ratwar sir.
Thank you, ma'am.
So hence, moving on to our session 4, the next session, which will cover the anesthetic concentration in neurosurgical patients with deranged coagulation profile, as well as complications and post-operative management of these patients. Our honorable chairpersons for these sessions are Dr. Sandeep Redwar sir, Head of Department of Neurosciences, Jnmc, Dr. Mule, Head Department of Anesthesiology, CIIMS. Now I request Dr. Mule to introduce Dr. Manisha Kartikar ma'am for the first segment.
So good afternoon, everyone. Can you hear me?
Yes, ma'am, we can hear you.
Okay, thank you so much. And it's been a very nice, very nicely organized session so far. Beautiful presentations, very clear. So let me introduce Dr. Manisha Kartikar. She is Chief Anesthesiologist and Intensivist at Palwant Institute of Neurosurgery and Intensive Trauma Care, Solapur, and has a lot of creditable activity ever since she's been practicing anesthesia. She's been president of the Maharashtra State Chapter ISA associate editor for the Indian Journal of Anesthesia, national ISA coordinator for Cultural Club. She has held various posts in the Maharashtra State Chapter of Anesthesia in the past, secretary-elect, secretary, vice president, and president-elect. And she's done some great work. She's been doing a lot. She's been practicing anesthesia, neuroanesthesia, I think, particularly for a long period of time. She's received many awards also, as I can see here. Proficiency Award received thrice, the COLS Award at ISACON 2021, and Dr. Rukmini Pandit Award at ISACON Ahmedabad. So I hope that she will be able to tell us very, very nicely and very, very clearly about her presentation in neuroanesthesia and neurosurgical cases. Over to you, Dr. Manisha.
Thank you so much, madam, for your nice introduction. And it's nice to meet you all after a long time. In fact, I could not meet you in this Nagpur when I came to Nagpur for the conference. And it is at least very nice to see you virtually.
Yes.
So let's begin with the very practical topic that we are going to discuss today. That is anesthesia for a patient who has deranged coagulation profile, especially when he comes for neurosurgery. Let me share my screen. I don't think, are you able to see my screen?
Yes, ma'am.
But I am not able to see my screen. That is why.
No, actually your Zoom screen is seen. Your slides are not seen.
I'll just check. What you are able to see?
Your Zoom screen.
Okay. I'll stop share. I will again do that. I'm sharing now. Again, the same problem.
Same thing.
Ma'am, your presentation is
visible.
Okay. I hope now you are able to see.
Yes, ma'am.
Yes. Just give a minute. Yeah. So as I said, let us discuss in next 20-25 minutes the practical points that are regarded for managing such kind of cases with patients who have deranged coagulation profile, who comes either for elective neurosurgery and the worst nightmare for any anesthesiologist, that is an emergency neurosurgical intervention. So I'm going to tell you about two cases which we did very recently. And these are the two cases. I'm just going to tell you the clinical scenario at the moment, and at the end, after discussion of all the practical points, I will again discuss with you what we did to these two patients. This was a case, a 60-70-year-old patient who was a known hypertensive, who was on clopidogrel aspirin, and who was operated for CABG as well as mitral valvotomy in the past, and was taking warfarin and was admitted to our hospital with this kind of bleeding from a cardiologist, because he was admitted at a cardiology unit somewhere in the center near Solapur, and then he was admitted in a drowsy condition with such kind of hematoma on the CT scan. So we received the patient in the ICU. The patient was he had GCS of around 8/15, but he was localizing to pain nicely. He was maintaining his airway at that moment. His coagulation profile, though as he was on clopidogrel as well as on warfarin, was hampered little bit. So we just waited for some time, and then we will discuss at the end regarding the anesthesia management for this case.
This is a clinical scenario which we faced very recently in the month of December. A patient who had IHD was undertaken for stenting in one of the hospital near Solapur, and he had acute paraplegia following the intervention. Though the cardiac stenting was done, but this
To interrupt you, ma'am.
Yeah,
But your slides
sorry.
are not moving.
Your slides are not moving, Manisha ma'am. Oh, so sorry. I'm able to see that.
I can see only first of your slides.
Just introductory slide is seen. I think I'll share again. Something has gone wrong for sharing.
Yeah.
Yes. Yeah. Okay. Now,
So it's now visible and shared, ma'am.
Yes.
Yeah. It's
So,
visible. now.
So this is the second case, first case scenario which we discussed. I think you were able to listen to the discussion what I had mentioned. So this was a big patient came with big bleed like this in the brain, and that patient was receiving. He was on clopidogrel and aspirin for his bypass, which he was done around 8 years back. But then he was also on warfarin. So that is why he had this bleed and he came to us with GCS 8/15. This is another case. It was the patient came to us very recently in the month of December with a big bleed in the spinal cord. That this big bleed was there because this patient he had received streptokinase in a cardiology center very nearby to the Solapur neurosurgical center, and he had developed acute paraplegia following the streptokinase injection, and he was referred to us in an emergency because of that acute onset paraplegia. So these two clinical scenarios, they occur in a patient who have deranged coagulation profile. The most important problem in a neurosurgical intervention in a patient who has deranged coagulation profile is that the bleeding occurs in a closed compartment. We all know about the famous Monro-Killian hypothesis. Brain is a closed, compact space where there is no space for anything else other than the blood, the CSF, as well as the brain tissue. So in a patient who has excess of bleeding in this closed intracranial space is going to create rise in intracranial pressure, mass effect, and the patient will become drowsy. The same thing will happen if there is a bleeding in intraspinal compartment and the patient will develop pressure symptoms on the spinal cord at which place the compression will be there. So if you consider coagulation profile in neurosurgery, it can be hypercoagulability or it can be hypocoagulability. Hypercoagulability is the most commonest situation. I'm so sorry, hypocoagulability will be the commonest situations which we are able to see in our day-to-day practice. Though hypercoagulable state is not very rare, but still incidences of cerebral thrombosis can occur, and we will discuss both the situations, hyper as well as hypocoagulable states in neurosurgical patients. So the main complications of coagulation disorders on the brain are related to the risk of spontaneous bleeding. A patient who is on warfarin, who is on clopidogrel and aspirin, if he sustains a trivial trauma, or in cases of patients who are hypertensive and who gets peaks of high blood pressure, especially the geriatric population, especially the hypertensive patients, then these patients who are on anticoagulants may bleed in the brain. The risk of cerebral thrombosis, as I said, is less frequent and is associated with damaged endothelial surface or hypovolemic conditions. Emergency reversal of coagulopathy is always a double score because we need to keep the coagulable status that is needed at the time for the stent of the heart stent or for whatever purpose that drug is started. We need to keep it functioning as well as we need to avoid the excessive risk of bleeding or excessive risk of thromboembolism. So it is not the anesthesiologist or the neurosurgeon that will only take the decision regarding the surgical intervention as well as the anesthesia management. We need to consult the cardiologist because the patient might have been inserted a stent very recently, maybe on a stent for which a surgical intervention may not be advised for at least a year or maybe for some few months if he is on a bare metal stent. A hematologist who will guide us for various blood and blood products that are needed to reverse the coagulopathy, and of course ours as well as communication with a neurosurgeon is always very vital in anesthesia and surgical management of these patients who have deranged coagulation profile. We have discussed throughout the day about various reasons for coagulopathy. So let us discuss mainly for neurosurgical intervention, other than congenital, the most common, the acquired causes of coagulopathy in a neurosurgical patient. So what are the acquired causes of coagulopathy in a neurosurgical patients? Nowadays, because of increased cardiac interventions, many of the patients are receiving anticoagulants for atrial fibrillation. For patients with ischemic strokes, many of the patients are on antiplatelet agents, and even in patients who are having carotid stenosis, they are also on antiplatelet drugs. It is required for the patient to place on double antiplatelet drugs before pipeline embolization for cerebral aneurysm treatment. And the risk of bleeding in such kind of patient is found to be a very relevant risk, that is around 23% patients might bleed, and the reversal therapy in all these patients is always not possible. So what are the common causes of coagulopathy? Patients with or without head injury, with polytrauma, with massive blood loss will have dilutional coagulopathy. There may be dilution of coagulation factors and platelets by fluid resuscitation and blood transfusion in a patient who have sustained massive blood loss. Head injury itself can cause DIC, disseminated intravascular coagulation, and may be associated with thrombocytopenia, which we routinely see in a patient who comes to us with head injury. A head injury patient may have severe liver disease with vitamin K deficiency. So these are the commonest causes of coagulopathy that are seen in a patient who comes for neurosurgical intervention. What about the drugs? I'm going to discuss the commonest drugs at the moment. We will also discuss about the newer anticoagulant agents which are now commonly prescribed to the patients. But the commonest drug at the moment which the patients are taking and who are coming with neurosurgical and who come for neurosurgical intervention because of some bleed somewhere, either in spinal cord or brain. These patients are usually taking either aspirin or clopidogrel, warfarin. They may be on heparin, or they may be thrombolized, or they may have received streptokinase, urokinase, or atiplase for some or other kind of either a neurological problem or a cardiac problem. I just discussed about novel oral anticoagulants. The popularity of these drugs is increasing in the cardiologists, neurologists, and internal medicine specialists in last few years. They have been introduced in clinical practice, especially dabigatran. And this dabigatran, though they have found a reversal agent for dabigatran, but still it is not that easily available. And with the COVID era, in last 2 years, dabigatran has been and rivaroxaban has been commonly used in neurosurgical and in all kinds of patients for to avoid the complications of thromboembolism. There can be a real life-threatening scenario in case of intracranial bleeding, as the patients who are on novel oral anticoagulants, they have lack of reversal agent, and if we do not intervene, then there can be irreversible cerebral herniation, and if we intervene, then there can be risk of increased bleeding intra-op as well as post-operatively. So why we are so much worried about these new oral anticoagulants which are in use at the moment? The experience in their use is still limited. There is insufficient evidence related. I request the host to mute everyone.
आणि झोपण्याच्या आधीच तिकडचं करून घ्यायचं म्हणजे कसं आहे, सोपं जातं. ते राहिलंय म्हणे ते तावदान पुसायचं मावशी म्हणत होते.
I request the host to please mute everyone.
Yes,
So,
ma'am.
yeah.
Yes.
There is insufficient evidence related to the use of newer anticoagulants because of the few studies that have been published at now. There are no reliable laboratory tests to measure their effects, and with the exception of dabigatran, though no reversal agent has been found for these medications till now, and no guidelines are also available for reversal of dabigatran, especially in patients who are undergoing neurosurgical interventions. So let us see now clinically how you will work up these patients who come with deranged coagulation profile for neurosurgical intervention. We need to completely assess the patient with detailed history, medical history, past surgical history, any history suggestive of any congenital hemorrhagic disorder. Drug history in detail should be asked. Family history also should be asked in detail. Physical examination, patient must look for ecchymosis and hematomas or petechiae and bleeding from mucous membranes. And also, while asking for drug history, it is also important to ask patient about any history of NSAID intake, because these NSAIDs might cause platelet dysfunction. Even a single dose has been reported to cause platelet dysfunction, and that is very important history that has to be asked in while assessing these patients for surgical intervention. So what are the patients who might be taking anticoagulants? The patients who have history of rheumatic heart disease, who have history of atrial fibrillation, patients who are on prosthetic heart valves, patients who gave history of ischemic stroke, maybe a TIA, patients who gave history of DVT and are taking treatment for prophylaxis of deep vein thrombosis and pulmonary embolism, especially the patients who underwent surgery, immobilized patients, or those with procoagulant disorders. Patients with acute coronary syndrome, rivaroxaban may have been used. Most often patients are taking warfarin, oral thrombin inhibitors like dabigatran and apixaban and rivaroxaban. What are the laboratory workup that you will do for these patients if they come for either elective as well as for emergency neurosurgical intervention? I'm not going to go into the details of hematological workup, but I'm going to touch the practical aspects at the moment, because so many times in the emergency neurosurgical setup, the investigations like rotational thromboelastometry or thromboelastography are not available at all the centers. So the basic investigations like platelet count, laboratory tests for enzymatic coagulation, the international normalized ratio, most important, APTT and thrombin time, laboratory tests for fibrinolysis like measurement of fibrin degradation products and D-dimer test, and as well as assessment of bleeding time. These are the most common important investigations that we need to carry out, especially in emergency neurosurgical situation when we want to operate these patients in an emergency. So if the patient is coming for an elective neurosurgical case, one must assess the coagulation profile in detail. If facilities of thromboelastography or rotational thromboelastometry are available, then one can go ahead with such type of investigations if time permits. Why this is important? The coagulation profile has to be assessed very properly. This is because if there is a minor derangement of coagulation cascade, it can definitely affect the intraoperative course because of massive bleeding that may occur because of this minor derangement in coagulation profile. And if there is a suboptimal surgical hemostasis, that can lead to low cerebral perfusion state because of the risk of bleeding also, massive intraoperative bleeding also, causing hypotension, causing low cerebral perfusion pressure, or even if the surgeon operates the hematoma very well, but if there is a minor coagulation profile or derangement, then there may be occurrence of post-operative intracranial bleed again, and
again there will be, the patient will not recover because of that. For emergency neurosurgery, of course, the major focus should be early efforts for possible reversal of the cause leading to the intracerebral bleeding and to preserve the cerebral tissue perfusion and oxygenation throughout when we are reversing the anticoagulant effect of that particular drug. So let us discuss now the commonest drugs which the patient are taking at the moment and coming for emergency neurosurgical interventions and the evidences available for the use of these drugs. Warfarin is an oral anticoagulant. It interferes with vitamin K metabolism. It affects vitamin K dependent factor 2, 7, 9, 10. Also affects protein C and S that is needed for clot formation. Patients who are on mechanical heart valves, chronic atrial fibrillation, patients with history of venous thromboembolism are usually taking warfarin. If they come for elective surgery, stop the drug for 5 days, allow INR to decrease below 1.5 and take these patients for surgical intervention. What happens if this patient comes for emergency neurosurgery who are taking warfarin and who develops intracranial bleed? Prothrombic complex concentrate given in a dose of 20 to 50 units per kg has been said to be very effective option available for reversing the INR. 90% of the patients achieve normal INR within 15 minutes. If it doesn't occur, second dose might be repeated. But again, the main issue about is its availability. And of course, there is a risk of thrombosis associated with use of prothrombin complex concentrate. The next possible option is fresh frozen plasma containing vitamin K dependent factors 2, 7, 9, 10. It can be used in the dose of 15 to 20 ml per kg. Monitor INR and continue it till the INR falls below 1.5. There is a risk associated with high volume load, especially when the patient is a cardiac patient, and the fresh frozen plasma also may have low concentration of factor 9. So that has to be taken into account. At the same time, vitamin K 5 milligram IV can be given per 24 hours for INR correction. PCCs with normal amounts of factor 8 are known as 4-factor PCCs. This is something for theoretical information, while the products without factor 8 are the 3-factor PCCs. Guidelines recommend that these platelet complex concentrates are better over FFP because of their rapid administration and the complete INR correction is possible when we use them. But the problem with them at the moment at most of the centers is their availability. Recombinant factor 7A is also recommended for anticoagulation reversal. It is helpful in warfarin-induced intracranial hemorrhage. It has earlier action than PCC and FFP. However, because of its cost, availability, as well as thrombotic complications, again, this is not routinely used. Traumatic brain injury. That both patient who sustains head injury both develop hypercoagulable state as well as hypocoagulability. There is release of tissue thromboplastins from the brain, from the part of the brain which is ischemic, which can cause hypercoagulability. Patients who develop DIC may have platelet dysfunction, fibrinolysis, consumption coagulopathy, and hemorrhage leading to hypocoagulable state in patients who have sustained traumatic brain injury. Patients with TBI often present with DIC, which might not be evident till the surgery starts. And this is very important clinically. This is because what happens, many a times a patient comes with head injury. On day one, we do all kinds of investigations, including PT-INR, APTT, everything. They are within normal range. Patient is also settled at that time. Maybe another 24 to 48 hours, patient may develop an increase in the size of hematoma and patient may need urgent surgical intervention. It is always advisable to do coagulation profile before taking the patient in OT. And why this is important? This is because many a time it is not evident till surgery starts that the patient is having DIC. So it is important to go do these investigations, keep fresh frozen plasmas available, and then only take these patients for surgical intervention. So it is always better advisable to do platelet count and PT-INR before taking these patients for surgical intervention. There are various predisposing factors that are accompanying blood loss and multiple trauma involving long bone fractures, which can cause consumption coagulopathy. Incidence of traumatic brain injury related coagulopathy is not very rare. It is around 25 to 30% on admission, and it doubles within 72 hours post-trauma. And that is why I mentioned that it is very important to assess the coagulopathy before taking the patient for surgical intervention. And why this is so important? Because early detection and hemostatic monitoring minimizes the most important adverse effect, that is the secondary brain injury. And any patient who comes with traumatic brain injury, the main aim of neurosurgeon as well as neuroanesthesiologist is to minimize secondary brain injury. So regarding traumatic brain injury and coagulopathy, the famous CRASH-2 trial was there, where they found this is a clinical randomization of an antifibrinolytic in significant hemorrhagic trial. We discussed about the use of tranexamic acid in obstetric patients. The CRASH-2 trial also assessed effects of tranexamic acid in reducing hemorrhage in patients who have head injury and who comes for neurosurgical intervention. This study was famous and was known as CRASH-2 intracranial bleeding study. This study examined effects of tranexamic acid on intracranial hemorrhage in traumatic brain injury. This study showed beneficial effects of early administration of tranexamic acid that was within 3 hours, and it has mentioned that it may improve outcome. The CRASH-3 trial was published recently in the Lancet, where they again examined effects of tranexamic acid, and results of CRASH-3 trial showed that tranexamic acid is safe in patients with traumatic brain injury, and that treatment within 3 hours reduces head injury related bleeding and death. So patients should be treated as soon as possible after injury with tranexamic acid, and it is advisable to give tranexamic acid within 3 hours after injury. Many a times patients are on heparin. They may be an unfractionated heparin or low molecular weight heparin. For unfractionated heparin, it is better because of its short duration of action and the effect can be reversed with protamine. For low molecular weight heparin, the advantage is there is no monitoring required. For unfractionated heparin, you need to monitor the APTT round the clock. But in patients who have high risk of bleeding, it is always better to put these patients on unfractionated heparin, as you can always reverse the unfractionated heparin. What about the patients who are taking double antiplatelet therapy? For elective surgery, stop these drugs prior to surgery. Bridge the patients with heparin. Low molecular weight heparin are usually starting 2 days after cessation of warfarin, and a last dose should be given 24 hours prior to the procedure. Post-operatively, warfarin is restarted, and concomitantly, low molecular weight heparin is given, and it is continued till INR reaches therapeutic value. For high bleeding risk procedures, that is for neurosurgical intervention, most of the neurosurgical interventions are high bleeding risk procedure. It comprises, as I said, most of the neurosurgery. So anticoagulants should be stopped before elective surgery. For warfarin, 4 to 5 days before surgery, and for all novel oral anticoagulants, they should be stopped 48 before surgery. Usually, patients have to take these double antiplatelet drugs after coronary stenting. If they have drug-eluting states, they need to take these double antiplatelet drugs for almost 12 months. And if there is a bare metal stent, then it has to be taken for 6 months. It is reasonable to postpone surgery, elective surgery for that time. But if you need a neurosurgical intervention in emergency, then there is no definite guidelines, but we need to consider the opinion of cardiologists, and we need to tell the patient the probable risk that is there because with this stenting, and the bridging therapy should be undertaken with advice from the cardiologist, and we need to do the life-saving neurosurgical intervention at the same time telling the risk of thrombosis of the stent to the patient's relative. Bridging with eptifibride was suggested for general surgical procedures, and might be a suitable option for neurosurgery, but there are no published data at the moment on this drug. So for emergency surgery, we may consider platelet transfusion in an emergency. Drugs like desmopressin and cryoprecipitate, if available, are also useful. Desmopressin, it raises factor 7 as well as von Willebrand factor, increases platelet adhesiveness, and it can be given in a dose of 0.3 microgram per kg body weight. The next important aspect we discussed about traumatic brain injuries. The other important aspect is about brain tumors and coagulopathy. These patients can have hypercoagulable as well as hypocoagulable state. The coagulopathy can develop while the surgeon is operating on the brain tumor. When he is manipulating the tumor, there is release of tissue plasminogen activator, and patient may develop DIC intraoperatively. This is more common with patients who have glioblastoma multiforme. They show plasma hypercoagulable profile, and this is related to adverse outcome in patients with GBM. Studies have showed that the coagulopathy worsens the surgical status of a patient who has glioblastoma multiforme. Another important situation, cerebral venous thrombosis. The choice of treatment in patients who have CVT is heparin, either a low molecular weight heparin or unfractionated heparin. Because of impaired venous return, these patients have raised ICP, midline shift, mass effect. There is development of cerebral edema and herniation. These patients respond extremely well to drugs like heparin. But it is always advisable again to start unfractionated heparin, monitoring APTT very regularly. But these patients might need emergency neurosurgical intervention if there is a midline shift, mass effect, deterioration in the neurological status of the patient, and these patients of CVT may need emergency neurosurgical intervention when the patient is on heparin. But we have done many the patients, the anesthesiologists who are dealing with neurosurgical cases have done this kind of cases. But since these patients are on IV heparin, the reversal agent is also available. But by the time, what my experience is, by the time we decide about the surgical intervention, most of the times, and we arrange for fresh frozen plasmas, by the time everything is prepared for surgery, the effect of the PT-INR also comes to normal by that time. So these patients are always tricky and challenging for the neuroanesthesiologist, as the main line of drug of treatment for this patient is an anticoagulant. So let's see, for the reversal of heparin, you can give protamine sulfate. Reversal of low molecular weight heparin, this is, I haven't used this drug. I haven't seen also whether it is available or not. I inquired, but I don't think it is available at my place. It is adnexanate alpha that has been preferred for reversal of heparin. For reversal of warfarin, I have already said vitamin K plus 4 factors of PCC. Check PT-INR at 1 hour, 6 hours, and 24 hours after 4 pints of PCC. If INR is less than 1.5, you can give additional 4 points of PCC or 2 to 4 units of FFP. If INR is more than 1.5 at 6 hours, you can 1.5 at 6 hours, you can give vitamin K. Usually, since PCC is not available, usually fresh frozen plasmas are given. 4 pints are given at a stage. Then we repeat INR, and depending upon the INR status, we advise more FFPs, and vitamin K is started as soon as the patient is planned for emergency neurosurgical intervention. As I mentioned, for dabigatran, though there is no anti-reversal agent available for neurosurgical intervention, but they have mentioned that oral activated charcoal is advisable, and few studies have found that idursulfimab is also have been, I am not able even to pronounce it drug because this drug is not available at the moment with us. It is idursulfimab, that is 5 gram IV, that has to be given depending upon the when the last dose of dabigatran is given or not.
So again, I inquired about this drug. This drug is not available at the moment in India with us. But these are the guidelines that has been recently published regarding the reversal of these drugs. So I thought since we are dealing with this important topic today, so at least we should know these drugs so that when they become available, we should be able to use them. Again, for drugs like rivaroxaban, apixaban, endoxaban, and metrixaban, the same oral activated charcoal is advised, and the same adnexanate alpha is also advised for these patients. And also they have mentioned that these drugs can be removed even by dialysis. So this was, as I mentioned, this was published in Stroke Vascular Neurology Journal in the year 2020, very recently, and most of these drugs are not available in our setup. So coming back to these two cases, the first clinical scenario where this patient had a massive intracerebral bleed. This was the scan done on admission. The patient worsened neurologically in next 24 to 48 hours. We thought that this patient is going to need neurosurgical intervention. As I mentioned you, this patient was on warfarin. So we reversed warfarin. We gave him his cardiac status was normal, though he had underwent a bypass surgery. His cardiac status was normal. So we gave him 8 units of FFP along with vitamin K. We repeated for the first INR was around 4.5. Then after giving 8 units of FFP, the INR came down to 2.3. And then we again gave him 4 units of FFP. So this happened over a period of around 24 hours. And we decided that we will operate this patient. Then once the INR was below 1.5 and with good platelet count, with good normal APTT, we operated this patient. This patient did extremely well after surgical intervention, though he had a long course in long stay and long duration of hospitalization because of the hemiplegia and hemiparesis which he had developed. He needed tracheostomy and a long stay in neurosurgical setup, but then he went home and he did extremely well. Second case scenario, as I mentioned, there was a bleed in the spinal cord. So this bleed, because of this bleed in the spinal cord, it was a huge bleed extending from the dorsal to almost lumbar region. So this patient was again, he had received, as I mentioned, streptokinase for cardiac stenting. The cardiological assessment done at our setup mentioned that he has a normal ejection fraction. His APTT was prolonged, his PT-INR was prolonged. PT-INR was borderline, but APTT was prolonged. We gave him again fresh frozen plasmas. We explained the high risk to the surgical relatives because the patient had already developed paraplegia. There was no sensations also. But this patient also did extend. We operated him in 8 to 10 hours when the APTT was in normal range and PT-INR was less than 10. The most I must say that the most the positive thing for this patient was the cardiologist mentioned us that his cardiac status is normal, though he has underwent maybe because of that stenting which was done very recently, almost only 24 hours back, but he didn't have any cardiac problems intraoperatively, neither postoperatively. His power slowly improved. When he went home, his power was he was able to move his toes little bit, but not that very well. But at the end of now 2 months follow-up, I saw this patient coming into our neurosurgical OPD with walking with support, and I was really happy for the whatever work we did. The neurointensivist, the neurosurgeon, as well as neuroanesthesiologist for this patient, taking into the risk of bleeding as well as taking the risk of whatever complications that were related to his recent cardiac intervention that was done recently. So, though these cases are very challenging, the effective communication between the neurosurgeon, hematologist, neuroanesthesiologist, and neurointensivist is very important in managing all these cases. For elective neurosurgery, you have to plan the reversal. That is not an issue, as most of the cases who come for other surgical intervention also. For neurosurgery, we have to do for elective neurosurgery. But emergency neurosurgery is very challenging. Depending upon the urgency of neurosurgical procedure, anti-reversal coagulation has to be planned. It has to be planned in such a way, very aggressively, by by all the specialty doctors, so that we operate the patient in that safety margin where either the neurosurgical intervention will be beneficial to that patient, whether it is intracranial bleed or intraspinal bleed. So as I mentioned, multi-pronged approach with consultation of hematologist, neurosurgeon, neurointensivist, and neuroanesthesiologist is very crucial in managing this kind of cases. Thank you very much for patient hearing, and I think this topic is interesting. And with Mule Madam at the chair, with along with Dr. Iratwar as a excellent neurosurgeon practicing in Wardha, I think the topic will create interest in many listeners, and we will have a good discussion on this topic. Thank you very much. Thanks for patient hearing.
Thank you, Manisha. Very nicely said, very nicely put. There are a few questions there in the on the chat box. If you would want to take them, this one is this one. Sometimes a massive traumatic head injury, common coagulation profile like PT, APTT platelets are normal and no history of bleeding tendencies or anticoagulant treatment. Still, patient shows massive bleed. Would you want to make a comment about this and advise something, anything more to be done? What would you say about this?
I'll just go through that patient because it is sometimes in massive traumatic head injury, common coagulation profile like PT, APTT platelets are normal and no history of bleeding tendencies and anticoagulant treatment, and still patient shows massive bleed. Should we advise INR and D-dimer? Madam, if we do PT, usually we get INR. INR, rather than prothrombin time, it is always advisable to do INR. And if the INR is less than 1.5, it is always advisable to allow this patient for neurosurgical intervention. There may not be a massive bleed because of coagulopathy. Then second thing, what you said is about D-dimer. Most of the patients who come with traumatic brain injury with polytrauma with multiple fractures, usually they have D-dimer positive. So we should expect when such patients come, we should expect that these patients are in coagulopathy and we need to keep fresh frozen plasmas ready. And even if the INR is normal, the D-dimer, the D-dimer has to be done in such patients. And I think keeping plasmas ready, or in fact transfusing the plasmas also, because if there is a massive blood loss, then we need to give fresh frozen plasmas, and along with that even vitamin K will be helpful in giving such patients.
Dr. Manisha, I really wonder if we can arrange fresh frozen plasma for all head injury patients. I think what the question means is that in spite of not having any risk for excessive bleeding, some patients might show a lot of bleeding in head injuries. And it is, if I think your observation would be the same, then sometimes we wait for head injuries, don't operate them immediately. Sometimes they remain on ventilator, or they may be posted for surgery 3 or 4 days after initial trauma because they become worse. Sometimes we find that the bleeding is much more in such patients. Would you like to comment about this?
Yeah. Madam, if there is a excessive bleeding, there is no other option left at the moment other than arranging for fresh frozen plasmas. Normally, we do not arrange fresh frozen plasmas for every patient of head injury. But if that's why the most important aspect is to do again a coagulation profile when the patient is taken for neurosurgical intervention. And that is the most important thing. As I mentioned in my slides also, that we need to do, because so many times patient comes on first day with a Glasgow Coma scale between 13 to 15. The neurosurgeons are not interested in operating. They observe the patient, but when with increasing size of hematoma, increasing size of hematoma may be also an indication of underlying consumption coagulopathy. So it is very important to take the patient before taking the patient to do routine coagulation profile, repeat everything. And if you find something abnormal, wait till the coagulation profile comes normal. If it is a dire emergency neurosurgical procedure, then go for fresh frozen plasmas, transfuse them intraoperatively. That is only going to help your patient to save from excessive bleeding.
May I ask you to elaborate on one point, Dr. Manisha?
Yeah, ma'am.
There can be a lot of bleeding in other neurosurgeries as well, massive bleeding. Would you or the next speaker would want to talk about massive blood transfusions and very clearly indicate what should be done, What is the ratio? Would you like to just spend 1 minute on saying that?
Yes,
Talking
madam.
about it?
Madam, I think for neurosurgical patient who is bleeding excessively, blood loss should be replaced with blood loss. But there is a consumption of coagulopathy, consumption coagulopathy. So same time 1:1, one blood along with one fresh frozen plasma. The ratio should be 1:1. And if there is excessive bleeding and if platelets are available, platelet-rich plasmas are available, then it should be 1:1:1. That's what I would recommend for a neurosurgical intervention.
Right. Thank you, Dr. Manisha. There are a few more questions. This one says, we had a patient left hand arterial thrombosis undergone thrombolysis with streptokinase and hemorrhagic infarct developed, operated craniotomy, 5th fundoxaperin on 7th day, had intracranial bleed and not recovered. What is to be expected in these type of patients?
Yeah. The question mentions that the patient had developed left-hand arterial thrombosis, who was given streptokinase. He developed brain infarct. Craniotomy was done.
He has
was
embolized
embolized.
everywhere. He has embolized
Yeah.
everywhere, isn't it?
Yeah. So the basic was the monitoring of coagulation. Why did the patient die? Again, he had intracerebral bleed. Maybe then the monitoring of coagulation profile has to be done very meticulously in such group of patients who are receiving thrombotic agents and that is and antiplatelet agents and who need emergency neurosurgical intervention. So close monitoring of all coagulation profile. The basic monitoring, I may not say you should go for rotational thromboelastometry in every patient or elastography. It is not available everywhere. So the basic monitoring that has to be done is PT-INR and APTT. A patient who is on antiplatelet agents, patient who is on heparin, this monitoring should be done every 6 hourly. For APTT, every 6 hourly if the patient is on heparin. And if you are able to, and you adjust the doses of your heparin according to the doses of APTT that you get. So that is more important. The patient value has to be kept within 1.5 times of the control value. And you have to monitor this frequently and adjust your heparin doses accordingly. You have to, So APTT, normally we give unfractionated heparin in such kind of patients who have developed, who have a tendency to bleed, because then you can stop the heparin immediately. You can monitor the APTT. You can stop the drug drips immediately as soon as the APTT values are raised beyond 1.5 times the normal range. So very thorough monitoring, close monitoring with a watch on APTT levels has to be done for those patients who have a high risk of bleeding and who are on heparin.
Thank you, Dr. Manisha. Dr. Sandeep Peretwar, you would like to comment anything?
Yes, it's always a panic situation whenever it's bleeding. In the intracranial whenever neurosurgery is happening, and
And
Dr.
neurosurgeons always want to even catch hold of an RBC also, because they want a clear neurosurgical field at the end.
We don't want any post-operative bleed. That's the reason. And thank you so much, ma'am. You have covered almost all aspects of coagulopathy in neurosurgery. And
I would like
it's
Dr.
always a
Sandeep.
pleasure to hear. Yes,
Can I
ma'am.
say one thing, Sandeep? I would like
Yeah.
you to tell to everyone, because everybody may not, all anesthesiologists may not be practicing neuroanesthesia, right?
Right.
But I would like you to point out which other, spine surgery, otherwise you can have a lot of blood transfusion and blood loss and blood problems. Would you want to speak a few words about that?
You want me to speak on bleeding
Just
during surgery?
Which cases in spine surgery, tubercular surgery, spinal cord tumors, you would want your anesthesiologist to be very wary about lot of blood loss? I would want you to just say a few lines about that.
Yeah, thank you so much. I think I don't know everyone knows about Dr. Shubhangi More, ma'am. She's one of the senior most she's practicing neuroanesthesia since more than 3 decades, I guess, at SIMS Hospital. And even Dr. Katikar sir, madam, both are practicing together in Solapur. And it's a pleasure and honor to chair the session along with you, ma'am. And for others, I would like to tell that neurosurgery, bleeding, the positioning matters a lot, as you have experienced. So position can control the at least intracranial bleeding to some extent whenever it's a venous bleed. And as far as spine is concerned, again, if you're operating in prone position, because of extra the venous pressure, it oozes a lot, and it becomes difficult when there is excessive epidural veins. But most of the time, it can be controlled just by irrigating it, by putting some soft gel foams and the Surgicel and the other methods of hemostasis and the patients. But if you're operating on some spinal tumors, particularly the metastases from renal cell carcinoma or thyroid, then it becomes
it's a nightmare.
challenging. Yeah, it's a khatarnak. Yeah.
So, and I would like you also to mention your experience, and Dr. Manisha also, about lot of blood losses in children. You know, that can be totally horrifying. You know, Dr. Manisha, also, I would like you to say what is your experience about that, because that can be challenging also, very, very challenging.
Yeah, recently I just would like to mention about a case. Last week only I operated 2 years child who fell from the height of first floor, 12 feet. And she came to us within few hours, and the scan was showing the hyperacute subdural hematoma and with a significant midline shift.
Yes, yes.
And when I opened it, there was hardly any blood clot, but there was so much liquefied blood, what you call it, hyperacute. And as soon as I decompressed, it started oozing from everywhere, and it takes a lot of time to control such kind of bleedings. So I don't know whether it behaves differently in pediatric age group compared to adults. Any experience?
No, it doesn't behave differently. It is too much more horrifying because the scalp bleeds like hell. And the child has such a little weight that, the transfusion is always massive. And it is almost as if we start resuscitating inside the OT itself. And, I think Dr. Manisha also must have had such kind of experiences in her career.
Yes, madam.
Would you like to say something?
Yeah, madam. There is massive bleeding, as sir said, Dr. Radwar said very correctly that such kind of subdural hematomas, they bleed massively, and for pediatric patients, the blood loss is very, very important. It makes a significant loss in the hemodynamic status of the patient, or when there is a massive blood loss, there is a hypotension, and we do not want hypotension in a neurosurgical patient.
Absolutely.
Especially, madam, so many times for patients, the babies with brain tumors, especially when we operate them in prone position, the posterior fossa tumors, they also bleed a lot. So in such situations, madam, what practically I have seen is that I start the blood, like whenever I see a pediatric patient coming with massive bleed, intraoperative, massive traumatic bleed, or a massive tumor, then I start blood right from the skin incision.
From the first moment.
Yeah, right from the first moment, because even a 5 ml of blood loss is significant in that a baby who is a 1 year old or a 6 months old who is undergoing such neurosurgical intervention. I usually give blood, maybe whether this practice is ethical or not, I don't know, but it has saved many of my patients. So I would like to mention this practical point here. I give blood through syringe pump. And I give the blood through syringe pump. So whenever there is a massive blood loss, I can increase the rate of transfusion to almost 100 ml per hour. And because, or many a times even to 200, because that is the only syringe pump is only available at the moment with us, which can give blood, which can transfuse blood so rapidly, and it can save the patients. There is a risk of giving blood without filter, but so many times I've seen 2-3 times the babies are saved when I give blood through syringe pump. So that is the practical point I would like to mention here. Start the blood right from the beginning, where you expect massive blood loss in pediatric patients who are undergoing neurosurgical intervention. And at the same time, you start, you can use the bolus doses along with the syringe pump. So if there is a 10 ml blood loss, give 10 ml of blood immediately. Replace 1 ml of blood with 1 ml of blood transfusion only. So
Yeah.
that can be the, I think, the practical point, and it has helped me in saving many patients intraoperatively when there is a massive blood loss.
Yeah, that's right. Even if there is no external blood loss in this particular baby, the intracranial bleeding was just 100 ml, but this pediatric age group do not compensate usually, and hemoglobin was 5. And so with appropriate management, absolutely child became well, and we could discharge in a week time, and that thanks to anesthesia team and
No,
neurocritical team.
I would also like to mention that, remember, for all anesthesiologists who are doing any kind of neuroanesthesia, babies do very well. We have to be very, very proactive with them. They may be very bad prior to surgery, but they do extremely well, and therefore nothing, and they become very hypothermic. So we should proactively ventilate them. That is also important. Right.
Yes, ma'am.
You mentioned correctly, madam. Babies coming in a very bad neurological status with severe head injuries do extremely well after surgical intervention, and they go home happily. They have a great immunity, and I think many papers are published on this, even in neurosurgical journals, regarding these babies doing so well after a bad head injury or bad neurological status also.
Yes.
Ma'am, can we continue discussion after the last talk of the day?
After
I think
the next one.
Dheeraj Bhandari is also waiting. And hope Dr. Katikar ma'am and sir had a great time in Wardha, where we had organized
we
a
enjoyed. We
conference.
enjoyed it thoroughly. We enjoyed.
Thank you so much.
Miss meeting
Here,
Mole madam, but we enjoyed the conference.
yeah. Ma'am was busy in theater because Singh sir was here and others were there. So here I take opportunity to thank organizers and welcome next speaker, Dr. Dheeraj Bhandari, who is a professor of anesthesiology and consultant intensivist at MGIMS Sevagram. And he's also a nodal officer of NELS Skill Lab project at MGIMS Sevagram. He has a fabulous academic career. He was a WHO international consultant of ICU at Timor-Leste, and he was also a national ISA COVID-19 task force member. And his areas of interest and specialized area is obstetric anesthesia, ICU, and quality improvement. And he is a recipient of many awards. He had received gold medal during his MD anesthesia in 2010, and DCCM topper of ISCCM. And he is also a recipient of Young Talent Hunt Award during Criticon 2015 and ISH Nareni Award at ISACon Jaipur. He has been he has contributed as an expert committee member to various organizations of government of India, and he has contributed extensively for policy making, and he has 13 publications to his name with 5 original articles. I request Dr. Bhandari to talk on his topic, complications and post-operative critical care management with a deranged coagulation profile. Dr. Bhandari, please.
Are the slides visible, sir?
Not yet.
Sir, the slides are not visible, sir.
Yeah. Yeah, it's visible now.
Now they're visible, sir.
Yeah. I'll probably switch off my video for a better quality. I'm just a sort trying to get to the. Shall I relog, sir? I'll give it a try. I'll relog in 1 minute, sir.
Okay, no problem. Till then, we can have one question for Katikar ma'am or Mure ma'am who can answer this question. We have seen nowadays many cases with a drug-induced coagulopathy, and it's very common. I think Dr. Mayuri Gollar had a question. Dr. Katikar would like to answer. How early to start antiplatelet drugs after surgery if a patient is already on antiplatelets perioperatively?
It is advisable to start the drugs as early as possible till our neurosurgeons allows us, till the drain is removed. It is advisable from anesthesia or from intensivist point of view to start the drug as early as possible. But if the neurosurgeons do not want, because of there is a risk of bleeding, and if the neurosurgeons do not want to start it immediately, then it is always advisable to bridge the therapy, give heparin. You can continue with heparin until the neurosurgeons, if the drains are removed or till the neurosurgeons are happy with the hemostasis, whatever they have achieved post-operatively, they want to do the post-op scan 24 hours after the surgery. Till that time, you should bridge the patient with low molecular weight heparin. That's what I can suggest.
I think that is the practice. I think that is the practice that is followed in our ICU also. The next day when scan is done, if things are all right and no bleed or anything, then they will start LMWH on the next day. And then subsequently go on to the routine therapy, whatever it is.
Right. Dr. Bhandari is ready.
And usually if the patients are on clopidogrel or aspirin, and if the patient undergoes surgical intervention like a spine surgery, we start it from second day, sir, because there is no risk of bleeding. Surgeons are happy. If the patient is made mobile on second day, then we start it from second day. Or clopidogrel and aspirin.
Okay. Is Dr. Bhandari ready with the presentation?
Sir is not able to share his screen.
Do you have his presentation uploaded on your computer? You can play the presentation if possible.
Yes, sir. We can play the presentation from our side.
Yeah.
Hello, am I audible, madam?
Yes, you're audible.
Yes, sir, you're audible.
Thank you, thank you. I'm doing it through my mobile device. Pardon me for the same.
No problem. You are very well audible and your slides are visible.
Yeah. So, first of all, good afternoon, everyone. Respected Muralidhar Joshi, sir, Dr. Diwatiya, sir, Dr. Manisha Kartikar, madam, respected chairpersons, Mule, madam, and Irith, sir, all seniors, organizing team. I thank for this wonderful opportunity to talk here. And it indeed has been a wonderful delight to hear all the talks in the morning. And it has probably made my job very easy. So when somebody says me to manage a post-operative patient or in a critical care setting, it basically is to know what is the physiology, to understand the pathology, and then to deal it with the knowledge of pharmacology of the drugs in various conditions like obstetrics, neurosurgery, and regional anesthesia, and probably taking it over further to individual level of management. So it becomes very easy after all the morning tasks. At the same time, it gives a bit of challenge that what separately are we going to do in the critical care setup. If we can have a slideshow, please. We can go to the next slide. Next slide, please. Yeah. So as we so we all understand that this is going to be a very vast topic, basically post-operative critical care, and especially for a patient with coagulopathy. So I'm not going to deal with every nuances, but I'll try to restrict in certain few important examples. Second important thing, when we talk about coagulopathies, it is important that we understand that there's a balance between thrombosis and bleeding. Many a times we talk about bleeding, but we try I would not say like intentionally forget, but over a period of time, the bleeding takes probably more precedence over the thrombosis. So we'll try to see if we can have some sort of a syndromic approach. And then third and most important thing is, when we say managing a critical care, we all understand critical care is evolving significantly over a period of time. It is one of the most resources consuming thing. There are a lot of new things which are coming over a period. And the most important thing for this is that we need to understand that what is an ideal resource and what are the available resources. For example, what investigations I have, what blood products I have, and what are the ideal things which can be there. And then trying to make a balance out of whatever best is available with us. Next slide, please. So as we all understand, before we go into this depth of this topic, we understand clearly that there is an ample amount of evidence where it's clearly mentioned that a coagulopathy in an ICU, be it irrespective of medical or surgical problem, it increases the morbidity and mortality for the patient. So that's very important for us to understand. And it is both ways. It is equally important that for a thrombosis, that also increases the morbidity and mortality. And also for a bleeding patient, a coagulopathic bleeding patient, that also influences. This is a very wonderful article which had come in 2021, which very clearly showed an impact that a patient who has a bleeding or a coagulopathy, even to the fine tune of say just a hemoglobin drop to somewhere around 7 gram percentage or requirement of 1 PRBC, it was an independent factor associated with mortality. So we need to understand that whenever there's a bleeding, it is something which we all need to take up seriously. Next slide, please. Now, these are the three scenarios we can have. That is, we have a coagulopathy either in the preoperative period, or preoperative was normal, but we developed intraoperative coagulopathy, or the patient was normal in preoperative and intraoperative stage, but the patient developed coagulopathy in a postoperative phase. So when we say preoperative coagulopathy, there can be multiple things. We have had so many examples since morning. For example, a trauma patient comes who is being resuscitated in emergency medicine department, and there has been massive transfusion protocol being initiated. But even before that, there has been significant dilutional loss. That is a preoperative coagulopathy. There can be hereditary disorders. There can be patients who are on multiple medications. For example, warfarin in a patient with a rheumatic heart disease, and there might have been certain changes, isn't it? Over-the-counter herbal medicines, a very important and often neglected cause for preoperative coagulopathy. Liver disease patients, uremic patients, sepsis patients, these are all patients which can present with preoperative coagulopathy. Now, imagine a preoperative has been normal, but the patient develops intraoperative coagulopathy. Very classic in our setup will be a patient who suddenly develops a significant amount of hemorrhage, a spine surgery, a postpartum hemorrhage, an abdominal surgery with some vessels opening up, a cardiac surgery. So this is very common. And an inherited disorder which has been manifested on table. Very commonly it happens. We heard Aruna madam giving an example in the morning. Tonsil patient, nothing abnormal, to come to the theater, tonsils removed, the patient had sort of a bleeding, and then later diagnosed to have an inherited disorder of coagulation. Now the third scenario, the preoperative was normal or intraoperative was normal, or probably there were certain risk factors, but the patient developed coagulopathy in the postoperative period. And the most common reason is the sepsis or DIC, which can become very common. There can be certain medication errors or the powerful medications which we use. For example, we need to be very clear in our mind that all the medications which we are using for hemostasis, say the thrombin inhibitors or oral newer anticoagulants or warfarins or heparins, they are very powerful drug, and they have a certain window over a period of time when there might be a different bioavailability, and we might see that the same thing which we are given to prevent a thrombosis might lead to excessive bleeding. So the reason for this slide here is very clear, that we need to understand where we started so that in post-operative ICU, we'll be able to manage it. Next slide, please. Yeah. So now, what are my concerns as an anesthesiologist or intensivist for post-operative concerns for a coagulopathic patient. Anesthesia concerns, a specific hardcore anesthesia concerns, for example, neuraxial complications. I have a patient who is on some sort of anticoagulant. I have decided to use a neuraxial anesthesia, epidural and spinal hematoma becomes a concern for me. So I need to keep on looking into that. Again, if I'm doing some procedure, for example, putting a central line, putting a tracheostomy, my coagulation parameters become very important for me, especially when I'm doing that in intraoperatively or in the ICU. Now, the another concerns for intensive care specialists especially will be ongoing coagulopathy and its management. Then monitoring this coagulopathy. How is this coagulopathy evolving? And then the last thing is specific diagnosis and treatment. So that becomes very important for us to understand. Next slide, please. So as I was saying, thrombosis and bleeding, they're probably the different spectrum of the same patient. It's a very tight hemostatic process in the body which is happening, and in between somewhere we'll have a DIC where there will be something like thrombosis and bleeding which is going on. So if I am an intensivist who is looking towards a ICU patient, even otherwise, when I'm looking for a coagulopathy, if there is a coagulopathy which is developing, this is going to be my broad outlook, that whether my patient is developing some sort of thrombosis. A thrombosis can again be a major vessel thrombosis, or it can be a micro thrombosis, which is going to affect my organ dysfunction. And secondly, it's going to be the bleeding. Again, bleeding can be a clear-cut overt bleeding, or it can be bleeding inside the organs where it might take certain time to manifest, and you will have to be really vigilant for it. For example, a GI bleed manifesting as fall in hemoglobin, an intracranial bleed in a patient in ICU, and if it gets undetected for a period of time, especially if the patient was sedated, paralyzed, then it becomes a catastrophic thing. So this is going to be my outline, how I am going to manage a patient. Next slide, please. Yeah, so the general outlay becomes very clear, irrespective of whatever I am doing, especially if you are a new anesthesiologist, intensivist, and you are in the ICU, always remember, irrespective of whatever emergency comes to you, don't forget the basic ABCD approach, where a simultaneous resuscitation and evaluation is important. Remember, airway and breathing can kill faster than circulation and faster than disability. Very important that we have a multidisciplinary involvement with anesthesiologist or the intensivist leading from the front. So that becomes very useful and critical. There are significant literature to clear-cut point out that a closed ICU has better patient outcomes as compared to an open ICU model. I need not emphasize it furthermore. Important thing for us is to follow the norm, that is less is more for transfusion of blood and blood products. Thankfully, over a period of time, especially since we have started to optimize our resources, we have started to have practicing restrictive transfusion strategies, and which has been shown to clear-cut have a major morbidity and mortality beneficially outcomes for the patient. So important thing is that less is more, and we need to be very clear on the same thing. And last important thing which I would like to say is that trying to move from our routine, not exactly sort of surpassing them or not exactly replacing them, but starting to use more and more point of care assays, especially point of care coagulation assays like ROTEM or thromboelastogram, along with probably your traditional ways of coagulation will be very useful. There is a clear-cut ample amount of literature, especially in cardiac surgery patient, and then probably into trauma as well, where they say that point of care assay test, initially there might be a significant cost associated with procurement of device and everything, but the cost associated with the decreased amount of blood products being used is something which will make it as more and more cost effective. So we should try and move more and more toward point of care as a testing functions. Next slide, please. So patient evaluation, the history and examination becomes very important to look between the bleeding and thrombosis. Then this will be followed by a diagnostic workup, where we can use point of care coagulation assays and conventional testing. And then important to move from an empiric treatment Empiric treatment is very important in an acute setup. For example, massive transfusion protocol is an empiric treatment. So when we don't have the results at the start, a massive transfusion protocol becomes very clear cut. It's an emergency. We don't have a clear reason for bleeding. Initial empiric treatment is very important. But ultimately, the whole idea, especially in ICU, should be goal-directed treatment, including the transfusion practices, and to be very clearly aware about the medications which can modulate the hemostasis. And then it doesn't stop there. We keep on re-evaluating ourselves with history and diagnostic workup. We see the trend of the investigations. We see the trend of the clinical evaluation of the patient and see how the patient is responding to our treatment. Next slide, please. So 3 important things for us to look into from ICU perspective. One is the venous thromboembolism. Second is the bleeding part of it. Third is the DIC part of it. And then another important part is when I'm doing special procedures in ICU, if there are certain indications for this. So that is what I'm going to talk about throughout the lecture. So coming to the first part, that is venous thromboembolism risk assessment tool. Now this is something which has to start in the preoperative period, but has to well continue into post-operative ICU period. These are wonderful guidelines, and probably whenever time permits, at least we should try to go through the executive summary of this guideline. These are 2019 and 2020 guidelines for management of venous thromboembolism, especially in surgical hospitalized patients. So if we can we go to the next slide? Now, this is a beautiful abstract from the AHA paper. And if we look at the 5 major areas of policy guidance, they say one is performing the venous thromboembolism risk assessment in an individual patient, then creating a benchmark for hospital comparison and pay for performance programs. Third is to improve the public awareness of VTE. Fourth is tracking VTE in a nationwide thing. And fifth is like an antimicrobial stewardship data. We should also have a centralized data stewardship. Now, this is probably still, we are probably at an early stage, at a very infantile stage for this thing. But probably one area where we should start focusing is we should start having a VTE risk assessment individually for our patients in ICU and in all surgical patients. So probably this is something we should be implementing over a period of time. Next slide, please. So the most common used score is Caprini risk assessment tool for surgical patients. There are numerous scoring calculators which are available. You can get into one of them, or simply you can have a pre-printed leaflet and you can do a easy scoring. Now the thing is, it is very nicely seen in one of the systemic reviews that if you have a Caprini risk assessment score of more than or equal to 8, a pharmacological prophylaxis is needed. But if you have a score of less than 6, which constitutes almost 75% of the patient, there is no benefit for pharmacological prophylaxis and it will cause increased bleeding risk. So this is again very important. So probably almost 50 to 75% of our routine surgical cases won't need a pharmacological prophylaxis, especially when we tend for an early ambulation. Now this is an extensive score. There are many other scores which have been used, like Padua score. Next slide, please. And there is another score, what we call as the improved score. That is the International Medical Prevention Registry on venous thromboembolism score. Now, similar to a thromboembolism score, we can also have a scoring for bleeding risk assessment. So that becomes very important. These are all very clearly available in the net and in the literature. So I'm not going to go into detail. But what is important to emphasize over here is that we need to organize some sort of structural way, some sort of protocolized way, where we talk the same language, where we have a same language to assess VT risk factors or bleeding risk factors in any surgical patient. Next slide, please. So again, I'm not going to go into detail of this thing, but a major surgery, which is without any high risk, a simple mechanical prophylaxis will do. A high risk major general surgery, pharmacological prophylaxis will do. In an orthopedic surgery, especially hip or knee arthroplasty, a direct oral anticoagulant or a low molecular weight heparin will be preferred. For major trauma or gynecological surgery, again, a pharmacological prophylaxis is there. And very important to note that major neurosurgery, TURP or radical prostatectomy, there is a suggestion against the use of pharmacological prophylaxis. The reason this is why I'm trying to emphasize this is something which will continue from pre-op and will well go into the post-operative period. We need to understand that this is not only the sole factor, the patient risk factors, as we have seen in any of the scoring, will also certainly help us into looking for how we have to decide further. Next slide, please. Next slide. Yeah. So again, a simple mnemonic like FastX BID, it has revolutionized, or probably it has made very important contribution to decreasing the morbidity and mortality in the ICU. And if you see, one of the important things, be it for medical or surgical patient, is to daily keep on evaluating in ICU whether my patient needs a thromboprophylaxis or whether my patient needs to stop the thromboprophylaxis because of the bleeding risk. Very important. You have your patient, you do your rounds in the morning and do your FastX BID. You won't miss whether your patient needs a thromboprophylaxis drug or whether you need to stop the thromboprophylaxis drug. As simple as it. Next slide, please. So that was something about venous thromboembolism. I'm not going to talk in detail about thromboembolism or pulmonary embolism in detail. That is like an ICU thing. That's a whole talk in itself. But one thing which I would like to pinpoint, especially in a post-operative pulmonary embolism, is that there are no very clear-cut guidelines. It's an individual decision. And the most important 2 or 3 things which we need to understand is, one, whether my patient has a hemodynamically stable or unstable pulmonary embolism, which is solely defined by hypotension. My echocardiography will help me. And we need to remember that thrombolytic is mentioned as an absolute contraindication in most of the exclusion criteria in the pulmonary embolism studies. But at least therapeutic anticoagulation can be given. And when we talk about thrombolytic for a pulmonary embolism in a post-operative patient, the decision becomes very, very individualized, understanding that the patient might bleed even to the other way around. So this is very important. Now coming to the second aspect, thrombosis is done, probably looking at the bleeding in the post-operative ICU. So bleeding risk assessment tools, we have seen already there was an improved score. Next slide, please. And there are lots and lots of other bleeding risk scores. So one of the important bleeding risk scores were one from the International Society for Thrombohemostasis, and then a second score was HemStop. And then recently there was a bleeding indicator, especially for surgical ICU. Use whatever you are comfortable with, but use the same score in every patient. And this is something which will decide daily in your patient how much of thromboprophylaxis you need to see and whether you need to be very vigilant about your patient having a bleeding or not. Very important. Next slide, please. So when we talk about patient evaluation about a bleeding thing, one of the most important features is persistent bleeding, and that is something we need to pay attention to that. Other than that, look into family history, look into medication history. On examination, look into ecchymosis, petechiae, hematuria, or prolonged bleeding from surgical drain, incision site, or puncture site. Very commonly, we will see this. Or look for jaundice, splenomegaly, any connective tissue disorders. And another important marker is unusual drop in the hemoglobin. So that becomes very important. 2 important points, especially in a bleeding patient, will be look for persistent bleeding and look for an unusual drop in hemoglobin. Especially intraoperative patient in a GA, a hematuria, or probably a surgeon is saying my patient probably bleeding more. It's something you really need to pay attention to rather than ignoring the lead of the call of the surgeon. Next slide, please. So we have seen the history part of it. How do you evaluate this particular patient? Especially the patients in bleeding, we will do a complete blood count, and a peripheral smear becomes very important. You will notice an unusual drop in hemoglobin, but peripheral smear will further tell you the type of platelets, whether there are any abnormal cells, and it will point it out to you as a particular etiology. When we talk about platelet count, thrombocytopenia is the most common coagulopathy in ICU. But important cause for at the same time is pseudothrombocytopenia when the Coulter is done, when there are platelets which are aggregating in the clumps. So peripheral smear really becomes very important. Again, if you remember, I talked about ideal investigations. I talked about available things. Platelet function analyzer is something, PFA, for example, 100 is something which is very ideal, but very difficult to have in our resource limited setting. Next slide, please. So we saw CBC, we saw hemoglobin. Then we come to our conventional pathways of PT and APDT. There has been a detailed discussion throughout in the morning. I won't go into the details. But if you look into the pros and cons of PT, APDT, the pros are familiarity of all the staff with an interpretation of PT, APDT, ease of availability, very easy to repeat it again and again. That becomes pros. But the cons is something like it investigates only a narrow part of coagulation. It is not looking at the coagulation system in the whole. If you remember the talk in the morning about the physiology, it was originally designed for clinical monitoring of anticoagulant and not exactly for coagulopathy. And if you look at the point of coagulation, point of care test like TEG or ROTEM, there are slightly inferior results with PT and APDT. Having said that, it is the still most important armamentarium in our day-to-day practice. Next slide, please. This is very important. All of us now understand what a thromboelastogram look like, but just to point it out, I'm sorry, I'm right now on mobile. I'm not able to use my pointer. But if you look at the initial part, that is the clot time, which is something like generation of the fibrin pathway or the coagulation pathways there. If you look at the green part of the slide, that is something where the fibrin and platelets start linking with each other. And that indicates how the coagulation pathway and platelets will be what's the current status of coagulation pathways and platelets. Then you have something called as the maximum clot strength, and it not only looks at the thrombin or the clot generation part of it, it also looks at the clot stability and how it is going to dissolve over a period of time. So it looks at overall picture, and then there are very clear-cut diagrams and clear-cut interpretations as to how you can give a particular guided therapy. That is beyond the scope of the current talk, so I'm not going to go into detail, but very important, wherever we have TEG or ROTEM thing, that is going to aid us significantly, and we should push our administration to acquire more and more of this test to improve the patient quality. Next slide, please. So again, the same thing, when we talk about coagulation, the screening test is APTT, PT, and thrombin time. Thrombin time is again not very easily available. For platelet, the platelet counts and the peripheral smear becomes very important. And probably all the rest of the tests are probably beyond the reach of a routine healthcare setup. Next slide, please. So this is how it will look like. Again, it has been discussed in very much detail throughout the session. But just to summarize, if you talk about low molecular weight heparin or fondaparinux, your PT, APTT, thrombin time, all will be normal. If we talk about direct thrombin inhibitors, you will have a PT, APTT, as well as thrombin time, which is prolonged. I have clearly highlighted. If you talk about vitamin K antagonist, that is warfarin, only your prothrombin time will be prolonged, where the rest of the thing will be normal. And if you talk about factor 10 inhibitors, your PT, APTT will be normal, but prolonged, but the thrombin time will be normal. Now, thrombin time is difficult for us to get into day-to-day practice, and at times that is why it's very difficult to differentiate between the thrombin inhibitors and factor 10A inhibitors. Next slide, please. So, having said that, we have looked into how do we approach a patient. We talk about clinical factors, we talk about investigation, and then we come to the causes, that what can be causes of coagulopathy in a critically ill patient. So very important to understand that there can be a secondary disruption of hemostasis. I'll come to that part, but then there can be three important things to understand. One is there can be consumption of either of the coagulation factors or platelets. There can be loss of this factor secondary to blood loss, or there can be decreased generation like in inherited disorders, or there can be drugs which are causing them to function in the wrong way. A three simple, easy way to remember them: consumption, blood loss, or decreased generation itself. Next slide, please. Now, this is the crux of whole management of the bleeding patient. This is undisputable. Acidotic patient, a hypothermic patient, and a hypocalcemic patient, despite whatever amount of blood or blood products you give, if you don't correct them always, it is difficult that you will achieve a normal hemostasis. Having said that, it's not very important that you correct pH by giving soda bicarb, but you correct the pH by trying to correct the underlying condition. And temperature and calcium is something which is very commonly ignored, either in intraoperative setup or in a post-operative setup. It happens very frequently in our operation theaters. We have a patient with massive bleeding. We start giving them fluids. We start giving them blood, which are cold, but we somehow fail to identify that while we are giving them, we don't monitor the core body temperature. We don't try to give them the warm fluids or level 1 fluid warmers, and the temperature drops significantly. So even for the time being, you are getting a hemodynamic stability, but when this patient comes to post-operative stay, you see that these patients have started deteriorating. They are going into DIC, and probably the anesthesiologist in the intraoperative period will start blaming the ICU physician. I send a perfectly normal patient with so much of blood transfusion, and you deteriorated the patient. And the intensivist will say, you sent me a cold and hypothermic and an acidotic patient, and despite the minimum stability, the patient deteriorated at the end of the day. I'm not going to talk in detail about the blood products, so I'll just try to skip them. I understand we are running late of time, but just to be important, we need to understand red blood cell indication, acute and non-bleeding, and transfusion triggers. Very important to understand that hemoglobin can be rechecked within 15 minutes to 1 hour after transfusion, especially if it's not acutely bleeding. And that is again going to give us a goal-directed way to understand it. Next slide, please. We have leukoreduction, we have irradiated RBCs, we have CMV negative. The reason I am mentioning here in today's post-operative thing is where we do organ transplantation, this issue becomes very important and we need to be aware. Again, a very common practice, at least in the olden days when I remember, we will say, no, get me a fresh RBCs. There is no advantage and it is a wastage of resources to get a fresh RBCs. The blood bank, let them manage it. They understand and they will give you the blood bank, which is most appropriate. Next slide, please. Plasma, as we all discussed since morning, it is one of the most misused components of blood product. But then there are clear-cut indications and then there are certain indications where you should not use. In an empiric therapy, massive transfusion protocol, 1:1:1. Severe liver disease or DIC with bleeding and invasive procedures, especially when the INR is a problematic thing. Plasma exchange, very clearly indicated. Warfare in anticoagulation, Manisha madam very nicely pointed out, plasma is not the first choice. The first choice is PCC, but many places PCC is not available and we do use plasma. The volume which has to be used is massive, and often if there is a specific factor which is not available. Next slide, please. Plasma, don't use in a clear-cut suspected deficiency factor. Try to use the same reversal of anticoagulation, bleeding of unclear etiology, and just to correct some INR, 1.8, let's try to correct an INR and we are using a FFP. It's not going to be useful. Next slide, please. Platelets, again, very important. When we talk about medical, we say less than 10. For example, right now there was a dengue season. We understand that the platelets should not be transfused unless and until it's less than 10,000, even 5,000. But for a surgical procedure, we need to have the platelet count of minimum 50,000. And for say, certain important neurosurgical or posterior eye procedures, we need to have platelet count somewhere around the 1 lakh. I'll come to invasive lines procedure. One important thing in, especially in ICU, remember your conditions like heparin-induced thrombocytopenia, TTP, HUS, DIC, APS. You will get a thrombocytopenia, but many a times they are thrombocytopenia with thrombosis, and you should not treat this patient with routine empirical platelets. You should be very, very vigilant about that thing. Next slide, please. Cryoprecipitate, a big source of fibrinogen. We have already talked about it in the morning. Next slide, please. We talked about PCC. Madam nicely explained about 3 or 4 factors. It's again very important for warfarin reversal. It's the first choice. If it is not available, then plasma becomes the first choice. Recombinant factor 7. Next slide, please. It's again costly, not easily available, but when you have an unexplained bleeding, unexplained rise in INR or specific conditions, it might be useful. Just for the sake of condition, especially in the post-operative patient, it becomes very important. Next slide, please. Now coming to the complications of blood transfusion, blood and blood products, because this will be something which will be more commonly seen in the post-operative period. Massive transfusion protocol, again, it's a whole detailed topic, but it's more commonly used in operation theaters and emergency department rather than in ICU. So I'm not going to talk into detail, but massive transfusion protocol, we understand it is 1:1:1. And then ultimately the idea is to convert an empiric massive transfusion into a goal-directed therapy using either PT, APTT, fibrinogen, CBC platelet levels, or thromboelastogram if we are having the same thing. We can have febrile non-hemolytic reactions, which can be managed very conservatively. Hemolytic reactions, especially because of ABO incompatibility, rare, especially with today's repeated cross-checkings and multiple checklists. But if it occurs, it can be fatal. Be aware. Allergic and anaphylactic reactions. And just a word about TRALI and TACO, that is transfusion-related acute lung injury and TACO. The reason I am emphasizing this is something you will see in the post-operative period in the ICU. And there are many times a diagnosis of exclusion, a supportive therapy is what is going to be required into this thing, isn't it? For example, if you use a fresh frozen plasma instead of PCC to correct a massive coagulation problem, you will need to use a large amount of volume, and especially this might cause a TACO. TRALI is something which is again going to be a problem for all of us. Next slide, please. Now coming, we have already seen thromboembolism, we have seen about bleeding. Now coming to the last part of it, that is the invasive procedure, that is central venous catheter. Now, when we said central venous catheter in ICU or in operation theater, the guidelines are not very clear. This is a very nice paper from 2017. And they have said, try to do a non-tunnel catheter, avoid subclavian vein. The most experienced user should do it. Wherever possible, you should do a USG guided. And the guideline says, platelet, again, more than 20, if they are 20,000, and if the INR is probably somewhere around less than 2.5 to 3, you probably need not correct the coagulopathy. But if otherwise, you can use the correction. And again, because of the fear of litigation, fear of unexperienced user, USG not available, we see that this is something which is more common and empirically more unnecessarily used. Next slide, please. Tracheostomy. Again, there are no very clear-cut guidelines, but probably a lower threshold to do. A platelet of 50,000, INR less than 1.5, something you have to do. Percutaneous is better than surgical in some data, but again, not very important. Now, again, because there was some change in the presentation, I'm not able to do it. Before I go towards the summarizing the whole thing, I just wanted to talk about the DIC. DIC is something which is missed often in this thing. As I told, DIC, two important things to remember. One is there is bleeding and thrombosis simultaneously going on because your factors are getting consumed and they are causing platelet aggregation. There is thrombosis, that is especially microvascular thrombosis. And in the secondary phase or in the delayed phase, you will start seeing a coagulopathy, and that is something we need to understand. Now, how do you decide whether my patient has DIC or not? Two only important things. One is you look for whether my patient has underlying precipitating cause for DIC. That is the first question we need to ask. Sepsis, major surgical trauma, neurosurgery, obstetric complications. These are all very clear-cut precipitating factors. So if I have a precipitating factor, next I go for the laboratory markers. And what laboratory markers I will do? I'll do three important things. One is the platelet. Second is the PTINR. That is one we are trying to look whether my thrombus or my platelets are consumed. Secondly, I'm looking whether my PTINR, other coagulation factors are consumed. And the third thing I look into is fibrinogen. And the fourth important thing is, while all this thing is going, what are the marker of thrombosis? A D-dimer level. And you get a score of more than 5, it is very likely that you have a DIC. But then what is the treatment for DIC? The treatment for DIC is treat the underlying cause and use coagulation, use the blood products only and only when there is a clear-cut chance of bleeding. And then you will try to maintain your platelets, say about 50,000. You'll try to maintain your INR less than 1.5. And that is the reason. Do not use tranexamic acid. Do not use heparin routinely. They are sort of a contraindicated in DIC. Now coming to the last thing, to summarize the whole thing. So basically, when I'm looking into an ICU perspective, I have to look into two things. One is bleeding versus second is thrombosis, and how do I manage to do this? And this is something which I have to incorporate in my daily rounds in ICU. I have to look whether my patient is getting bleeding or thrombosis into the patient. For example, you might have a patient of abdomen into ICU and you are just looking into abdomen. It doesn't serve the purpose. So managing a coagulopathy in ICU is a big risk. coagulopathy is independent factor associated with increased morbidity and mortality, and we need to do a balancing act of thrombosis and bleeding. You have to use validated scoring system. This is something which is very significantly missing in most of our surgical pre-assessment, in our pre-anesthesia checkup assessment, or into our ICU assessment. See if we can incorporate some of the scoring systems, very important. Always look into what resources you have for investigations, and they are not one-time resources. Your clinical history, your resources of your investigation, you have to see the trend, how they are behaving. Ultimately, you start with an empiric therapy in ICU when you don't understand a problem as to what is happening, but ultimately you go toward a goal-directed therapy, and this goal-directed therapy can be again based on hemoglobin, a platelet count, then a PT, APTT, INR, a fibrinogen level, and if possible, if you have a point of care assessment. That's it. And it should be an intensivist-led model who should lead this thing. But then, having said that, next slide, please. This is a teamwork. Absolute teamwork, a efficient lab service with an updated equipment, a fast turnover time, and a good external quality control validation is very important. If you all agree with me, PT-INR is something which is one of the most probably wrongly reported result, either because of wrong sampling or because of wrong delay in the sending the sample to the lab. Second is a modern resourceful blood bank transfusion medicine, which have the blood products probably in quantity as well as quality. Very important. And it goes beyond the routine PRBCs, platelets, and our fresh frozen plasma. And ultimately, you have to have a whole team which is working together, isn't it? Including the nursing and the support staff. Next slide, please. So as my boss always used to say, in ICU, it is very important to pay magnanimous attention to minute details rather than at times managing the magnanimous fancy things which occur very occasionally, very rarely. Meticulous attention to these minute details repeatedly over a period of time, every time you assess the patient multiple times in a day is something which is going to help us. And don't be afraid or don't be shy to ask for help. We should all be aware about our limitations and involve your hematologist or something, especially when it looks like whatever you are suspecting and the treatment is something which is not responding to the routine thing. Thank you very much.
Thank you, Dr. Dheeraj, for excellent evidence-based presentation. I just have a query, as you're also working in a Sevagram, and we do come across poor patients with spinal cord injury. So I just want to know your take on mechanical thromboprophylaxis versus pharmacological thromboprophylaxis, the financial aspect versus medical aspect.
Sir, you will very clearly agree with me, sir. If you look into the data, pharmacological thromboprophylaxis is any day superior to mechanical prophylaxis in most of the cases where it is not contraindicated. But the thing is, in patients like, for example, neurosurgical patients or patients where there is a possibility that patient might be bleeding, a mechanical thromboprophylaxis gives us some sort of an advantage over pharmacological prophylaxis. Again, if we talk about mechanical prophylaxis, there are two ways, especially when we are talking from the cost point of view. One is the simple, our crepe bandage or the stockings which we are using. And second is the sequential intermittent pneumatic cuff compression, and which is definitely much better than the simple stocking. But then having said that, the pumps come somewhere around 70,000 to 1 lakh. I personally still believe, sir, that in an intensive care unit, we should have a sequential pneumatic intermittent cuff devices. In long term, if you look at the number of patient quality days saved, the number of resources, it definitely balances out, and it is definitely useful, very useful, sir.
Yeah, when I say mechanical, it meant for this pneumatic sequential compressive prophylaxis only, because I don't think this crepe bandage and other thing works. But those paraplegic patients who is going to be paraplegic for next few months to years, those who come with a complete spinal cord injury, so it's very difficult to continue the anticoagulant drugs and the monitor the PTI. Many times they come back
Very much agree with you, sir. But then simultaneously, you might be also probably saying, now the things are changing. But if you remember, and probably it is still practice the crepe bandages and the stocking, but probably they are
No, it doesn't
something
work.
like a placebo effect, and we are satisfied that we have done something for the patient. Ultimately,
No,
that is
no,
how
no,
it
no.
works
It's
out.
in our ICU, at least we have a dedicated neuro IC,
Yes,
and
sir.
we do practice this pneumatic compressive sequential compression for all those who are going to be bedridden for next few days, at least in the ICU. And
Yes,
when
sir.
we discharge them, we instruct patients' relatives. If those who can afford, they really buy and continue the same device at home. Because that becomes cost effective compared to the pharmacological
Yes, sir.
therapy. And if those who can't afford, so we instruct them to have like pumping the calves intermittently, and those who can take care of the relatives. It
And I
really
think the
works.
cost has also come down significantly, sir. Somewhere, if I remember, in 2012, it was 1.5 to 2 lakhs, and now I think they are coming even between 50, 70 K. So it's probably more affordable, sir. Yes.
Right. Yeah, but it was a nice presentation.
Thank you, sir. So I take this opportunity to thank the respected chairpersons, the organizing team, Vivek Chakole, sir, and my seniors, my teachers who are there. Thank you very much.
Dheeraj, thank you very much. It was really nice presentation. We enjoyed a lot.
Thank you, sir.
Dr. More ma'am has any question to the speakers?
No,
Any
Dheeraj
other chats?
Dr. Dheeraj has been exhaustive about everything, and I'm
Yeah.
so glad he started with ABCD and ended with something that is really important, that is the venous prophylaxis.
Thank you, ma'am.
Hats off to you for a very good presentation. Very nice. Thank you very much.
Thank you, ma'am.
Thanks to
Thank
all
you,
the-
Mure madam.
Thank you.
Thank
I
you
would
very
like
much.
to take this opportunity to thank Dr. Vivek Chakole, Dr.
Yes.
Chandak ma'am, and entire organizing team for excellent and smooth conduction of CME. Thank you so much.
Thank you, Sandeep sir. This CME will help in our neuro ICU also. Neuro
Yeah.
OT and neuro ICU. Definitely it will help. Right, sir.
Thank you, Dr. Chakole, sir. Dr.
अरे
Shubhangi
मॅडम
Mole,
थँक्यू
madam.
व्हेरी
Dr.
मच
Sandeep
तुम्ही
Tigatwal,
एवढा
sir.
वेळ दिला थँक्यू थँक्यू
Nice, sir. Thank you very much, Dr. Bhandari, sir. It was an excellent presentation. I enjoyed listening to you.
Thank you, ma'am.
Thank you so much for inviting me on the prestigious dais of ISA Wardha and Jnmc Wardha. Thank you so much.
At the outset, I would like to congratulate Dr. Katikar ma'am and sir. Ma'am is, I think, ISA Maharashtra chapter president, and Dr. Katikar sir is the president-elect of Maharashtra. It's a Midwest chapter of Neurological Congress.
अरे वाह 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 मॅडम सही आहे
Yes, sir. He's followed my footsteps. असं म्हणूयात.
कॉंग्रॅच्युलेशन मॅडम
Congratulations, ma'am.
Thank you so much. Thank you. मोळे मॅडम नमस्कार. भेटते नागपूरला आले की.
भेटा जरूर या जरूर या
मॅडम मला तुम्ही असं अगदी जस्ट अनेस्थेशिया जॉईन केलेलं असताना बघितलं होतं. त्यानंतर आय थिंक आय एम मीटिंग यू आफ्टर अ लॉंग टाइम.
Yes, years and years.
Years and years, yes.
And I met ma'am
All the
just
best.
after finishing my neurosurgery training from Amrita.
Yes.
मी इंटर्नशिप संपल्याबरोबर मुळे मॅडमला जॉईन केलं होतं सिम्स मध्ये काहीच दिवस होतो
फिर भाग गए आप Then you ran away. I'm glad all of you have come to do a very good CME. Good. Keep up the good work. Thank you.
Thank you,
very much.
madam. Thank you.
Thank you so much, all the dignitaries. Thank you so much, ma'am, for the minute details that we learned today and all the practical aspects that we learned today, ma'am. Today, the CME has enlightened us with more of the knowledge, ma'am. And to conclude this CME, I would like our chairperson, Dr. Aruna Chandak, ma'am, to conclude this CME, to have some words.
Myself, Dr. Chandak, Chairman of CME. It is my great honor to conclude the CME, the great academic feast it was. It was power-packed, knowledge-enhancing from all great anesthetists from India. We all are empowered with knowledge. All speakers made us more aware and clear about the patient's management in coagulopathy state. very practical oriented, and made easy to understand from all eminent speaker. Thank you very much. Few words from my side. दिल की बात जुबा पर लाना, दिल की बात जुबा पर लाना दिलदारों का काम है। दिल की बात जुबा पर लाना दिलदारों का काम है। आप सभी का हमारे साथ होना दुग्ध शर्करा पान है। आप सभी का हमारे साथ होना दुग्ध शर्करा पान है। कहते हैं अच्छा काम करने अकेले ही निकलो, कहते हैं अच्छा काम करने अकेले ही निकलो, सहस्त्र हाथ जुड़ जाते हैं और कारवा बन जाता है। मेरा उन सहस्त्र हाथों को सलाम, मेरा उन सहस्त्र हाथों को सलाम। Thank you for your contribution in academic feast. Thank you very much, madam.
I think it was an excellent academic feast. Everyone has enjoyed clearing their concept about this topic, perioperative management of coagulopathies. On behalf of organizing team, it's my privilege to propose a vote of thanks on this occasion. I would like to thank our patrons, Honorable Shri Dattaji Meghe Chancellor and Dr. Ved Prakash Mishra, Pro-Chancellor, DMIMS, for providing us this platform for today's CME. I would like to thank members of boards of management for providing necessary infrastructural and financial requirements for conducting today's CME. I'd like to thank Chief Guest of today's CME, Dr. Murlidhar Joshi, for giving out his valuable time from his busy schedule. Thanks a lot, sir. Next, I would like to thank the torch bearer of this event, our respected head of the Department of Anesthesia, Dr. Vivek Chakule, sir, for leading and inspiring us in working towards the goal of conducting this CME and giving me the chance as an organizing secretary. I would like to thank our chairman, Dr. Chandak ma'am, and ISA Wardha City Branch President, Dr. Chandak sir, Secretary Dr. Verma ma'am, and GC member Ninabe ma'am. My heart fills with lots of gratitude and respect for our distinguished guest speaker, Dr. Divitiya sir, Dr. Manisha Katikar ma'am, Dr. Aruna Chandak ma'am, Dr. Javed Khan sir, Dr. Dheeraj Bhandari sir, Dr. Sheetal Dalal ma'am, Dr. Riya Balikar ma'am, Dr. Karuna Taksande ma'am, Dr. Samina Khatib ma'am, for not only sparing their invaluable time for us to grace this occasion, but also for enlightening us with their commendable talk on the subject. My heart goes out to thank our delegates for accepting our invitation, attending this online CME, and encouraging morale of the speakers by their gusto and enthusiasm. We are also grateful to the chairperson for sparing their valuable time for chairing today's session of CME, Dr. Nita Verma ma'am, Dr. Virendra Belekar sir, Dr. Murlidhar Joshi sir, Dr. Jayashree Sen ma'am, Dr. Nima Acharya ma'am, Dr. Anita Nehme ma'am, Dr. Sandeep Iratwa sir, Dr. Moe ma'am. And I would also like to thank observers, Dr. Prakash Mohite sir and Dr. Makaran Vevare sir, for taking out their valuable time for our CME. Conducting this CME would have been impossible without the zealous effort of our junior resident, Dr. Yatharth, Dr. Somya, Dr. Sambit, Dr. Kapil, Dr. Vidur, and rest junior residents who were always on their toes to help me out at any point of time. Above and beyond, let's not forget the backbone of the CME, our department and our colleagues, non-teaching staff members, Aarti Ambedkar, Lata Sorode, for carrying out their allotted work with full enthusiasm. Last but not the least, if someone is left by me unintentionally, so kindly accept my regards. With this, I would like to conclude my vote of thanks. Thank you.
Thank you all. I would like to thank Dr. Prakash Mohite sir and Dr. Makaranda Vevare sir, as they are MMC observer, for their kind contribution in this CME, and they have validated the CME. Right, sir. Thank you, madam. Thank you, everybody. It was around registration is around more than 400, and at a time more than 250 participant has been attended the CME. So it is a good number, right? Thank Thank you. Thank you all. Thank you very
Yeah,
much.
congratulations for successful CME, Dr. Chakole and team. Good.
And
Thank you, sir.
bye-bye.
Thank you. Thank you very much.
So
Thank you
allow
very
us to
much.
leave, please.
Good.
Thank you.